of the Lifestyle Medicine Conference. My name is Abdelmajid Al-Mouka, and joining me on stage are Hanan Al-Hindi and Abdullah Al-Ghassab. We are truly glad to see you all back again with the same enthusiasm you've carried over the past 2 days. Over the previous sessions, we've explored how lifestyle medicine reshapes education, strengthens communities, and supports long-term health and well-being. And today, we continue that journey, a day rich with ideas, evidence, practical strategies, and speakers who will take us deeper into the science of a healthier living. Between sessions, remember to enjoy the activities prepared for you. Join the open dialogue tables, experience the walking stations, and make the most of every moment. Now, we begin our first session. Join me in the honor to introduce today's first moderator, Dr. Mishari Al-Jam'ani, Executive Director of the Saudi Model of Care, Family Medicine Consultant, Trainer at the Family Medicine Academy, and Consultant at the Health Insurance Authority. Please welcome him.
Good morning, ladies and gentlemen. And I have honor to be with you today, especially with big names to this first session. Before we starting, I should to mention that we have 6 barcodes for each session, and we have one for evaluation and one for the question. The first lecture we have with us Professor Fahad Ashibani, and the topics we talk about the beyond medication, how lifestyle shape outcomes in GI and hepatology. Dr. Ashibani is accomplished academic and consultant gastroenterologist and hepatologist with over 25 years of experience in advanced therapeutic endoscopy, hepatology, and medical education. He currently serves as a professor of medicine at Al Faisal University and consultant hepatologist, gastroenterologist at King Faisal Specialized Hospital in Riyadh. Welcome, Dr. Fahad.
Assalamu alaikum, sabah al khair, good morning everyone. And really thank you for the organizing committee for the invitation to speak in this outstanding conference on lifestyle in Hail International Conference. When the organizing committee talked to me a few weeks ago to present about lifestyle in gastroenterology and hepatology, something related to that, I said, well, I spent some time to think about it, because everything in gastroenterology and hepatology, in fact, is related to lifestyle, starting from the esophagus, to the stomach, to the bowel, then passing by the gallbladder, the liver, the pancreas. All these organs are actually related directly to lifestyle. And in the next 15 minutes, when they said, okay, you have 15 minutes, I was really questioning what I should cover really in this 15 minutes. I need actually more than that, but I have really to give you some examples on how lifestyle really modify and change beyond medications, the lifestyle. So this is the outline. I will just go through it quickly. So to overview lifestyle mechanisms influencing the GI hepatic physiologies, and discuss the modifiable risk factors, and also the role of obesity, in fact, which is very important part of my lecture to talk about obesity and its impact on the GI and hepatology. So let's go through the GI. GI has actually a lot of neurons. It is the second organs that has really rich of neurons compared like to CNS. CNS is number one, then followed by gastroenterology. And in fact, we have more than 70% of the immune cells reside in the GI because they're regulating the inflammation. And also we have what you call hypersensitivity of the viscera that will affect the function and also the GI motility. Now we ask what GI organs and hepatology organs or pancreatology organs or gallbladder doesn't like any other organ. Doesn't like a lot of stress, doesn't like certain foods, doesn't like smoking, alcohol, sedentary life, and lack of sleep. All this is common. But let's go through one by one examples. When I searched about obesity, I was really astonished that obesity is really, it's a pandemic worldwide. And there is a recent data that's showing that 1 out of 5 of Saudi population are obese, and 1 out of 2, they are overweight. Regardless if you go to the east or west part, southern or north part, we have actually obesity and or overweight. And this will affect the GI system from the esophagus, causing reflux, irritable bowel syndromes, fatty livers, and many others. So looking at the GI and liver complications, if we start, for example, by the liver, obesity directly actually causing what you call now fatty liver disease, and this might lead to liver cirrhosis and hepatocellular carcinoma. Looking at the bowel, it might affect actually the irritable bowel syndrome and even inflammatory bowel disease, like Crohn's disease and ulcerative colitis. There is actually a high prevalence in those who are obese, and also the resistance to treatment in obese patients. Pancreatic cancer, gallstones, and reflux also will be affected and have a negative impact by obesity. When we talk about gastroesophageal reflux, it is a condition in which develop the reflux of the stomach content, causing troublesome symptoms and or complications. In particular, it will cause heartburn or regurgitation. The prevalence of reflux, in fact, is increasing, and this is parallel to the obesity that's increasing worldwide. And this might lead to what you call Barrett esophagus and esophageal adenocarcinoma. And having excessive fat in the abdomen, what you call visceral obesity. This might lead to reflux and affect actually the sphincter of the lower esophageal part. And obesity also increases the estrogen, which has a negative impact on the relaxation of the sphincter, and also might progress to the Barrett esophagus and adenocarcinoma. Again, I like to search what is the prevalence of these conditions in my country. So I just put in Google, what's the prevalence of GERD worldwide? And it gave me actually a rough estimate of 14% worldwide. People, they have reflux symptoms. But I was really shocked when I said, well, Saudi Arabia is number one having GERD, which is around 45%. Then I looked to the data. Let me just go back and review, and it was actually published a few years ago. Saudi Arabia has more than 30% they have reflux. And I looked to a paper that was published by one of my colleagues, Dr. Majid Al-Madi, and in fact, he distributed medical students into 4 shopping malls in Riyadh a few years ago. And they just get questionnaire, and they found actually 45% they do have actually reflux symptoms based on the questionnaire. This, of course, that was not confirmed by endoscopy or by pH study. So we know now that GERD risk factor, one of them is the obesity, other factors like smoking, low physical activities, and others including like smoking. And so moving to okay, I think I see the slide here. Okay, moving also to the sleep. So having good sleep, actually, it will reduce the GERD severity. So always we emphasize sleeping early, enough time, it will reduce the symptoms of reflux. And there is several meta-analyses that show positive association between BMI and GERD, and central obesity is independent risk factor for the consequence of GERD, including Barrett esophagus. So how lifestyle now modify? If the patient come to my clinic and ask me, doctor, well, you are saying a lot, so how can I help myself by reducing the symptoms? Patients now are worried about side effects of medications like proton pump inhibitors, causing dementia, osteoporosis, which is not fact. So if you don't need this one, if you don't need this headache, let's go through the lifestyle modifications. And in fact, just doing lifestyle modification, it will have a positive impact up to 40%. This will include the weight reduction, and this will have a positive impact on the reflux symptoms, avoiding late meals. In addition to that, we advise to avoid triggering foods and no shoes fit all. So every patient has really specific food. We give them a list of type of food and we'll say, well, look at this food. Some of them might trigger your symptoms. Some of them might be suitable for you and you decide about it. Other factors like, for example, smoking and alcohol, this is always should be discouraged for all patients with reflux because it have an impact on the lower esophageal sphincter relaxation. So this is the summary about lifestyle modifications that we always advocate the patient to try and do it. The second really important disease that I would like to discuss is the fatty liver disease, which is, again, it is a pandemic and it is the silent killer now for many patients. And NAFLD, they call it non-alcoholic fatty liver disease, and NASH, which is non-alcoholic steatohepatitis, now has been changed to MASLD and MASH. And the single most important factor is actually the overweight and obesity. And 90% of individuals with BMI more than 35, they do have hepatic steatosis. And losing weight up to 10% will reverse the steatosis and improve the inflammation. So those who have a normal liver, once they get really overweight and obese, there is a risk of 35% having a fatty liver disease, but only small percentage of them, like 10 to 15%, will progress to inflammation and cirrhosis, then hepatocellular carcinoma. However, given high prevalence of obesity and fatty liver disease, given this small percentage, still it will be counted as high numbers in the future. The pool prevalence worldwide is 30%, including the MENA region, which is the Middle East and North Africa, and the global rates of MASLD is increasing worldwide. So we have to agree that MASLD is really parallel to the obesity, diabetes, and dyslipidemia, as is shown in the graph. In fact, in the States, including now actually Saudi Arabia, number one indication for liver transplantation, in fact, is fatty liver disease. It is now beyond the alcoholic, beyond the hepatitis B and hepatitis C and autoimmune. This is a nice study that was published recently by our colleague, Dr. Khalid Aswad. In 2017, the MASLD prevalence was 25%. They are just estimating the projection and overcasting the next few years. In 2030, up to 48%, they will have MASLD. And in fact, this will reflect on cirrhosis and hepatocellular carcinoma. So lifestyle, we'll go back. What you advise the patient? They come to you to the clinic, first question, what can I do? Well, you have always to adhere to lifestyle modifications from exercise, even if you didn't lose weight, it will help actually the fatty liver. So we need energy deficit, we need good regular exercise as defined by WHO, 150 to 300 minutes walk, moderate activity, avoiding sugars, sweeteners, and fructose. Patients think, well, I'm not eating fat. I'm not eating greasy food or fatty meals. This is not enough. The fructose by itself will change in the liver to like a fat. So you have to avoid. Of course, stopping the alcohol and Mediterranean diet. There's a good evidence that if you eat Mediterranean diet, rich of really fish and olive oil, it will help. So weight loss, if you lose more than 3%, it will help in reversing the steatosis. If you lose more than 10% of your weight, over time, it will actually reverse the fibrosis. So number one is diet. Number two, exercise. And each clinic visit, we have to stress on the patient, what have you done over the past 3 weeks or 3 months? How can I help you on that? So to avoid the drugs, sleeve surgery, and bariatric surgery, try to stress in the first lifestyle modifications, which is diet and exercise. And response actually goes very good with weight loss. NAFLD will improve with weight loss. And usually we encourage it to be done over like a period of time, not acutely. Factors affecting Mediterranean diet or always is encouraged. We tell the patient with Mediterranean diet is really healthy food. Try to use it and apply it in your daily life. Exercise is important, effect on the liver fat. It has a positive impact. I think the coffee is really encouraged nowadays, especially the black coffee. It has really a positive impact on the liver. There is a 3 meta-analysis, all of them actually retrospective observation studies. We do still need prospective studies, but at least drinking 3 cups of black coffee per day, it will help the fibrosis, it will help fatty liver, and prevent liver cancer. Moving to the third topic after GERD and fatty liver are the colonic polyps. And as you know, colonic polyps can be hereditary from your genes, which cannot modify by ourselves. And the other one, in fact, is the sporadic, which is more common. And the sporadic, either we have hyperplastic polyps, serrated, and the adenomatous, but the adenomatous and serrated are the one who will cause colon cancer. And in fact, due to insulin growth factor in obesity, it hyperstimulates the colonic mucosa to cause more polyps. So obese patients are more prone to develop adenomatous polyp that might yield to adenocarcinoma. So risk of colon cancer and exercise, it is a negative. So once you exercise, the impact on the colon cancer is in fact positive. One more thing is the pancreatitis. Those who are obese, risk of pancreatitis is more, getting more gallstones. And in fact, even post-ERCP, when we do an ERCP, there is a risk of 5 to 10% post-ERCP pancreatitis. When I get a patient with post-ERCP pancreatitis and he or she is obese, always, I don't sleep that night because I know the risk of complication in that patient in particular is high compared to non-obese patients. Motility disorders like GI motility, gastroparesis, constipations, incontinence are more, in fact, with patients who are obese compared to non-obese. Obesity also increases gallstones, high cholesterol, saturation in the bile, impair the gallbladder motility, and also rapid weight loss might actually have a negative impact that will cause rapid development of the gallstones. So always we advise for and advertise for healthy diet. Have a positive impact on the reflux, on fatty liver, gallbladder, polyps, and other organs. One of the most really common conditions that we are seeing in daily life, especially in the community, is irritable bowel syndrome, and we are always advising for the FODMAP diet. And as you can see, the response to the IBS with the FODMAP is actually comparing to those who are not taking FODMAP. Now, the last few slides is the risk of obesity and cancer. Obesity has a direct impact on cancers of the pancreas, of the colon, esophagus, stomach, as well as the liver, directly or in indirect way. So as you can see here, all the cancers in the GI tract are actually increased in obese patients compared to non-obese patients. Now, last slide. When the patients come to me, to the clinic, and they are worried about surgeries, medications, why I should take this one or that one, I say, well, you have a lifestyle or you want medications or surgery. Just look at these numbers. For fatty liver disease, just doing a lifestyle up to 80% you can improve, while medications give you only 20 to 30%. GERD, 40% will improve. Of course, many patients will end up by getting some medications. But if you want to minimize the medication dose and the duration, go with lifestyle. IBS, IBD, name it, functional dyspepsia, always there is a positive impact on adherence to lifestyle modifications, in particular diet, exercise, stopping smoking and alcohol. Thank you so much. And again, thank you for the committee for inviting me to the conference.
Thank you, Professor Fahad, for this nice topic and interesting for this. The second lecture, we have Dr. Abdurrahman Al-Rajhi. Dr. Abdurrahman Al-Rajhi is a medical doctor with a Master of Public Health and fellow the Infection Disease Society of America and fellow of the American College of Physicians and fellow in the Royal College of Physicians in Denver. The talk, the vaccines and healthy aging. Welcome with me, Dr. Abdurrahman Rajhi.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman. Bismillah, walhamdulillah, wa salatu wa salam ala Muhammad Rasulullah. I'm really honored and pleased to be part of this great activity. When I initially thought what infections are related to lifestyle, I actually had to think of something related to living. And as one of the themes of this conference is Live 80, I thought it's a good point to see how vaccines would actually make longevity better and get you a healthy aging at that stage. These are my disclosures, and here is the outline. We'll basically talk about infections and the humans, and then how they are affecting cancers. So unfortunately, you will hear more about cancers this morning, the vaccines, and then living longer and healthier, which is the aim of everyone, and then any future in terms of vaccines for us. If you look at how people die globally, this is the distribution of the main reason for death. And you could see that 3 out of 4 humans would die from non-communicable diseases. And 1 out of 7 will die from communicable diseases. And if you look at things like pneumonia, tuberculosis, the really significant part of people still die from these conditions. And infections are actually preventable, and the best way to avoid them is to get the vaccines if we can develop vaccines against them. Now, the previous chart was for before 2019, and what happened in 2019, all of us remember that, the COVID. After COVID, still infections are really significant, and you could see the impact of COVID even by this day and age. It's still affecting millions of people and a major part of or cause of death in humans. Looking deeper into how people actually die in different societies, because in low-income countries it's different than high-income countries, and you could see that in low-income countries the majority of people die from communicable diseases. If you go to middle and low-income countries, chronic diseases are getting more frequent. However, still things like tuberculosis and HIV are really main concern in these regions. If you go to high-income countries, then majority of it is actually related to ischemic heart disease and strokes, but you could still see many of the infections like pneumonias and complications of these conditions is important. And for anyone who works in hospitals and deals with patients in their last few days of life, you could see that many of these conditions are actually tipped over to death because of a concurrent infection, whether it's acquired in the community or in hospitals. And trying to see what people die from and what age they die in terms of infections, you could see that in high-income countries, almost 70% of people would die after they live for 70 years or longer. And for kids, it's only 1%. But when you go to low-income countries, unfortunately, the majority of people would die younger than 70. And what is really more hurting is that 4% of all kids would die before they complete 15 years or 15 birthdays. And considering the numbers of children in low-income countries, the numbers are really very high in children dying from preventable conditions. Going deeper into the causes of infections that actually are causing death, the master of all infections causing death is beyond competition is tuberculosis, and second to it is smallpox. And unfortunately, smallpox has been eliminated, and all these deaths are now non-existing since we have a very effective vaccine and practically eradicated smallpox from human diseases. And the rest of conditions, many of them actually have either do have a vaccine or they will have a potential vaccine in the near future. Trying to see how people, humans lived and their expectancy over the years, I picked up this graph for 5 sub-Saharan countries where survival and life expectancy has been improving over the last 30 years until 1985. And since then, it started dropping. Any thoughts why would that happen? What happened in 1985? It's AIDS. It doesn't show here, but actually these countries, it's below, these countries are having more than 10% of HIV prevalence, and this is just a model of how a single infection or a single agent can actually impact the community's life expectancy. And we have seen that also more recently with COVID in certain countries. So what is the impact of infections on humans? They actually can kill directly. They can kill indirectly, as we said, and people with chronic conditions are tipped over by concurrent infection. They cause cancers, and we'll go through these. And also they cause severe disability. And looking at agents causing cancers, there are several pathogens that actually can cause cancers. Whether the majority of them are viruses, but you could still have parasites, you could still have bacteria. And we'll see in a minute how what proportion of cancers are actually caused by these infections. For example, if you look at a single virus, which is the human papilloma virus, and that can cause cancers in so many organs, including the cervix, the mouth, and the other oropharynx and other genital areas. And almost 5% of all cancers are caused by this single virus in humans. And that's worldwide. Now, if you focus on developing countries, it's of course higher, and in developed countries, it's lower. And hopefully now we have a very effective vaccine, and that will significantly impact these types of cancers and deaths. Trying to look at a different virus, HIV and human herpes simplex virus, and you could see that, and again, they can cause Kaposi sarcoma and Hodgkin lymphomas, and they're really very significant contributor. I think at the end of the slide below, there is the rate of lymphomas in HIV patients, which is more than 160 times the general population. In fact, if you look at certain lymphomas, like immunoplastic lymphoma, it's almost exclusive in HIV patients, or more than 600 times higher in HIV patients. Now, looking at all cancers and trying to see what proportion of these are actually happening because of infections. And apparently, you could see in developed countries, it's almost 7%. But in developing countries, 1 out of 4 cancers is actually caused by an infectious agent, and the majority of these are actually preventable, whether it's hepatitis B virus infection that, again, has a very effective vaccine for it. And the total, as we said, is almost 26%. Moving to disabilities, if the infection does not kill you and does not cause cancer, it will significantly cause a disability. And these are the rates of disabilities from certain infections. And you could see something that we really have very low consideration for is influenza. And you could see how many lives lost for influenza and disabilities from different types of viruses or infections. And looking at specifically our areas, or looking at regions, because the previous slide was from European countries, and you could argue that these have different rates of infections, which is true. But here are the groups of causes of deaths, including infections and chronic non-communicable diseases and injuries. And if you focus on the Middle East, which is our region in the middle, I don't think that pointer works, but it will come here. These are the sub-Saharan Africa's almost 60% of disability-adjusted life years are related to infections, while in our region in the Middle East, it's almost 16% of all disabilities are caused by infections, and these are, of course, preventable, and hopefully by vaccines. So what are vaccines? These are biologic agents that are prepared to improve immunity to a particular disease. So they're not really therapeutic. They actually do trigger the body's immune system to defend against specific pathogens. And they have been used for quite some time by humans. I mean, there are evidence that thousands of years peoples in the Middle East and maybe in China have used certain techniques to prevent infections by inducing infection in young kids, specifically in leishmania, for example, and other pathogens. So the question that this presentation tried to answer is, do vaccines actually improve health and do they increase longevity? What do you think? Can I see hands? Who says yes? Yeah, maybe 10%, 15%. Hopefully we can convince the rest that they actually do. So this is a report of WHO, actually citing 1 year benefit from vaccines from the expanded program of immunization, which is mainly dedicated for kids. And in 1 year, it's estimated that it averted 4.4 deaths, specifically related to the expanded program of immunization in children. This is a very, very interesting classical graph. Interestingly, in Copenhagen, since 1750 until 1850 and maybe beyond, they were keeping records of who dies and who's born and what is the cause of death in these people. And at that time, smallpox was a major problem in Copenhagen. And you could see, I really don't have a pointer here, I don't think it works. You could see that the crude birth rate was actually fairly stable for some time. And then it dropped, of course, with the development and urbanization. But also you could see that the death from smallpox on the left side lower graph has been significant before they started vaccinating compulsory in 1810. After they started vaccinating in 1810, almost, or actually it went down to zero, as in all countries now. And in spite of birth rates getting less, the natural population increase was actually more by significant factor, not only related to smallpox vaccine, of course, because other things were developing during that time. But I think the most important thing is that death from smallpox in this community went down to zero over 100 years. You could still argue that these data are old and they may not really be reflecting what's happening in current years. This is a most comprehensive review, and it came only last year, looking at the impact of the expanded program of immunization on health and lives or deaths averted in the global aspect over 50 years. And you could see here that, for example, for measles, there are millions of years gained from the vaccination, and total over 50 years, more than 154 million deaths averted. The life years gained and the life full of health gained were in the billions. That's over 50 years from these vaccines. There is really no doubt that vaccines will actually improve the health and have a better survival for humans. And looking at this again, looking from even before Christ, alayhi salam, you could see that humans were living expectancy around 30 years. There are other several factors, of course, but you could see that the smallpox was the initial most important vaccine introduced and improved survival, with other, of course, socioeconomics and health and hygiene impacting survival. And still, vaccines are really significant in that part. And these are just a few examples of vaccines doing that gain. There was another graph behind this, but I think the system is not showing it. It's actually was supposed to show that the International Longevity Center plotting the index of longevity or healthy life in communities, countries, and the acceptance of influenza vaccine. And in that graph, it's actually beneath this picture. In that graph, the more population accept the influenza vaccine, the better longevity they have, and the higher rank of longevity in the index. And this is our country from that graph. You could see that For example, in the lifespan, we have now 77.9, as this conference aims to 80, hopefully we'll get it. However, our metric rankings is 42 out of 153 countries. And the lower the number is the better. And if you go down, for example, in things like happiness, alhamdulillah, we are in a good score of 14. However, but you look at environment and other things, we really have lots of activities and lots of effort and work to do to improve our systems. Another example on how expenditure on vaccination will actually impact the ranking. This is the same system of International Longevity Center, ranking countries from 1 to 10 and so on. So the lower is better. And the more countries are spending on immunization, the better ranking they have and the better life months gained in these countries. So it's a very direct relationship between expenditure and longevity. Now, finally, these are the most recent vaccines that are given to adults. And these are the 3 main respiratory viruses that are actually significantly causing disease and mortality. And people are arguing whether this is still has an impact on health and longevity. This was a recent study came out last month, actually. And you could see that, I'm afraid it will not show because these are slides heading behind. So you could see that the vaccine effectiveness, for example, for corona, is actually 40% or 37% protecting it from admissions to hospitals and all the complications related to it. You look at RSV, for example, it's 79%, and for influenza, it's up to 42% reduction in the admission in people who received the vaccine compared to the non-vaccinated communities. This is the graph from WHO, the table most recently for the expanded program for children. And our country, alhamdulillah, is one of the leadings in terms of acceptance and rates of vaccinations. And the Ministry of Health is really leading a great job in doing this and making it electronic. And you could see it in your kids, in your mobile devices, and so on. And finally, these are the adults vaccination schedules. And I think very important for all of us, especially people who have chronic illnesses or heart diseases or are more than 50, which is none of the audience here, alhamdulillah, Allah yatawwal a'mar al-jami'. Then there are certain vaccines for them that will really improve outcome. We have also the Majlis Daman al-Sahhi, the Council for Health Insurance, had a huge document on adult vaccinations and has extreme details on whom to vaccine, what to vaccine, and how to use it. So the structure and the guidelines are available. It's only part of our community to accept this and health practitioners to adopt this in their healthcare centers. So the future vaccines are going to be better, administered differently. We have more diseases, and hopefully we'll have non-pathogen related diseases. And one of the earliest ones that actually have a vaccine for is Alzheimer's. So you have a vaccine to protect you from Alzheimer's disease, and work is really tremendous on this. I picked up one example, which is again my main interest in tuberculosis, and you could see that the work on these vaccinations are quite tremendous. More than 9 potential vaccine candidates are under development for stage 3 or phase 3 and phase 2. With that, I end, and thank you very much for your attention.
Thank you, Dr. Abdurrahman. And the third talk we have with Dr. Muhab Jamaluddin. Dr. Muhab is a public health registrar physician and a research assistant with the WHO Collaborating Center. He leads the public health administration at Ad-Dir'iyya Hospital, Riyadh Health Cluster, and holds MBH from Imperial College of London. Welcome with me, Dr. Muhab.
السلام عليكم. Good morning, everyone. This is Dr. Muhab. I'm a physician by background and holding a public health degree from Imperial College. Also a WHO member in Imperial College, as well as that I'm a head of public health administration at the Al Hospital Riyadh Third Health Cluster. I'm really proud of presenting in this wonderful conference side by side by wonderful speakers, and really thankful for all the committees of organizing such a wonderful conference. Actually, my focus today is simple. We want to add healthy years, not just more years. I will share a practical plan or a proposal that you can start in one clinic with one team and one group of people. So let me start. Why now? Under Saudi Vision 2030, the target is to raise the life expectancy to 8 years. For me, the real win is the health span. Living those years in good health years is the challenge. For those who attended Dr. Abdullah Asiri talk in the first day, actually he noted that Saudi Arabia has reached almost 65 years of healthy years with no diseases. And this is the latest study estimate that estimated in 2021, which leave a gap of a 14-year for what we reach in 79 years in 2025. To move from words and theories to action, we keep it tight. And let's say we keep it tight with one clinic and one group with 90 days, and only 3 or 4 measures can people follow and can people feel in real life. 90 days is long enough to see the true change to things like blood pressure, physical activity, and patient engagement, but it also short for to keep the team's energy high and to repeat the cycle quickly. Now, why does this matter? The global trend is worrying, actually. About 31% of adults worldwide are not active. And the trend has gotten worse than the last estimate in 2010. Inactivity pushes the chronic diseases and harms the mental health also and the quality of life. The answer is not complicated. Simple daily action with support from healthcare teams and the system, of course, can shift the results faster than we think. I would like to show you a video that really shows you how inactivity impacted our life and shows you how our everyday life changed from the 90s until 2025.
To the 90s. We just explored. No one knew where we were. I heard in 2025 they have a tracker on your phone. That's no fun.
Welcome back to the 90s. We had to actually record it. No filters, no edits. It was what it was.
I heard in 2025 you just make fake videos with a phone. That's not real.
Welcome back to the 90s. This was our clubhouse, our whole world. I heard in 2025 you just put on a headset to play. That's no fun.
Welcome back to the 90s. We just skate for hours. No plan, no parents calling us.
I heard in 2025 you have to schedule everything. That sounds so boring. Welcome back to the 90s. We had to actually come to a store and pick just one movie for the weekend. I heard in 2025 you can just watch anything, anytime. That feels like a whole experience is missing.
Hey, future ya. Bet you miss rewinding a VHS tape. What's it like not having to wait for your favorite song on the radio?
Welcome to the 90s. We just sat in the car and talked for hours. Nothing else to do.
I heard in 2025 everyone has their own screen, even when they're together. That feels so lonely.
If I gave you a time machine, would you come back?
So this question also could be raised in Saudi Arabia as well, as also life is changing since the 90s. So the good news is that Saudi Arabia already built a strong and fixed support for this. We removed trans fats from foods. We added taxes on sugary and energy drinks. And we put calories numbers on menus. That's also a big changing. And we have the Siha virtual hospital at a national scale, which really dramatically changed the access to healthcare. With this space, it's really easier and safer to grow the lifestyle medicine. And the setting is perfect for the 90 days that I'm proposing. So how do we run this? We run this in real life by proposing a plan that we focus on 4 things. First is the data that I'm proposing, simple list of people at risk, and a simple weekly registry chart so we can see the change over time. Second is the teams, a short daily brief about 5 to 7 minutes, and a 15-minute weekly review meeting with the clear owners and fast problem solving. Third is the environment, which is the most important. Simple in-clinic reminders and community partners that fit daily life. Fourth is the measures that matters. We picked 3 or 4 KPIs, like the percent of people who reach safe blood pressure, or the drop of A1C if we track diabetes, and weekly minutes of activity as well as the no-show rate could be a KPI. Just to be clear, when we choose the group of people to work with, we can pick stable patients with uncontrolled high blood pressure, with readings of 140 over 90 of 2 visits, or 160 over 100 of a 1 visit, without warning signs. Or we can easily track what we call so let's say we track we don't track the emergencies. We only track the people to pick a preventive group of adults who are not active and who have some risk. To mention, we do not include emergency, as I said, but we can establish fast lane for them if we suspect a blood pressure crisis or any emergencies. If there is, for example, strong chest pain or any urgent issues, and our 90 days program is, as I said, is for stable patients. We use it in the proposal like in a 6-pillar coaching plan with a micro habit people can keep and learn from. Now, to make this matches Saudi model of care, the flow is simple. We screen, we stratify and sort people by risk, and we give targeted care to those people. As well as we connect primary care, virtual follow-ups, and community programs. This also supports the health sector transformation program goals, which are better access, better quality, efficiency, and stronger prevention. While the whole team uses the same simple steps, the same few measures and KPIs, and the same feedback cycle. Next, we adopt the plan to daily life in Saudi Arabia, we choose the right time, the right place, the right partners as well, and the right message, of course. As our weather is hot in summer in Saudi Arabia, maybe we could propose indoor working well with our environment. Also, partners should be and can be useful with Sport for All Federation, NGOs, schools, and workplaces. And of course, messages should be short and friendly to those people to help people do the behavior that we are proposing. Every week, we track many people to join and how many minutes they move and how the habits improve through the plan. Digital tools and AI can help, but only when we trust them. Of course, we have to keep things clear and safe. Every suggestion says why, how sure it is, and when it was last updated. If healthcare or healthcare provider disagree on something or on the AI digital tools, she or he can override it with a short note, so the system can learn and we get fewer useless alerts. We try it in quietly mode first, as a test mode, and then compare it with a real decision in real practice. Then we use it in live with a quick second check, and a simple record could follow it up. This two-way trust, clinician involved and trial that learns, brings real adoption and practice both sides.
1 minute.
Let me close with the 90 day that I'm proposing week by week. In week 0 to 2, we choose the clinic and the group, and also we set a baseline and we agree on 3-4 measures, as I said earlier. A clear set of steps in the clinic to start with from week 0 to 2. To week 3 to 4, we run the pathway, we do the daily briefs and the weekly team review meeting, and we rapidly remove and fix any blockers that we face. In week 5 to 8, we adapt our coaching to the needs that we have, and also adapt our referral as emergency may be faced during this plan, as well as we add small community partners, as I said earlier, and we publish simple weekly chart. In week 9 to 12, lastly, we show before and after. We share quick wins, and I'm about to finish. And we plan to how to scale this up and to put it in a wider group. In summary, here is a call to action. Our aim is to add a healthy years, as I mentioned earlier, not only years. We do not just add years, we add good years without chronic diseases or diseases in general. We start small and fast, one clinic, one group, 90 days, and we keep data and AI clear and trusted, as well as we build partnership with primary care, community, and workplaces. Then we share results, and after that, we possibly scale it up if it works, possibly to larger scale. Thank you very much. This is my presentation. I really thank you for your attention.
Thank you, Dr. Mohab, Dr. Abdurrahman, Dr. Fahad, in the stage. And again, for our audience, we have the barcodes for the question and evaluation. and welcome with me our doctors. Okay, thank you. We will starting our session by the ending of this most interesting lectures, starting by question one with Dr. Fahad. How the parent can do to encourage their children to avoid the bad nutrition habits?
Excellent question. Role model is really important. If someone really parents are not really doing the right things, eating the junk food, not exercising, they are overweight, they are smoking, of course, role modeling, al-qudwa al-hasana is very important. You cannot really encourage anyone, either a patient sometimes. You know that you are a doctor who's smoking and you are not following lifestyle things, and you are advising the patient to do this and that. You will say, well, that's good, but probably you should maybe start. And this happened actually to one of my colleagues. He was talking to one of the patients. He is a cardiologist, and said, do this and that. And he know that he's a smoker. And he said, well, probably you need to advise yourself first. And again, in the family, when you have kids, we should be a role model for them. We should not smoke, eat from homemade food, do exercise, a small gym in the house or a small swimming pool, or do walking together. So I think very important is always to encourage. It is easy to be said than practiced and to be done, but I think it can be achieved with really emphasizing why I want you to do this and that, not because I want to cut this junk food or fast food. No, this will have a negative impact, not now, after a year or 2 or 5 or 10 years. And you cannot really able to, cut it off later on. So either to be done early and to be persistent. If you do it, not just a matter of a day or 2 or a month or 2, it has to be persistent. It has to be always on the day, and we have to always to encourage the family to do all the lifestyle things.
Thank you, Dr. Fahad. You mean do it again to be habit for our children. That's you mentioned. Yes. The second question for Dr. Abdurrahman: do vaccines safe for kids? Safe for kids?
The quick answer is yes. I think the benefit from vaccination at a community level far outweighs the risks to individuals. And we know certain people are actually very skeptical about vaccines for children and accusing ADH and so on. I really think that these are just propagandas from the anti-vax groups. Millions of lives are saved by the vaccines, and we have seen tremendous outbreaks in college campuses for young college students who missed the vaccines, or the vaccines were ineffective in them, and with all the complications of measles that you could think of. Some of them are really very disastrous in terms of mental complications and so on. There are side effects, of course. Many of them are actually very limited to sites and fever and so on. But in general, I think one of the most effective interventions that humans have developed to improve survival and health is the vaccination.
Thank you, Doctor. Dr. Fahad, we have a question for: can we use the PPI chronically?
The quick answer is yes, if needed. If needed, PPI considered to be safe. There is in fact, they're medicine at the end. I try to minimize the dose, to minimize the duration, but if you need it, you cannot well say, well, I don't want to take it because I have a severe heartburn that might lead to erosions, peptic structure, Barrett esophagus, and cancer. But you said, I don't want to take it because risk of PPI, I have heard in social media, it causes Alzheimer or cardiac or osteoporosis or fractures or others, or vitamins or iron deficiency. If you need it, yes, but always you have to follow the doctors. Always ask your doctor, do I need to continue or can I minimize the dose? And if you don't need it, of course, don't take it.
Thank you, Dr. Fahad. By this question, we finish our session of the time. Thank you, everyone, and with my colleague, Dr. Abdel Majid.
At this time, we warmly invite our distinguished speakers and session moderator to stay on stage to be acknowledged for their valuable contributions. Do not forget to scan the QR code. Use it to share your questions with your speakers. Fill out the lecture evaluation and pick just one open dialogue to join during every break. Thank you.
Hello again. I'm Hanan Al-Hindi, and I'm delighted to be with you, me and my colleague Abdul Al-Ghassab, in the third day of Higher International Lifestyle Medicine Conference. We started the day in the gut, the liver, and the immune system. Basically, all organs that complain first when our lifestyle goes off track.
And now, we're going one layer deeper into how our habits can switch our genes on and off.
If your DNA could leave you a sticky note this morning, would it say, keep going, or please change the plan?
To take us into this fascinating world of epigenetics and health innovations, please welcome our moderator, Dr. Yasmin Asgheh, consultant of internal medicine / oncology, supervisor of the oncology specialty at حائل Health Cluster. Please welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Today, inshallah, we will discuss the interesting topic of epigenetic and health innovation. Starting off this journey with Dr. Ahmed Al-Malak. He is a consultant endodontist and head of infection control at حائل Dental Center, حائل Health Cluster, Saudi Arabia. He serves as a supervisor of the National Infection Control Development Program and educator in the National OptiDent project, leading nationwide initiatives to enhance dental infection prevention. So if you welcome me to Dr. Ahmed Al-Malak, going to present Innovating Health, How Digital Solution Redefine Infection Control and Wellness in Saudi Arabia. Welcome, Dr. Ahmed.
Hello. Good morning, everybody. First, I want to welcome you all in the حائل International Lifestyle Medicine Conference. People who are from outside حائل and from all around the world. I have the pleasure to meet many of the pioneers in lifestyle medicine. So I want to welcome you all today. And also I have to thank for the organizing committee also, and with our leader, Mr. Abdulrahman and Dr. Mishal for the nice organization. Today, we are going to talk about the role of digital solutions in lifestyle medicine and also in infection control. Regarding the lifestyle medicine, nowadays we have a lot of tools and technologies like specifically the artificial intelligence. So the artificial intelligence empowers the lifestyle medicine and also the infection control. So the Saudi Vision 2030 accelerates this transformation and support it. Today, I'm going to share some of the examples that they are in the final phases, inshallah, will be implemented in hospitals. And I will share the value of using the recent technologies in lifestyle medicine and also in infection control. So how the AI improves the accuracy, time, and cost. Recent studies, and I will provide if someone is interested to dive more in the studies regarding the role of AI in lifestyle medicine and in the medical field in general. I will provide him with the references. So recent studies showed that when they compare the humans with the artificial intelligence in the medical field, it shows that it gives us or reduce the human error significantly. So this is very important that we have to follow this change and use those technologies. Regarding the speed and efficiency, also studies showed that the AI and the automation of AI, it's doing complex calculations and accelerates the clinical decision-making processes. Before, the companies, when they plan to do applications or softwares, they have to do committee and a huge budget, and they have to prepare for a long time to create a simple software or application. But now we have with the recent tools, like the AI, maybe in a couple of days we can create an application. So we have to use this, and we are inshallah using those tools to implement it in the lifestyle medicine, infection control, and many of the medical fields. Also, the cost reduction. Since we have a high accuracy and we have a speed and efficiency, so we can detect the diseases and infections very early and with high accuracy. So we reduce the patient stay, okay? And also the operational cost will be reduced significantly. So this is a simple comparison. We have a lot of things to compare. but this is a simple comparison regarding the AI-powered infection control. The traditional approach, before we are doing in the infection control, we are doing manual auditing and documents and archives, and we have a lot of papers. We have a lot of time consumed. And as we all know that the time is money, and also the patient stay for a long time, this is also cost. So this is the traditional manual data collection, reactive response, delayed reporting, limited prediction. While the AI-enhanced approach, it provides us with automated monitoring, predictive outbreak prevention and detection, instant visualization, and proactive risk scoring. We are working in many applications now. This is which work as a proactive detection for infection control. Also, we are working in lifestyle medicine for proactive disease detection. We are working some applications to proactively detect any disease. This is one of the examples that we have created. This is the first application in the Middle East that involve all the 6 pillars of lifestyle medicine. It's Saudi-made, and it's interactive, and it's motivate the user to use or follow a healthy lifestyle. It works on motivating the patient. It's like a tree. It's growing while you are following a healthy lifestyle, and it will dry if you leave it. So this is, and send positive message. So it's also, we are working, this is in the last phases, inshallah. The feedback is very positive. So this is the goal of using the technology, to have a positive feedback and compliance of a healthy lifestyle. This is one of the platforms that, inshallah, we will be with Wiqaya. It will be distributed, inshallah, to hospitals all around the kingdom. It's work in the supply guard, called Supply Guard. It's AI powered, and it will help us to control and manage the chain of supply. As we all know, during the COVID-19 pandemic, we faced a lot of shortage in supply, and we have to control and manage and calculate the consumption of the supply and the PPE. So this model helped us a lot. We are doing a prototype, but we tested. We are in the phase of testing it in hospitals. The hospitals give us a very positive feedback. They said people, they want such applications which make it everything easy and accurate. So why not? The Saudi Vision 2030, the digital health transformation, the key national digital initiatives driving healthcare innovation. The national AI strategy. In Saudi Arabia, we have the SDAIA, which is the Saudi Data and Artificial Intelligence Authority, which support and do adoption for AI in all fields, not only medical field. So the Kingdom of Saudi Arabia is following this trend, and this is what we have to do, to follow the trend in technology. Also, the plan is for smart hospitals, telemedicine expansion. We already started with the telemedicine, but we need more to expand and improve. Also, unified EHR systems, digital infrastructure modernization. So what will be the impact? What is the impact on patients' outcome? all these percentages, like 35 reduction in errors, this is not, this is a huge reduction. So how about the speed or time? 50% faster diagnosis, 28 cost saving, 60% will increase the patient satisfaction. No delay, no errors, so you will increase the patient satisfaction. And this is another model in infection control. This is, inshallah, it will be international. We will share it with the WHO and CDC, inshallah, after finalization, final approval. This is called Surveil AI, or infection control calculator. It's working on focusing on surveillance. As we know, all the hospital-acquired infections are very critical. So we are leading now and trying to use the technology in such critical field. Regarding the lifestyle, the traditional monitors relies on self-reporting with inherent bias and limited accuracy. Subjective measures provide incomplete picture of patient health, while the digital monitoring, continuous data collection, provides objective measures and enables early detection. The AI identifies subtle changes and triggers timely intervention. So this is regarding the lifestyle. We have some challenges, but inshallah we need to create a very powerful tools, and we will face all the challenges, inshallah. But we have some of the challenges are data privacy, digital literacy, infrastructure reliability, system integration, and workflow optimization.
Dr. Ahmed, 1 minute, please.
So the future of digital lifestyle medicine, the convergence of AI, the predictive prevention, precision nutrition, virtual AI care team, and continuous optimization. So if anybody wants to plan to do a tool, we are now almost in most of the models in the training phase. So you need to do assessment. What do you need? Stakeholders engagement and pilot testing, then training programs, and finally continuous improvement. Key takeaways: technology empowers prevention. The AI enhances accuracy and cost effectiveness. Saudi Vision 2030 drives transformation. Collaboration ensures successful implementation. So just one last thing, AI will not replace humans, but people who are using AI will lead the future. Thank you so much.
Thank you so much, Dr. Ahmed. Such an excellent topic. And we have another good topic coming next. But first, I need to remind you about the questions. If you want to ask, use the QRS code or the dialogue sessions. Also can use the QRS code. Next, epigenetics in life. Maybe it's too broad of a topic to be discussed in 15 minutes. Good luck, Dr. Abdulaziz Al Athman. So our next presenter is Dr. Prof. Abdulaziz Al Athman. He is the president of the Saudi Society of Clinical Nutrition, president of the Saudi Parenteral and Internal Nutrition, professor and consultant of clinical nutrition, leader of the health advisor and clinical nutrition clinics in Sahha Virtual Hospital. You are most welcome, Dr. Abdulaziz.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. سعد الله صباحكم بالخير. السلام عليكم ورحمة الله وبركاته. My apology, I will just give some words in Arabic because I'd like to be sure that my message conveyed clearly to all people. We are talking about epigenetics. The question is, what is epigenetics? All of us, we have mobiles. And these mobiles have hardware, right? And it has also softwares and applications. Can you benefit from your mobile without these applications and programs and softwares? No. So they should work together, okay? As you like, your mobile, you can upload the applications. Some people will upload it with games, some people will upload it with, something related to health. So according to these applications, you will benefit from your mobile. And this is one point. The other point is, why do you like to eat chocolate? Why do you like to eat sweets? Do you have like sort of sweet addiction? Why kids they don't like vegetables and fruits? هو سؤال مهم. My message today is to you, not to anybody else. لماذا نحب الشوكولات؟ لماذا نحب الفاست فود؟ لماذا أطفالنا ما يحبوا السلطات والخضار والفواكه؟ Why they didn't like healthy foods? This is not your fault and not their fault. This is the background of epigenetics. So the hardware is the DNA, and the applications is the epigenetics, which is above the DNA. Means our lifestyle, healthy or non-healthy, will program our DNA and direct us to be healthy or non-healthy. So كلما كان عندك عادات صحية وغير صحية، بالذات في الأطفال less than 3 years, this will definitely affect the future of these kids. So my message to all parents, رسالتي لكل الوالدين، انتبهوا لأطفالكم اليوم. أنتم تعملون برمجة لأطفالكم في المستقبل. This chronic disease does not just come from the sky. ما نزلت علينا من السماء. This is because our unhealthy lifestyle, and we have to correct it from now. We can use, as Dr. Ahmed said, the AI or any technology, but we have to go back to our roots, to our natural food, that from our plants, our area. As you eat from حائل area, it's good, better for your health and from other foods. So, what do you mean? Do you mean that our food will affect our health? Yes, all of us know that. But there is something beyond this. This food, either healthy or non-healthy, will make a programming for your DNA and make your DNA ready, either to healthy, if you eat healthy or following healthy lifestyle, or unfortunately, if you get some diseases that if you're not following lifestyle, we are not just focusing on diet, but diet actually is affecting this, affecting the DNA and future of your health. What the mechanism is easy. There is something called methylation. The methyl group will connect to the DNA, and this methyl will switch off this DNA, not doing other proteins. يعني كأنها redirects the DNA to away. So try to direct your DNA to the right way for getting healthy. Then we have something called histone code. The histone code is the histone that shaping the DNA to be ready to manufacture the criteria or the causes of health or disease. A lot of studies, and Dr. Shaima, Dr. Nasreen will show you some of these studies how our diet affect our DNA and affect the future of this young generation. في الماضي احنا we have obesity, عندنا سمنة, عندنا شوي سكري, عندنا ضغط. But why do we have these different diseases? عندنا الآن تصلب اللويحي, توحد, أمراض كثيرة. From where we get this? We get this before 20 years, 30 years, because of our unhealthy lifestyle. So also, there is what we call nitrogenomics. Nitrogenomics means this DNA will affect our choice. Now, those used to تعودوا على الأغذية الصحية or 80%. يعني please don't follow dieting. No dieting, no intermittent fasting. Just make it easy to do your basic life. And the best hospital in the world, it's not in the Japan or Germany or Saudi or United States. The best hospital inside you. You need actually to program your body and your family to prevent these diseases by following moderate lifestyle. يعني لا تكون say I should be 100% everything dieting. No. The best direction from Allah said وكلوا واشربوا ولا تسرفوا. الرسول صلى الله عليه وسلم يقول ثلث لطعامه ثلث لشرابه ثلث لنفسه. This is what you need. So after you program your DNA for the healthy lifestyle, so don't worry. Even in future, you will not go to bad habits. But what about those kids, 1 or 2 years, they eat while they're watching their mobiles. They cannot eat without this habit or used to this fast food. I'm not talking about burger or shawarma. I'm talking about especially chips and this thing from the baqala, the market. This is the worst, highly processed food. This, unfortunately, definitely will take them to future, unhealthy future. Who's responsible about this? We. And you, me and you, all of us. So it's not part. It's not, just nutrients. Don't think about the nutrients. All of us said, what I should do to lose weight. You don't need any diet. You need to join this nutrition microbiome to have healthy microbiome. And also, epigenome means that you program yourself, your kids, to something good. Allah يعين أمعاءنا أو أعضاءنا. They were working all the day to correct. And despite of that, we go to bad habits. So the DNA all the time working, bringing these nutrients and trying to correct your mistakes. It will correct it 1 day, 3 days, but after that, it will stop and you will get disease. So we have RDA and RNI, means how much nutrients do you need every day. Now, no more of this, no more of RDA, no more of specific nutrients for all. Nothing fit for all. We have to go to something personalized nutrition. Do you know what is personalized nutrition? Means I have to have diet designed for you. I have to personalize my assessment, my diagnosis, and my intervention. I have to study you, and you sometimes know your genes to choose the right nutrition for you. So please, don't force your kids to eat something they don't like, because their DNA not programmed for that. Since they eat the balanced diet, that's all. So I have to go to this personalized nutrition, that nutrition or lifestyle designed for that specific person. All of us, we know the 6 pillars, and we have the 7th, which is exposure to the to the light, to sunlight and nature. Now, don't answer my question. Just think about it. How much? What's the percentage that do you think you follow the pillars of lifestyle? How much do you give? كم تعطي نفسك من 100? Don't answer the question. Just think about it. كم تعطي نفسك من 100 to follow lifestyle? Let us say who's doing 100%? Who's doing 90%? Who's doing 80%? Who's doing 70%? Who's doing 60%? To be honest, I am following 60-70%. I'm not from those people looking for perfect life. So we try to adjust our life. And sometimes we ask ourselves, why these kids, I see them in the street, here in Higher, they're smoking too much. Why do they smoking? I'm sure they know the benefit or difficulties or future or diseases or harm from this smoking. ليش بعض الشباب يدخنون؟ والبنات طبعا والبنات. هم يعلمون الخطر. But unfortunately, they programmed by social background. زي ما قال الدكتور فهد، الدكتور عبد الله، الدكتور فهد قال فعلا احنا لابد نصير قدوات. المعذرة دكتور، لابد نصير قدوات فعلا لأطفالنا.
Prof. Abdulaziz, you have 2 minutes.
Okay. Now it's not easy and not difficult. How can we program our DNA? How can be healthy? It is easy. It is, you just follow all type of healthy that's suitable for you and that's suitable for your kids individually. If you bring all of this, you will get good health. Sometimes there are people talking about Mediterranean diet or DASH diet or other diet. I think Hail diet or Saudi diet can be modified to be healthy. We should not, bring any diet from here or there. We should build it in our body. And we'd like actually to just summarize the lifestyle. It's not one step. It's not what I have to do or to learn now. I have to teach it to everybody. And we have to start with our parents, our kids, our family, to teach them that early good nutrition will lead them to future good health, and vice versa, unfortunately. This is my message, and thank you very much. Thank you, Dr.
Thank you so much, Prof. Abdulaziz. Very, very interesting topic. Let's go next to another good topic, epigenetic pathways linking lifestyle and life expectancy, a public health perspective. It's going to be presented by Dr. Shayma Mohammed Ibrahim Saeed. She is a full professor of public health and community medicine at Tanta University, Egypt, and currently serves in the Infection Disease Control Unit of Public Health Department, Hail Health Cluster, Saudi Arabia. She holds an MSc and MD degree in public health and completed the clinical scholar research training program at Harvard Medical School. Welcome, Dr. Shayma.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd thank the organizing committee and scientific committee for giving me such a great opportunity to participate in this great and huge, well-organized conference. I'm Dr. Shaima, Professor of Public Health, and I am now a consultant of public health at Infectious Disease Department, Ha'il Health Cluster. My talk today is titled Epigenetic Pathway Linking Lifestyle and Life Expectancy, a Public Health Perspective. In this talk, we will explore how our lifestyle choices such as diet, exercise, sleep, and so on interact with our genes to influence our life expectancy and health expectancy and life expectancy. I thank Dr. Abdelaziz for making my presentation easier by giving a review about epigenetics. I'll just review this basic facts shortly. First, as Dr. said, what is epigenetics? Epigenetics are heritable, reversible changes in gene activity without altering the DNA sequence. As Dr. Abdelaziz said, the epigenetics are the software controlling the hardware, which is our DNA in our genes. It responds to diet, exercise, sleep pattern, and environmental factors. There is many core mechanisms that affect the interaction between epigenetics and our lifestyle choices, such as methylation, histone modification, and non-coding DNAs. The first mechanism is which is methylation. It leads to switching our genes on and off, allowing sometimes our gene expression, more gene expression, and sometimes silencing some genes and stopping their work by adding methyl groups to a certain bases in the DNA sequence. Generally or naturally, the effect of aging on methyl of our DNA, it causes global hypomethylation, leading to decreasing of gene expression or silencing of some genes. Also, sometimes it may lead to site-specific hypermethylation, leading to more expression of certain genes. The lifestyle link between methylation and epigenetics, it leads to some nutrients may act as methyl donors, such as folate and vitamin B, which support healthy pattern of life, and some others are toxins. The other mechanism, or the second important mechanism, which is histone modification, there is some enzymes called sirtuins that affect the histone bases in the DNA sequence, may lead to either acetylation, which lead to opening of the chromatin and allowing gene expression, or deacetylation, which lead to closing and silencing of some genes. These sirtuins, which most important one is 6 and 12, are enzymes which are NAD dependent, and they are crucial for longevity. There is other less important mechanisms, such as chromatin remodeling, RNA modification, and the most common one, which is non-coding RNA, which causes fine-tuning of the gene activity. We have what is called epigenetic clocks. What are epigenetic clocks? They are biomarkers based on DNA methylation pattern that estimates our biological age. Every one of us has two types of ages. We have chronological age, which is calculated from years from birth. This is the ordinary one. And the biological age, which is the molecular level of age affecting our tissues and our organs, which is very important. This epigenetic clocks, they are biomarkers that measure this biological aging by assessing the degrees of methylation of our DNA. It is known that if the chronological age is similar to the biological age, it is well and good. But if there is a higher or acceleration of biological age than the chronological age, this carries a risk of numerous diseases, such as cancers, cardiovascular diseases, and so on. So these epidemiological clocks are measuring the degree of or the methylation pattern to assess the biological age of the individual. There are various generations of biological clocks or AB clocks. The first generation was just to measure the chronological age. It is just used in forensic detection of age and so on. The most commonly the most commonly one, which is the second generation that are used as a germ age clock, which measures the degree of methylation, so reflects the biological age of the individual. As we said, the more biological age, the more risk that is carried by the individual to encounter other diseases. The third generation, it acts can be used trans species. It is now used for studies across species, so it is called pan-mammalian epigenetic clocks. And now there is development of fourth generation, which is organ-specific or tissue-specific. It can reflect the pattern of methylation and the degree or the biological age of certain organs, such as the brain and so on. So it can be used in personalized medicine. So what is the interaction between epigenetics and our lifestyle? Some lifestyle pillars are protective, others are harmful, such as diet. It may be protective or may be harmful according to the type of diet. Protective diets leads to increasing in DNA methylation and leading to reduction of inflammation. Exercise is a gold standard, and it's caused histon acetylation, so leading to a decrease of insulin resistance and increasing of insulin sensitivity in our tissues. Other harmful practices, such as smoking, alcoholism, and toxins, leads to global hypomethylation, so increasing the biological age, carrying more risk for diseases. It leads to increase in morbidity and mortality. Also, stress leads to increase in our cortisol level, so cortisol-linked hypomethylation or methylation occur, leading to immune dysregulation. As mentioned by Dr. Abdelaziz, there are very close linking between our nutrients or our ways of nutrition and our epigenetics. So food is not just a fuel, but it signals our genes. Some foods are methyl donors, leading to increased methylation, such as folate and vitamin B12 and cholins. Other foods are by the second mechanism, such as sirtuins activators, such as polyphenols and omega-3s. The gold standard diet for epigenetic pattern, for better epigenetic pattern, is the Mediterranean diet. Also, some foods, such as processed foods, carry major risk because they cause hypomethylation, increasing in inflammation and disturbance in the methylation pattern. The effect of movement and circadian rhythm on our epigenetics or the epigenetic interaction. As we said, exercise is very important. It is act as a medicine, as physical activity remodels our DNA methylation and in fat and muscle cells. They reduce systemic inflammation. It was found that about 30 minutes per day slows measurable epigenetics, carries a measurable epigenetics pattern, and slows the accelerated pace of the biological aging. Also, restorative sleep is very important for our epigenetics. Poor sleep disturbs the epigenetic clocks, and it was found that about 7 to 8 hours is crucial from good quality sleep, not just any sleep, but the good quality sleep using the sleep hygiene. That it is critical for DNA repairs and metabolic regulation.
Dr. Shaima, 1 minute left.
There is important effects of environmental factors and social determinants of epigenetics. Pollution and social deprivation and so on can cause what's called epigenetic scars. Social inequality such as poverty, social deprivation, psychological stress accelerate the epigenetic aging. What is the public health interaction between epigenetics and public health? As a public health consultant, epigenetics helps explain the differences between population in their longevity. Public health strategies should incorporate epigenetic evidence, and we have to focus on the high-risk groups via risk stratification using such as epigenetic clocks for population research, using epigenetic biomarkers, and strengthening the policies that reduce environmental toxins and distress. For disease prevention, from risk prediction to prevention, we can use epigenetics, using epigenetic markers, because these biomarkers has a very important criteria that they appear before the clinical manifestations, so they can be used in screening for such diseases such as cardiovascular disease risk or cancer risk, and so on. So prevention become now in the molecular level, not just the behavioral level or behavioral modification. These are some important strategies for preventive health strategies: green spaces, food policy, clean air regulation, and molecular protection for all. Integration of lifestyle intervention such as nutrition, physical activity, stress prevention or production with epigenetic monitoring is mandatory. DNA-based risk stratification and estimation of the population epigenetic age and the prevention of biological age acceleration is crucial for public health interventions. Lastly, as we said, the biological aging can be used as a screening tool and can be used to assess the effectiveness of interventions and can be used for as a future screening potential tools. The future direction of epigenetics and public health, we have to combine both epigenetics and artificial intelligence in disease prediction and prevention. We can use the biological age monitoring in population programs. We have to design preventive lifestyle interventions, integrating biomarkers and into population studies. To summarize, epigenetics bridges behavioral, environmental, and biology. Healthy lifestyle slows biological aging. Public health extends lifespan and health span. There is a bimodal relationship between lifestyle, epigenome, and longevity. Lastly, the take-home message: your lifestyle writes your genetic story. Live healthy, age gracefully. Every habit matters. Small lifestyle changes lead to long-term benefits. Thank you.
Thank you so much, Doctora. Now we will jump ahead because we're late to the next presenter, Doctora Nisreen Al-Ahmadi, consultant in family medicine, Saudi Arabian Board, International Lifestyle Medicine Board certified. a trainer at the Family Medicine Saudi Board Medical Educator, Masters, International Breastfeeding Consultant, Smoking Cessation Trainer, ACLS and PLS Instructor, Advanced Coach, and Advanced EQ Assessor. And Dr. Nisreen was recently blessed with a special talent premium residency in Saudi Arabia. So we congratulate her for that. She is going to present, yes, give her a round of applause. She's going to present epigenetic and chronic diseases. Welcome, Dr. Nisreen.
السلام عليكم ورحمة الله وبركاته. كيف حالكم جميعا؟ يسعد صباحكم. Thank you so much for the organizing committee for inviting me for the third time in حائل conference. Each year, mashallah, we find this progressive and improving than before. Today, we're going to share with you interesting topic about epigenetics and chronic disease. And Dr. Abdulaziz and Dr. Shema make my work very easy, so I'm going to just go through the introduction very fast. And we're going to focus on chronic disease and epigenetics. Did anyone heard about Baja before? Do you know about it? This is in Indonesia, okay? And these people spending more than 16 hours underwater because their lifestyle for fishing and swimming and all these things. What they found, the researcher, that these people have a large spleen, splenomegaly. But this splenomegaly is physiological. It's not harmful for them. It's not causing hemolysis, nothing. So it's good for them to can breathe underwater for more than expected in a human being. And they found this BDE10A gene. They found it responsible for the spleen and the thyroid function. And this is very interesting to know. So subhanAllah, how our body is a miracle. It's accommodate with our needs. So what we are needing, your body is accommodate with you. So this question, is your gene, is your destiny? We're gonna answer it at the end of the talk, inshallah. Let's go to Madrid. Madrid in 2005, they did like observational study. They bring 40 identical twins, and they study their lifestyle in correlation with gene expression after from 5 years of old till 65 years of old. 47 often. So the study aim was to explore the epigenetic effect, the lifestyle on the epigenetic changes, and they found in 50 years old identical twins compared with the 3 years old identical twins, 4 times gene expression was changed, which is a huge. So let's go on our journey, starting with just review together very fast, because there is some of us have no, I think not physicians. So genome is our library from parent and mother and father. This is your own genome. And chromosomes, your box inside your library, it's contained the paired chromatide. Just I want you concentrate about the telomere, the long arm of the chromosome, because we're going to talk about it later regarding to aging process. And each nucleus have 46 chromosomes holding each chromosome a DNA. DNA inside each chromosome, it's almost 3.2 cm. And if we're going to extend the whole DNA in our chromosomes, maybe it's going to reach up to 2 meters. For this DNA methylation and the epigenetic processes, it's all talk about these 4 bases, the adenine, thymine, and cytosine and guanine, and how the methyl group attached to these bases to do changes. And this is the genotype and phenotype. I'm sure everyone knows about that. Just to explore the strength of genetic, these two different people with totally different characteristics, both of them have the defect in same chromosome, it's 15, chromosome 15. Angelman syndrome having the defect in maternal part of chromosome 15. And Prader-Willi syndrome have a defect or imprinting of paternal part of the chromosome 15. And this is give you totally different syndromes, totally different significance. So it's really, really something matter. Genotype and phenotype interaction, it's gonna give you genotype interaction with environment, give you the phenotype. Epigenetics, as they explained very nicely by Dr. Abdulaziz and Dr. Shaima, it's gene expression, okay, and how we're gonna see it explored in our body. And the good news, epigenetic changes is reversible. So it's not forever. You can change your epigenetics. Your genes not be changed, but epigenetics and gene expression, it's reversible. And we're going to see how it's happened. Epigenetic processes, it's a lot, but the process that was studied very well, DNA methylation and histone acetylation and non-coding RNA. Simply, DNA methylation, as was explained by Dr. Shaima, the methyl group attached to cytosine base make inactivation of gene expression in that area. In histone acetylation, like you are seeing gene off and gene on. So you're switching off in DNA methylation, switching on in histone acetylation. And this also was reviewed by Dr. Shaima, but just going to give you an example about DNA methylation. For example, if the patient was exposed to arsenic, toxic level, this will going to happen DNA methylation for specific genes. If in folic acid, you see the recent studies which is affecting the colon cancer progression and prevention. So in our nutrition, physical activity, everything happened. Environmental, outside and inside, it's really affecting your epigenetic and gene expression. So let's go to diseases. We have atherosclerosis, which is very common. We have a lot of cases, and it's a burden in worldwide. So atherosclerosis, what we are know about atherosclerosis mechanism, that the endothelial dysfunction happen, so permeability is increased, and monocyte going inside and doing that black. But we don't know what happened before this endothelial dysfunction, and what's triggered the endothelial dysfunction. There is oxidized LDL. LDL itself, when increasing in number or increasing quantity, the oxidative stress with bad habits and bad lifestyle make the LDL oxidize. And oxidized LDL affecting the endothelial dysfunction and make it high permeability and allowing for monocyte to come inside and do the whole process of atherosclerosis. So if we starting to prevent by giving aspirin, before that we have to start with good lifestyle to prevent the oxidized LDL. So we're gonna prevent the whole process from the beginning. And this is how we are seeing here, the oxidized LDL in yellow circle here. It's attached to endothelial and make it permeable, and the monocyte come inside, and the plaque formation and sclerosis happen. What is making LDL oxidize? As we said, bad habits like obesity, waist circumference if it's exceeding the normal, if the patient physically inactive, if we have high LDL and high blood pressure. So all this is affecting the LDL and make it oxidize, and this will gonna cause the whole process of atherosclerosis. What about diabetes? What the relation of diabetes with epigenetics? There is a lot of theories and studies actually till nowadays it's searching why diabetes happen for some people and not happen for others. Because you can find a person obese and have a lot of things, but diabetes is not coming, and others haven't diabetes. So this is related to epigenetics. This is from American Diabetic Association. They're posting this. The interaction of diabetes type 2 between genetics, environment, and epigenetics. The whole processes, DNA methylation, acetyl, and histone acetylation. So environmental factors is affecting your gene expression, and this will gonna affect, especially in diabetes, insulin sensitivity, and beta cell function.
Dr. Nisreen, 5 minutes.
This is environmental lifestyle factors here, including viral, pollution, ultraviolet rays, bad lifestyle habits. All these, what mentioned, is affecting environmental outside and inside your body, stress, everything. And this is causing cellular modification and somehow that's including the mitogene activated protein kinase, which is transferred to activated protein kinase. This one, very important. Why? Because if dysregulation happens for this, we're gonna affect the mitochondrial oxidation and insulin resistant, and you're gonna find it in all processes of diabetes. And this will gonna affecting, as we said, the beta cell function and the insulin sensitivity. And this is to be more detailed about this, which is very important in insulin sensitivity. Normal person compared to diabetic person, the methylation, DNA methylation will happen. This will gonna lead to insulin resistant. Okay, let me give you an example. What happened in your body in epigenetics exactly if you have transient hyperglycemia. As a diabetic, if you have transient hyperglycemia, for example, for 16 hours, the effect will gonna stay in endothelial cells for how many days? If you have only high blood sugar for 16 hours, for example. The effect on endothelial cells in your body, we're gonna stay for how it's here. 6 days. You imagine? So blood sugar high for hours, we're gonna transit effect for days. And if this is gonna be continuous, the effect will gonna be for years. But the good news again, it's reversible and preventable. So once we treat this, the effect will gonna be reversed. I'm gonna give you an example for this Gemini study, which is a beautiful study about the prostate cancer. They bring 30 patients diagnosed as prostate cancer, low grade, and they take biopsy from the same person before and after the intervention. The intervention was lifestyle modification, that's it. So their aim to see is their prostate cancer expression downregulated or upregulated if we only interfere with lifestyle modification. And this is all parameters was measured. And what they found, after 3 months of intervention, they found downregulation of prostate cancer only by lifestyle intervention, which was a shocking result. And side on, they found also BMI was decreased, systolic blood pressure was improved, LDL also was improved. There are a lot of parameters was improved in these patients. And regarding the whole aim of this symposium with aging and longevity, they found the telomere, it's the length of telomere in people with lifestyle intervention was not affected. So they was interested to continue this study for 5 years to see the telomere will gonna be affected or no regarding the lifestyle intervention only. Telomere, just to remind you, it's the long tail of the chromosome, which is a marker of aging process. Normally, it's be decreased and short. But in these people, they found this. Control group in the orange color, after 5 years of lifestyle intervention, it was shortened because these people was controlled group. They are living as usual. But compared to the lifestyle intervention group, after 5 years, it was not only stopped of shortening, it's elongated. And their recommendation was, we need to do this in randomized control trial in big population to see it's really we can elongate the telomere after lifestyle intervention.
Dr. Nisreen, 1 minute.
Yeah, I'm about to finish. I want just to remind you, Dr. Salih Al-Ansari, he was gave us this beautiful, actually, from Prophet Muhammad, peace and blessing of Allah upon him. He said, "Oh Allah, please us with our hearing, our sight, our strength to the end of our life, and make them the higher from us, because you are hiring disease as you are hiring health." Why physicians have to know about epigenetics? Why you have to know? Why we are bothering you with DNA methylation, epigenetics, and all these details? Because we need to know what the causation and association of disease, so we can interfere as early as possible and to prevent it. To deal with lifestyle habits and behavioral changes seriously, not only as luxury or something complementary. No, it's essential changes. It's affecting, as you see with me, and even in cancer level. To use the magic lifestyle habits for promoting health and reversing chronic disease. So if you have a chronic disease at the end of the life, as we see in the last 3 days in this symposium, you can reverse the chronic disease, and this is, we're gonna hire it to next generation, so we can hire them health instead of disease. So I'm gonna ask you this question again. Is your gene is destiny? Is your gene is your destiny? No. So you can change it by good lifestyle and good habits. I acknowledge to my friend, Dr. Vedat Falata. She helped me a lot in this. And these are my references. Thank you so much.
Thank you so much to Dr. Nisreen. Now I would like to invite our distinguished speaker, and Dr. Nisreen, if you keep with us, Dr. Ahmed, Prof. Abdulaziz, and Dr. Shayma to join the discussion panel. Thank you. Well, first of all, I would like to thank the organizing committee for focusing on such important topic, epigenetic. It's such a big field that I think every one of us here benefited a lot from the lecture that was provided by you. So we had a lot of questions. First of all, the question was directed to Dr. Ahmed Al-Malek by the audience. The question is, Dr. Ahmed, what indicators best measure the success of digital infection control initiatives?
Thank you so much. Regarding the infection control, the most important measure is the reduction in the infection. So this is the most important indicator. So it's measured. Many researches have been done for measuring the reduction in infection using the artificial intelligence or even digital innovations. So this is the most important indicator.
A question by myself. I found your presentation quite intriguing. First of all, I disagree on, still I don't think we are on the front to use AI. AI showed a great result in terms of data collection, prediction models, however, still is not show that much of effect in terms of clinical day-to-day activities. So in the physician role now, AI cannot perform at the smallest level, similar to radiology. It failed so many AI models. However, another thing I wanted to ask you about, you mentioned that the predictors might be able to predict the outbreaks. So is that within the hospital or within the community?
No, this is within the hospital. We are working in this, like our models. It's used for hospitals. As you know, for proactive, to be proactive, you have to measure some indicators like rising infections. This is a synchronized system. It's all connected together with the lab, with the clinical entries, the clinical signs, symptoms. So it predicts that you have a hotspot at this department. This you have to focus. You have it give you alarm. Even it will block the platform and give you a voice alarm and send automatic messaging to the head of department, to the infection control, and we are planning to send even to the MOH and Wiqaya. It's automated. Then direct the infection control, head of infection control to using the AI to fill the form to manage the outbreak and start outbreak investigation. So the proactive in such cases like outbreaks, to be proactive is a very important point. So the AI helps in this. This is a tested model, and it's very, very impressive.
Yeah, we hope to see more and more within Allah. Prof. Abdulaziz, we have a question to you from the audience. It's a question about what do you think about the effect of epigenetic in the Amish people? So the Amish people, as we know, they are a group in America and they are isolated. They grow their own food. They marry, I think, within the community. So do you think there is effect of epigenetic within them or not?
Thank you, Dr. Yasmin. As you know, Amish is immigrate from Europe for long due to some belief backgrounds, and they live in some natural, environment. The answer is yes. It's affecting their genome, and they live more than others with 10%. And some chronic diseases are actually like diabetes, other diseases not common in their community. Another, they are in Indiana, I think. The other example is the Honza. Honza is another, clan or group of people in north of Pakistan. They are eating mostly some meat and fruits, and also they live more. And some women get pregnant at 50 or 60 years. So yes, the answer is yes. And so this is why we'd like actually to minimize the canned foods and try to add more from fresh foods, especially from our area.
Next question, I think the last one, directed to both Dr. Hashim and Dr. Nisreen. I'm an oncologist, and cancer is the most important subject for me. You mentioned the epigenetic role of food, and Dr. Prof. Abdulaziz also mentioned about the incidence of the chronic diseases. So what we are noticing now generally in cancer community is incidence of cancer in younger ages. It used to be disease of the elderly. Now we have 20 years old, 30 years old that are affected by that. So in your readings, have you passed similar subject or not?
You are asking about the effect of epigenetics on and food and cancers and so on. As we said, food is just not just a fuel or giving us energy, but it also signal our DNA. So changing in feeding habits, using the foods that we mentioned as protective foods, such as folate, vitamin B12, and so on, which are, as we said, missile donors, and other epigenetic diets in general, can improve the health and can, as Dr. Nisreen said, it can reverse the effect of harmful practices for many years, and they can make our genes more healthy, leads to less expression of genes responsible for diseases such as cancers, chronic disease, and so on. So it is food can act as a medicine. We can start as Dr. Abdelaziz said, from childhood to make it is a habit from the start, and if it wasn't a habit from the start, it can be used later on to reverse the changes. Dr. Nisreen will continue regarding chronic disease.
Okay, thank you so much for this question. And actually, cancer, especially cancer, it's multifactorial. So we'll talk about genetic. Definitely have a role. Our nowadays stress is a main factor of that. The food itself a factor, but how you cook this food, from where you bring this food, how you store this food, how you are eating. So all mechanism of the process of this, it's affecting the body, and really there's a lot of studies related to, for example, the grilled مثلا on the charcoal, immediately this will gonna increase pollution. So a lot of factors, it's affecting nowadays in our way of living and causing this type of cancers in early age, as you mentioned. And again, genetics and that we are taking from our parents, including the genetic expression that we already take it from them.
Thank you so much. With that, we end our discussion. I think Dr. Abdelmajid have something to say.
At this time, we would like to invite all our distinguished speakers and session moderator to stay on stage so that we may recognize and honor their valuable contributions. We kindly ask you to scan the QR code for three things: to submit your questions to the speakers, to complete the lecture evaluation, and to select one open dialogue session for each break. And our valuable guest, we will have a break, short break for 15 minutes, inshallah, and we will begin immediately after the break, inshallah.
First. Yes, the first one.
And this one.
Both are ready.
There.
Both are ready.
Okay.
Hello.
Greetings.
Yeah, I can hear your voice. Thank you. Yes, doctor. I can hear your voice. Okay, thank you. Please be online.
Thank you. Of course.
Our esteemed guests, the break will be ended about 2 minutes or a few minutes. We will start shortly, inshallah.
بسم الله الرحمن الرحيم. بسم الله. بسم الله.
So, we've just seen that our genes are not a fixed destiny. They are totally listening to our daily habits.
One of the loudest messages they receive, it's from what's in your plate.
This is a question to you, our dear audience. If your genes can rate your meals from 1 to 10, what would they give?
Up next, we will look at the now food, how help life better longer, not just longer. Please welcome to moderator, our nutrition and health span session, Dr. Nashi Al-Rashidi, Vice President of Nursing and Midwifery in High Health Cluster. Welcome, Dr. Nashi.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm very honored to be here today, and I'm going to thank the organized committee and the scientific committee and the chairman of this conference, which is the conference is the cornerstone of the world. We're going to start with the first speaker, Dean Al-Munif. She's the consultant of family medicine and dietology in King Saud University and faculty of member and College of Medicine and King Saud, and she's in Master of the Healthcare Technology from the King's College London, UK. The first topic she's gonna be discuss about it, the living well with the diabetes, extending the healthy years, not just life span. Just welcoming with me Dr. Dina Al-Munif.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for the introduction, and thank you so much for the scientific committee for inviting me, and for all of you, dear respected audience, for attending. Hopefully, inshallah, my talk would be beneficial. I'm truly honored to be here with you today. So my talk would be about living well with diabetes, extending healthy years, not just lifespan, and those are going to be my objectives. Okay, so I'd like to start my talk with a very popular concept nowadays, and it's actually really important. It's actually one of our country's 2030 vision goals. So what is the difference between lifespan and health span? So lifespan is refers to or defined by the total number of years a person lives. On the other hand, health span is defined as the years lived in good health, free from chronic diseases and disability. So we can say that lifespan focuses on quantity, health span focuses on quality. So what's happening here in Saudi Arabia? So we can see that the population of Saudi Arabia's lifespan is roughly or approximately 79 years versus health span, which is 64 years. As you can see, there is roughly a gap of 10 years. So there is still room for improvement. Why not living a healthy life actively, independently, free from chronic diseases and or disabilities? And speaking of chronic diseases, one of the most common chronic diseases that's quite responsible of affecting a person's lifespan, diabetes mellitus. So let's go over a quick review of diabetes mellitus. It's actually a very prevalent disease. It is a global and a local problem, affecting over 500 million adults worldwide. It's estimated to project to increase affecting over 800 million by 2050. In Saudi Arabia, it has ranked as the highest in the second highest in the Middle East in terms of diabetes rate, and 7th in the world, affecting over 5 million adults among the population of Saudi Arabia, causing clinical and financial burden. Okay, so over 90% of the cases of diabetes is responsible or due to type 2 diabetes. According to the latest IDF report, by 2050, they have defined the key contributors to the rising type 2 diabetes, being urbanization as the top significant key contributor, because it has caused significant or remarkable change in the lifestyle of people, increasing the physical inactivity and increasing the rate of obesity and overweight as well. So as you can see, those risk factors or contributors are quite preventable. Okay, so going back to our concept, how can we improve a person's health span within the context of diabetes? So we have three key opportunities: preventing type 2 diabetes, early remission, and optimizing management among those who have established type 2 diabetes. Okay, so prevention starts by addressing the risk factors, as we have mentioned earlier, and managing prediabetes, which is the strongest predictor of future type 2 diabetes. As you can see, beta cells here are quite or largely intact, making prevention achievable. Second, even after diagnosis, there is a significant opportunity for remission. Beta cell, yes, reduced, but still recoverable. Third, for people with established type 2 diabetes, even if remission does not occur, this is not too late, there remains a major opportunity to extend health span through optimizing management, achieving glycemic control, preventing complication and disability over the long term. So let's start with the prevention. Okay, so prevention, of course, starts with early routine screening. As you can see, this is the latest ADA table 2025. Up to this point, it recommends for screening for diabetes among people starting at the age of 35 years. And of course, screen earlier if there is risk factors present. Okay, so let's go over prediabetes and how can we prevent it or manage it, let's say. So prediabetes is defined as dysglycemia, where glucose levels are above normal but not yet in the diabetes range. Mainly, it is caused by two key defects, increase in the insulin resistance, and beta cells are not able to secrete enough insulin to meet the rising demand. So why some people are at risk comparing to others? Endogenous insulin sensitivity is inherited, and it even varies by 6-fold among the normal population. Obesity, being a modifiable factor, adds an additional insulin resistance on top of what is inherited. Treatment focus up to this day focuses on weight loss to improve the insulin resistance that is happening. So let's go over the overview of the evidence on type 2 diabetes prevention. So up to this day, up to this minute, lifestyle modification intervention has proven to be successful in terms of type 2 diabetes prevention. Let's go over a summary of type 2 diabetes prevention landmark trials. As you can see, different landmark trials across different populations have studied lifestyle modification as an intervention comparing to pharmacotherapy and or placebo. And as you can see, it has been shown that there is a decrease or a reduction in the diabetes risk from 31 to 46% in the King trial over 6 years, and 58% reduction in the diabetes rate over 3 years in the DPP trial, and over 4 years in the Finnish DPS trial. There is another question. Does this intervention has a sustained benefit on the long run? Yes, it did. So as you can see here as well, in the King trial, by following those patients up to 20 years, 43% reduction has been shown. Over 22 years in the DPP trial, 25% reduction has been shown, and 43% reduction in the Finnish DPS trial. Okay, so how about pharmacotherapy? Is there a role in preventing or managing type 2 diabetes or often preventing type 2 diabetes? Well, in the DPP trial, metformin has been studied as an intervention as well. As you can see, it has showed a reduction by 31% comparing to 58%. The question is, whom has the, let's see, the major benefit by taking metformin? So it was shown that it has been most effective in younger population who has a higher weight, and among female who had a history of GDM. That's why ADA recommendation up to the latest edition 2025 metformin to be considered in patients who are less than 60 with BMI of 35, who has higher glucose readings, and among females who has history of GDM. What about the newer, let's say, generation of agents, GLP-1 receptor agonist or GLP-1 receptor agonist / GIP? So trials has shown positive outcomes with liraglutide, semaglutide, tirzepatide, primarily through weight reduction, improving insulin resistance. So yeah, they have been shown quite benefit, but keep in mind that those agents and other pharmacotherapy are not labeled specifically for diabetes prevention. Okay, so let's sum up what were the evidence-based lifestyle behavior strategies that were successful in terms of type 2 diabetes prevention. Weight management, physical activity, nutrition, sleep, smoking cessation, all has a direct effect in preventing type 2 diabetes. In terms of weight management, for all who are obese or overweight, losing at least 7% of their initial body weight will be really successful, preventing weight gain again and maintaining weight loss. In terms of physical activity, being active within 150 minutes per week and more of moderate intensity activity, adding resistance training, and breaking up any prolonged setting, all showed remarkable improvement in terms of type 2 diabetes. Sleep as well, fortunately, lesser quantity of sleep, less than 6 hours or more than 9 hours, could increase the risk of diabetes. Poor sleep quality as well might increase the risk of diabetes up to 84%. Evening chronotype, meaning sleeping late, waking up late, would result in 2.5 higher odds of type 2 diabetes. Of nutrition, there is no single ideal macronutrient ratio, always and always individualized based on preference, culture, metabolic goal. However, effective eating pattern that has been shown to be successful: Mediterranean diet, low carb, plant-based, vegetarian, and DASH. last but not least, smoking cessation. As smoking cessation has a direct effect on developing type 2 diabetes. Okay, let's move on to the second opportunity, which is early remission. And let's go over the evidence on type 2 diabetes remission. So, in summary, remission, which was demonstrated across multiple RCTs, highest success with early intervention, of course, in the course of the disease. Weight loss was the main driver. Beta cell recovery is possible. Okay, so what was the latest diagnostic remission criteria? It was HbA1c less than 6.5, measured at least 3 months after cessation of glucose-lowering pharmacotherapy. Okay, so what were the diabetes remission approaches studied in the literature? So surgical intervention has been studied with or without lifestyle modification, pharmacotherapy with or without lifestyle modification, of course, with the help of digital technological intervention. Last but not least, health behavioral intervention without pharmacotherapy, without surgery. Okay. This is a summary of the diabetes type 2 remission landmark trials. Okay, so as you can see, lifestyle modification has been studied as an intervention, and it has been caused a 46 remission at 1 year, 36 remission at 2 years in direct trial, with the maximum. Yes?
5 minutes left.
Okay. It was even studied in younger population, so in 61%, surgery has been shown 72%, with, of course, higher weight loss showing higher remission. So, predictor of remission, higher weight loss, shorter diabetes duration, preserved beta cell, glucose baseline not elevated, and no baseline usage. Going to the third opportunity, which is optimized management. Is it too late for a patient who has established type 2 diabetes to live a healthy year? Of course not. With the with the approach of comprehensive holistic approach. Type education always is the key. We have to supply the patient, equip the patient with lifelong tools to empower them to manage their disease. Knowledge is truly a weapon. It has showed remarkable outcomes in terms of improving glycemic control and their quality of life. Of course, it should be addressing the pathophysiology of the disease, how to monitor their disease, how to healthy cope, and how to take their medication, and how to reduce the acute and chronic complication. Glycemic control, aim for early intensive control. Always, landmark trials has shown that even early intensive control would create long-term metabolic protection, defined as legacy effect, even if the HbA1c has been worsened later. So it would dramatically reduce long-term macro and microvascular complication, as you can see. Individualization, of course, always is the key. Diabetes technology, with the modern medicine that we are facing now, technology is not a luxury. Using, let's say, continuous glucose monitoring, even with the latest guidelines, the population of use has been expanded, and they have recommended broader patient population usage, early initiation, but because it has improved the control and patient satisfaction remarkably. Why? Because it is an intervention. It can cause them to have behavioral modification. By the real-time feature, a patient would be more aware of what's happening. So they would modify there would be more adherent to medication, more adherent to lifestyle modification. Lifestyle modification as well, let's not forget the 6 pillars. Nutritional therapy has been effective in dropping A1C, and always remember, no one size fits all. Consider reducing overall carbs, of course, with a variety of eating pattern. And always tell the patients about the spikes of different macronutrient, carbs being the highest, giving the highest response of blood sugar response. Protein and fat gives a longer period of sugar response. And of course, physical activity and sleep shares the same with the pre-diabetes, as we mentioned earlier. Smoking cessation, as well, advise all people to avoid this, even e-cigarette, because it's shown a higher risk of complication, worse control, and decreases, of course, premature mortality. Comprehensive diabetes complication is the key by addressing and modifying risk factor, blood pressure control, lipid control, glycemic control, and with the use of modern care of cardiovascular and cardiorenal, let's say, protective agents for all patients who need it or targeted population. And of course,
one minute is left.
Tamam. So last but not least, psychosocial care always and forever for people with diabetes and their caregivers, because caregivers do struggle with the patients with diabetes, do this annually, and the type of diagnosis, because it has shown to improve the emotional outcome and modestly improve HbA1c. I have reached my last slide. Message to all of you. Every stage of diabetes offers an opportunity to extend health span. Early action, holistic care, and patient empowerment create meaningful long-term benefit. A message to the patients: diabetes does not limit your dreams, your future, or how high you can climb. It may change the journey, but it does not define the destination. Those are my references, and thank you so much.
Thank you so much, Dr. Dina, for nice presentation. I'm gonna to allow the audience if there is any question. Dr. Dina?
تفضل.
You are mentioned the continuous for insulin and something for the living with the diabetes. Can you please how to engagement the community through this education for the diabetes, because the most of the people.
Okay, so just to make sure I've got the question right. So you're talking how to make sure that each patient receives the right education?
Yes.
Okay. Okay, so let's start with patients who are newly diagnosed. We have to individualize the patient, their needs, their preferences, their culture. Newly diagnosed patient would be different than patient who have been having this diabetes for a longer period or duration of time. Newly diagnosed patient will definitely need intensive, let's say, educational approach, addressing all, as you have seen in my slide, a lot of, let's say, points, starting with the pathophysiology of the disease, how to monitor the disease, how to, let's say, I would like to summarize it. I'd like to all the patients of mine to be friends with their disease, not make them their enemy. So that's what we would like to do with education, and keep in mind other factors and takes it into consideration. Patient married, patient who is aiming to for pregnancy, a patient who is using insulin, patient who is not, patient who's using technology, patient who is not. So you have to take a lot of personal and clinical factors into consideration just to make sure that you are, and just to make sure you deliver and empower the patient with the knowledge they need. So inshallah, يعني lifelong management would be inshallah reachable, achievable by the patient, because education is truly the key. لأن الpatient we only see them like 10-15 minutes. They deal with the diabetes lifelong. احنا نشوفه تقريبا من 10 دقائق كل تقريبا 3 شهور أو 6 شهور. So we need durable effect. So دائما
Thank you so much. It's more clear for that. Can I ask you one question? What type of the physical activity do you recommend?
Excellent. طيب. So moderate to vigorous intensity physical activity for 150 minutes and above, distributed over a week. وأهم شيء 2 consecutive days. ما يكون في 2 consecutive days without activity. Examples of that: brisk walking. I always explain to the patient brisk, whatever is equivalent to brisk walking, where you feel that there is palpitation and you started sweating. And of course, adding 75 minutes of resistance over a week, and always and forever disrupt any prolonged setting. For 30 minutes, وقف كذا شوي تحرك ثم ارجع. هذه تقريبا in brief.
Thank you so much. Thank you again. Good luck. Okay, we're gonna to start with the second speaker. Dr. Abdulaziz Al-Juhani is the distinguished physician with the board and certification of family medicine and palliative medicine and pain management and medical education. He will talk about the longevity code, cracking nutrition for the longer, healthier life. Just welcoming with me Dr. Abdulaziz Al-Juhani.
الله يديكم العافية. كرنا ناس الله يحفظك. طيب السلام عليكم ورحمة الله وبركاته. I'm so proud إني مرة ثانية في حائل الرائعة. I would like to apologize to my colleagues that I'm sitting with them on the table. That most of my talk, it will be in Arabic just to transfer the message. Thank you. My talk حيكون عن longevity code and how nutrition cracking longevity in our life. لكن before we start, I have an issue. Okay. خليني let's to move للmain goal. إيش البيج بيكتشر من الليكتشر هذه؟ تمام؟ البيج بيكتشر إنه إحنا how we can compromise the morbidities. شلون نخلي الديزيز أقل بالمملكة. تمام؟ It's not a matter إنه نعيش أكثر. لا, it is a matter to add lives to our years. شلون نعيش إلى آخر يوم وإحنا بصحة. You get the message? So the question, how can our diet shift the lifespan curve, our lifespan and our patients' lifespan? Okay? Okay. I have a question for you guys. Which dietary pattern do you believe is most strongly associated with the longevity? Okay, in the scientific literature. Okay, I apologize, there is no QR code, but who is thinking that a ketogenic diet can add lives to your years? Raise hands. Okay, we have one. Okay, intermittent fasting, what do you think? Okay, good. 2. Okay, what about the Mediterranean diet? Do you think? Okay, we have. Oh, we have more. Excellent. Excellent, great. Okay, what about plant predominant diet? Oh, so most of the people, they are agreed about C and D, and this is very interesting. So let's to see the evidence about that. Okay. Please see the longevity the Saudi way. خلينا نقابل عم ظافر واسمعوا منه ونرجع.
بسم الله الرحمن الرحيم. معنا العم ظافر بن ثابت العمري. حياك الله يا ابو حسين.
يا هلا مرحبا، مساكم الله بالخير.
اهلا وسهلا. كم عمرك الحقيقي يا عم ظافر؟
الله يطول اعماركم ويمسيكم بخير. والله الاعمار بيد الله، ولكنه كان اول ما عندنا تاريخ، ولكن اللي انا اكتبه انه يمكن حوالي 136 سنه.
ما شاء الله.
الله عز الله اللي الله يبيح منهم. اسناني ما عاد منهم واحد.
الله يعطيك الصحه.
لا نسوان ولا ريق الا 2 نسوان نخبرهم بعد حياه. يشهد الله. الله هذا في طريقه ولا في امورها، والباقيين عسى الله يرحمهم ماتوا وبن الحقهم وعسى الله يحسن الخاتمه.
الله يعطيك الصحه والعافيه. نبغى كلمه ختاميه بالانجليزي.
Thank you very much. I be Mr. ظافر ثابت العمري.
Okay, this is an example about someone he lives for 136 years in Saudi Arabia. So let's to see the secrets. Okay. Do you hear about the blue zones? Do you know anything about the blue zones? So this is a cities among the worlds. The population in that cities has the highest life expectancies. So unusual in that cities on Okinawa في اليابان, Sardinia, Italy, and Icaria في Greece, and Nicoya في Costa Rica, and Loma Linda in California. Unusual إن الواحد يتوفى قبل 100 سنة. والأعمار بيد الله. تمام? So unusual, someone will pass away before he complete 100 years. Okay? Our goal, نبي حائل تنضم ليش؟ للبلو زون.
Tamam? So we would like Hail to be included in the blue zone cities, so the survival rates among the population in Hail to exceed the 100 years. But the question, what? How? Okay? Pillar number 1 is the plant-based powerhouse. Keep in mind that when you are prioritize plants, what that mean? Plants, when going on in our body, it will be boiled down and break down to 2 things: fibers and polyphenols. Fibers is not just for digestion, no. Fibers, it will help our body to what? What do you think? Fiber, when entering your body, what they are doing? Anyone? It will help your body to produce metabolites. We call it short chain metabolites. And that short chain fatty acids, it will reduce systemic inflammation. Okay? And that will help as anti-aging. بمعنى اللي يشوفك وانت عمرك 30 ما يقول انك في 40. You get it? Okay. So there is a very interesting meta-analysis and systematic review showing that dietary fiber intake reduce all cause and cause-specific mortality. It is unupdated and the link is down. Okay? Otherwise, polyphenols, the second things that when plants enter our body, plants are vegetables. Okay? When enter our body, it will be, it is usually in the berries, nuts, and dark leafy grains. It will compact oxidative stress and inflammation. مضاد للأكسدة, antioxidants. So that will enhance our cellular defense within our body. So this is pillar number 1. Okay? Pillar number 2 is timing. Timing is everything, the science of fasting. So keeping duration between the meals is not a joke, it is a must. Okay? Why? Embrace a time-restricted eating. This is very important. Why? Because عارفين الهاوسكيبرز ايش يسوون الهاوسكيبرز؟ Clean up the things. So time-restricted eating, that will embarrass autophagy process. فيعمل housekeeping inside your body to clean up all the damaged cells. And that works so effectively as anti-aging. Okay? Okay. So the duration may be 10 to 12 hours. وهذه واحدة من يعني إبداعات هذا الدين إنه خلال 12 شهر عندك شهر تعمل فيه housekeeping. This is very important. Okay? The third pillar is the protein paradox. Very important. The protein paradox optimize the protein intake. But what type of protein? Plant source proteins. Please keep in mind that if you are depending, that's not mean to be to exclude the animal proteins. No, if you are depending on animal proteins, that will cause something we call it overactivation the growth process. Like what? Like mechanistic target of rapamycin that will accelerate the growth in your body, okay, and lead to over-aging while you are still young, looking, okay? So a high animal protein intake in midlife is linked to increase in mortality, while plant protein is protective. In elderly people, we need the protein. Why? To avoid the sarcopenia, the muscle loss. كل ما كبرنا كل ما احتاجنا البروتين أكثر. تمام؟ الإيفيدنس إن أكشن، ربعنا اللي بالبلو زونز وش يسوون؟ First, dietary threats on that cities that I showed you earlier, what they are doing, 95% they are plant-based, heavily on vegetables, beans, and whole grains. They implement Japanese strategy was telling by our prophet since long time called Hara Hachi Piyu. Hara Hachi Piyu معناته لأكلت يسعدك لا تملى بطنك. تمام؟ 80% empty please. Okay? A moderate caloric intake, so aligns with the evidence of caloric restrictions. That's what we call it time-restricted eating. Okay? So the longevity diet, a practical scientist, a prescription, please. Any patients attend to your clinic or as whatever your health profession specialty, give them this prescription. So make 90% of your plates plants. Aim for a rainbow of colors. Please. Okay, rainbow قوس قزح. خلي يشوف الأشكال كلها في الطاولة. مو بس يعني just one color. Okay? Then eat your meals within a constant 10 to 12-hour window. This is very healthy. Prioritize the plants for protein, includes legumes, البقوليات daily. Embrace, if you eat animal products, please make it as a side dishes. قل له خلها شيء جانبي, مو main dishes. Okay? Embrace healthy fats from nuts, seeds, and olive oil, and hydrate with water. Okay? So this is prescriptions that any health profession can give it to the patients. Thank you. يعطيكم العافية.
Thank you, Dr. Abdulaziz, for the informative presentation. And I'm gonna to take the last speaker, Dr. Fanta Sayan. She is founder of Wellness Worker, certified lifestyle medicine, and she is coaching also in CHAF and author and the speaker. And she is certified in nutrition science and standard of the nutrition, also management and testing for cardiometabolic disease, Harvard Medical School. She will talk about the fasting and our relationship with the food. Just welcoming with me, Dr. Fanta Sayan.
Namaskar. I feel truly privileged, honored, and absolutely delighted to be presenting on this prestigious platform second year in a row. And thank you so much for this opportunity. Topic for my presentation today is fasting, reimagining our relationship with food. Here are the objectives. Just a second. Okay. I'm sorry for the technical glitch. So I'll share again my screen. Yeah, so here are the objectives. Eating nourishing food helps us stay healthy, and at times not eating anything also helps us stay healthy. And that's the very gist of fasting for you. There's a lot of research going on in this field of fasting. These are the sections under which I'm going to conduct my presentation today. I wish to bring your attention to section 2, 3, and 5. Without waiting any time any further, let's begin with the history and definitions of fasting. So religious fasting existed as early as 1500 BC. Therapeutic fasting was recommended by Hippocrates around specifically 440 BC. And in the year 1946, the term intermittent fasting was coined by Anton Carlson. So what is fasting all about? It is voluntary abstinence of some or all food, some or all beverages for a specific cause, and fasting can be continuous, intermittent, or therapeutic fasting regimens. Continuous can be short term, as in 2 to 3 days of fasting, long term, more than 4 days of fasting, and periodic fasting, where periods of fasting and eating alternate and they are repeated in a cyclic manner. Considering this definition, intermittent fasting can be called a type of periodic fasting. Intermittent fasting has many patterns: one fasting day per week, or 2 consecutive or non-consecutive days of fasting per week, alternate day fasting, or TRE, or time restricted eating as we call it, as my previous speaker has spoken about it. TRE is about eating within a window of fixed number of hours, which is then called eating window, and rest number of hours in a 24-hour cycle are called the fasting window. In TRE, as per an expert international consensus published in 2024, fasting window must be minimum 14 hours. TRE can be early TRE, as in eating window in earlier half of the day, or late TRE in later half of the day. Now, therapeutic fasting regimens, these can be many. Here, fasting remains the main component, but there could be other elements. Like in Bushingur fasting protocol, we have inclusion of bowel cleansing procedures. Section 2, let's see how our body responds and adapts to state of fasting. 4 to 6 hours after fasting, 4 to 6 hours after fasting, glycogenolysis begins, because now blood glucose levels are beginning to dip. So liver glycogen stores are broken down to maintain the serum glucose levels. 12 to 24 hours of fasting later, glycogen in hepatic stores has depleted. Serum glucose levels are down by almost 20%. And lipolysis now takes over as a fuel source supplier for energy production. So this begins preferentially in visceral adipose tissue. Triglycerides stored there break down into fatty acids and glycerol. Fatty acids and glycerol via portal vein travel to liver, and here fatty acids undergo beta oxidation to produce acetyl coenzyme A, and glycerol goes through a chain of reactions and produces acetyl coenzyme A and lactate. Brain, unlike other tissues in the body, cannot use fatty acids. Other tissues can use fatty acids for energy production, but not brain. Brain needs either glucose or ketone bodies. So gluconeogenesis and ketogenesis aim at supplying the energy source to all the cells. Gluconeogenesis, the substrates here are glycerol, lactate, and certain glucogenic amino acids, which are sourced from breakdown of skeletal muscle protein. About 80 milligram per deciliter equivalent of glucose is produced via gluconeogenesis. However, most of it is uptaken by the brain. Ketone body production uses substrate of acetyl coenzyme A and ketogenic amino acids like leucine, lysine, tryptophan, etc. So by now you may have noticed that with glycogenolysis, body starts shifting to starvation mode. Now all those functions that are not necessary for survival will be downregulated. So downregulation of thyroid axis results in lowered basal metabolic rate, growth hormone resistance because of reduced expression of growth hormone receptors on the liver, and hypogonadotropic hypogonadism, resulting in lower levels of testosterone and lower release of luteinizing hormone from pituitary gland. These changes in metabolic pathways now result in beneficial effects for us. These are the effects. Also, acetyl coenzyme A acts as a substrate for production of acetylcholine, and this results in increase in parasympathetic tone, giving us further benefits. A word on autophagy before we move ahead. This is a mechanism associated with self-eating, and onset is about 24 to 48 hours in hepatic tissue sample of animal models in lab conditions. What is the mechanism? Nutrient deprivation leads to induction of autophagy, and this starts with formation of double membrane vesicle inside the cell. This is called autophagosome. Now, this autophagosome engulfs the protein to be degraded, like misfolded, damaged, or mutated proteins, or damaged or senescent cell organelle. So these are engulfed. It then fuses with lysosome, and degradation of the cargo within occurs. Are there any benefits for autophagy? Yes. Like my previous speaker said, there are definite benefits. Cleansing of cellular environment takes place here, and as a result, cellular health improves, and there is an optimization of cellular function. Now, back to our benefits from fasting. So, in summary, there is a reduction in inflammation in the body, increase in antioxidant activity, induction of autophagy, improvement in insulin sensitivity, and of course, increase in parasympathetic tone. So this adaptive response to fasting seems to be beneficial for us, but is there enough evidence to support this statement that I just made? So let's now breeze through a few studies to analyze efficacy of fasting for health and longevity benefits. 2022 randomized control trial, all the participants were diabetic, 72 in number. The intervention group did intermittent fasting. This was 10 hours early TRE with Chinese medical nutrition therapy. What is Chinese medical nutrition therapy? This involves increased intake of fiber-rich, low glycemic index carbohydrate foods like yam, monk fruit, whole grains like oats, whole wheat, and white mulberry leaf tea. So this protocol was to be done for 5 days, followed by 10 days of free eating, and this to be repeated in a cyclic manner for next 12 months. So at 3 months, significant benefits in fasting group. At 12 months, most of these benefits the participants could retain. And HbA1c, as you can see, stayed in non-diabetic range. For cardiovascular health, now here various fasting patterns were analyzed, and this meta-analysis was published in 2023. These patterns were analyzed for their effect on cardiovascular health markers, as on your screen, and it was seen that there was no significant difference, which means that almost all the fasting patterns are equally beneficial for cardiovascular health, and this could be due to calorie restriction. Brain health and cognitive function. So this RCT 2024 published, and 40 participants, elderly people, overweight with insulin resistance, 2 groups. 5 to intermittent fasting with 2 consecutive days of fasting, and USDA healthy living diet, which comprises of fruits, vegetables, plant proteins, and whole grains. So duration was 8 weeks only, and longer term duration was needed, even though there were benefits, but longer term duration is needed because elderly people don't always respond favorable to all fasting patterns. Fasting mimicking diet in breast cancer patients. So fasting mimicking diet, 4 cycles of it to be initiated every time 3 days prior to chemotherapy, 34% completed, and they saw maximum benefits in terms of more than 90% tumor tissue loss. What about longevity benefits? Well, there are certain changes associated with fasting that do result in benefits in terms of health and longevity, like calorie restriction, protein restriction. Protein restriction independent of calorie restriction has longevity benefits, especially because of methionine restriction. Then reduction in IGF-1 levels, autophagy, fasting mimicking diet, all of these are consistently shown to be beneficial for increase in healthy lifespan. 3 cycles of fasting mimicking diet in a trial on humans showed reduction of biological age by 2.5 years. Some concerns: dehydration because of diuresis and natriuresis, gallstones because of bile juice flow stasis in absence of stimulus, loss of bone mineral density, especially observed in elderly. Sometimes it reduces up to 3% of total bone mass, and increase in inflammatory markers in prolonged fasting, like 48 hours or more. And then, of course, fasting is not for pregnant women, children, people with disordered eating, or elderly, unless done under medical supervision. Some research updates in the field of fasting now. September 25 study, 6 months, postmenopausal women who were put on very low calorie ketogenic diet saw benefits in terms of improvement in cardiovascular health. 3-month study, overweight obese women who reported for infertility treatment were put on very low calorie ketogenic diet 3 months prior to their IVF appointment. 58% was the pregnancy rate, but more interesting fact was that 6 women, even before they could complete 3 months of intervention, got pregnant. A review article that said that dietary pattern good for cardiovascular health, like DASH diet or Mediterranean diet, give more benefits when these are combined with early time restricted eating. Some more studies. So this 2 weeks trial where all participants had resistant hypertension. They were put on a 16-8 TRE for 2 weeks, and all of them could successfully reduce their blood pressure. It was hypothesized that this happened due to gut microbiota modulation. A June 25 study, 3 months randomized controlled trial, where it was seen that in comparison with late TRE group, early TRE group had more improvement in body fat mass, diastolic blood pressure, metabolic age, and fasting glucose. And now this animal model study, published September 2025, this year only, it showed that a 26-day intervention on animal models of alternate day fasting induced autophagy and restored beta cell function. This brings us to the end of my presentation. And in summary, fasting is about resetting our metabolism. Diseases are caused by dietary excess of unhealthy foods. And fasting gives the body a chance to restore the healthy metabolism the way it should be. TRE looks like a safe, doable, and sustainable form of fasting for almost everyone. Having said that, short-term effects of almost all types of fasting patterns are likely beneficial. What about long-term fasting? We can't say for sure because there are not very many human studies, more than 2 years duration. So before we say anything on long-term effects of fasting, we need more research and long-duration human trials. This is a list of references. Thank you so much for having me here.
Thank you, Dr. Fanta, with us. Please be with us. We're gonna to move the panel discussion. I'm gonna to ask Dr. Abdulaziz to come in the panel discussion, and Dr. Fanta, please be with us.
Yes.
We're gonna to move the panel discussion. We're gonna to ask first of all, we would like to thank the scientific committee, the organizers, and all the people behind of this, such as this event. Dr. Abdulaziz, I'm going to ask you, what is one primary public health goals of the implementation in National Nutrition Code focused in the longevity in Saudi Arabia?
Saudi Arabia. 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 Saudi
Okay, really the primary goal is to reduce diet-related non-communicable disease in the Saudi Arabia, such as type 2 diabetes and obesity, inflammatory bowel disease, cardiovascular disease. So this is the main goal from implementing nutritional codes in the population. Okay.
Dr. Abdulaziz, I have one question for Dr. Afand. Are there any specific guidelines or the best practice for someone that a new fasting? Doctor, did you hear me?
For me? Okay.
Did you hear me, Doctor?
Did you ask me?
Yes. There is one question for you.
Can you please repeat the question?
The question for you, are there any specific guidelines or best practice for someone for new fasting?
Yes, I would say start with a fasting window that is manageable for you and get yourself checked from a doctor in case you are living with a pre-existing condition, health condition. If you have a disease, then it is better to do fasting under a medical supervision. That will be better. And otherwise, if you are planning to do fasting regimens on your own, it is better to start with a time-restricted eating pattern where you have a fasting window of not more than 12 hours, which is easily doable. So eating at 7 o'clock in the evening and then eating your next meal at 7 o'clock in the morning is very easily doable and unlikely to have any adverse effects.
Thank you so much. I have one question for Dr. Abdulaziz, one question in Arabic, and I'm going to read it in Arabic and English. Dr. Abdulaziz, in your opinion, what is the secret behind Blue Zone? How have this population achieved such as remarkable longevity? In Arabic, في رأيك ما هو السر وراء البلو زون؟ كيف هذه الشعوب وصلت لهذه الأرقام العمرية? This is from the audience asking.
Yeah, I think the blue zones, they implement the three main pillars that we are talking about. So they depend mainly as a predominantly on the plant and utilizing greens, and also they take care of the protein intake according to the protein paradox. And also what I mentioned, me and my great colleague about time-restricted eatings and how that can help as a housekeeping in our party and to improve the gut microbiome to produce metabolize like short-chain fatty acids.
Thank you, Dr. Nasser. Thank you, Dr. Afanta.
At this time, we warmly invite our distinguished speaker and session moderator to join us on our stage to be acknowledged for their valuable contributions. Ladies and gentlemen, that concludes our fourth session. Our fifth session will be start at 1 p.m. after a short break, inshallah.
Okay. This one. Okay, that's fine. Yeah, my wife is good.
Yeah, feeling hot.
We will start after 5 minutes.
Hello.
After third session, it's clear that food is not just a foil, it's a part of our long-term treatment plan. And when nutrition meets movement, a good recovery, even surgery outcome can take a completely different. For your, as an audience, if you explore how lifestyle shapes the story, the operation room, and beyond, please welcome moderator of our next session, Dr. Mohammed Al-Harbi. Dr. Mohammed Al-Harbi, consultant of internal medicine and assistant professor, Saudi Board of Internal Medicine for King Faisal Specialty Hospital. Welcome, doctor.
السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. First of all, I would like to thank the High Health Cluster, the organizing committee, for organizing such an amazing event. So, getting away from the drugs, bills, blade. So today we are talking about the lifestyle. So how simple things make a big difference. So lifestyle modification, it is one of the pillars in management of all our patients. So we used to just prescribe medications, instruct the patients to do surgery, but we forget the most important things, which is the lifestyle. So practicing evidence-based lifestyle changing is an amazing, interventions to help the patients to live longer. I have one comment on the theme of this conference, Live 80. I used to see a lot of old age patients. So old age patients, I used to say live more than 100. Okay, it's not only 80, even beyond, by practicing an evidence-based, and lifestyle changes. So to start our journey, I'm gonna introduce our expert in the lifestyle, Dr. Sunil Kumar. Dr. Sunil Kumar, he's a lifestyle medicine ambassador at the Personalized Care Institute in the UK. By the way, he's an anesthesiologist, so he moved from getting the patient sleep to improve his life after that. Dr. Kumar, he's gonna speak on lifestyle medicine and surgical outcome. Without any delay, join me to welcome Dr. Sunil Kumar to the stage.
Hello. Good afternoon, everyone. We have been speaking about lifestyle medicine for last 2 days and seeing the impact of lifestyle medicine in chronic diseases which are lifestyle related. How many of you feel that it can have an impact on the surgical outcomes as well? 2, 3, 4, 5, 6. Yeah, thank you. I think this awareness, we have to bring it to the community, to the people, to the patients, to the surgeons, to everybody. So the topic today I'm speaking is about lifestyle medicine and how it can improve the surgical outcomes. Before I do that, I'm extremely thankful, and it's my honor and a blessed moment to be here again in Hail. Last time when I was here, I was sharing my first slide about Hatim Tai. The story about Hatim Tai and his fables, we in India used to hear as well about him. So the generosity and kindness this Hail has got now, it dates back to Hatim Tai. As Michelle heard about me, my interest in Hatim Tai, he immediately took me in his own car to the Hatim Tai's place. So these are the photos from there. Thanks, Michelle. You are more than a family now. Thank you. So I'm associated with multiple organizations, and I'm going to talk to you about lifestyle medicine and surgical outcomes based upon my experience and my knowledge nothing directly or indirectly related to any of the organizations we use our perspective. So why you should listen to me when I speak about lifestyle medicine and surgical outcomes? Obviously, I'm a lifestyle medicine physician. I'm leading on the lifestyle medicine projects in WHO Collaborating Center at Imperial under Professor Salman. Obviously, I'm also lead at the Prehabilitation in Special Interest Group in British Society of Lifestyle Medicine. I'm an anesthesiologist, so that also brings in my value there. And there is a Center for Perioperative Care, which has got Royal College of Surgeons, GPs, physicians, everybody under their umbrella to look about how perioperative care can be improved. So I'm an advisor in the perioperative care for lifestyle medicine, which can be used in rehabilitation. I'm also have written a book on power of preparation for surgery. That's how you. That's another reason why I'm talking on this subject. So surgical paradox we all facing globally, anywhere here or in the developed countries or America or UK, anywhere else. We have become a world class inside the operating room. We have got great monitors, surgical equipments, surgeons training, anesthesia monitors, anesthesiology skills and training. But most of the risk the patient faces from surgery sits outside of the operation theater, which is lifestyle driven conditions, which the comorbidities like diabetes, hypertension, and other lifestyle related conditions increase our perioperative risk, how we get operated, do we survive the surgery, and how once you come back out of the surgery, how do we perform? So globally, about 7 to 15% is a major complication rate. Imagine, despite of all the advancement in technical skills and everything else, we still have this much of complications in the patients. And recovery actually varies depending upon the baseline health of the patient, metabolic health, then the surgical technique. So, and also when patient is told that he's going to have a surgery, it's the most teachable moment, because at that point of time, patient is happy to listen to you and modify his life behavior at the maximum. So surgery represents 1/3 of the global disease burden. And I'm talking about UK numbers because I don't know much about here. 10 million surgeries per year in the UK happen, which are elective surgeries, and 1 in 5 patients develop complications, which is again 20%. And about 16 billion is spent on the elective procedures. So why this matters anywhere else plus here for Kingdom of Saudi Arabia and globally as well? Because we all know 70 to 80% of the deaths and morbidity are due to the lifestyle related non-communicable diseases. And there is high prevalence of obesity, diabetes, smoking, hypertension everywhere. These are the same risk factors they walk into the operating room for elective procedures. Imagine if I ask any one of you to run marathon next week or 2 weeks later, would you be happy to run a marathon? Anybody? No. How long do you take to get yourself trained towards going into marathon? 6 months, a few months, 8 months, 9 months, whatever, yeah? So imagine the surgery itself is like a marathon. You have to give some time to prepare those patients before they go there, because we have to increase their physiology and the reaction to the surgery. So every major surgical risk factor is lifestyle modulated. If patient has got low fitness, he can have pulmonary complications during operation and post-operatively as well, which will delay his recovery to go back home. Also, patients usually are malnutrition. They are sometimes obese. They all get high risk factors towards getting wound infected, and length of stay increases in hospital as well as in ICU if there are major surgeries. Again, smoking and alcohol has got respiratory events, respiratory complications, poor wound healing, and poor surgical outcomes as well. Stress and poor sleep, I don't have to explain to you all, but it's when it comes to surgery, they have got higher pain problems afterwards if you got a poor sleep habits pre-operatively. Obviously, there's delayed recovery as well. So if you look at it, most of the biology here is modifiable. We can't blame it on fate, especially for the elective procedures I'm talking about here. So why outcomes vary so widely for the patients when they come out of the surgical outcomes? Obviously, there's age and genetics. They are fixed. Epigenetics can be changed, but genetics are fixed. Surgical complexity of the patient is fixed, almost surgeon and the procedure dependent, they are on that. And comorbidities are partially modifiable depending upon what they have. And then functional capacity, nutrition, sleep, stress, they are highly modifiable. What do you understand by functional capacity? Anybody knows? Functional capacity, anybody knows? No? How much oxygen you need to be at rest without doing any physical activity? The basal oxygen requirement is about 3.5 mils of oxygen per kilo per minute you need just to be at rest. So that is called 1 MET, 1 metabolic equivalent threshold. So functional capacity refers to the patient's ability to perform physical activities that require oxygen delivery and utilization by the body. So obviously to deliver the oxygen, we need to have a good healthy lungs, then healthy heart, then the healthy musculoskeletal system. So essentially how in a perioperative medicine, it represents how much physiological reserve we have. So that's why we can't run marathon in weeks time or 2 weeks time unless you improve your physiological reserve. Similarly, for elective major surgeries, if you improve your physiological reserve, you come out as a winner. So the clinical reality of functional capacity, I told you 1 MET is when you use it for at rest. When you start standing up and start walking slowly, you're using double the oxygen, which becomes 2 MET. Then you start a little bit brisk walking, it becomes 3 to 4. And when you start doing average activities, running or walking for longer time, you need more than 4 METs. If any patient is entering any elective surgery operating room with less than 4 METs of energy, it equals to poor capacity. And evidence-wise, it has been proved that they have got increased post-operative complications, especially cardiopulmonary, and prolonged hospital stays and mortality. It is modifiable through rehabilitation. If you look at this graph, if dotted line is your average basic functional capacity before anything is happening to you. Now, if you go with that average capacity, obviously you'll have a little bit of, if you look at red line, you lose, preoperatively you will start losing your functional capacity with all the factors related to disease as well as stress. And then once surgery happens, you go below the dotted line. So you are actually going in less than 4 METs, even towards 1 MET. It takes longer time for you to come back to recovery, even to the baseline what you had before. If you apply enhanced recovery programs, which are just enhanced recovery programs during the surgical time, you can still have a good outcomes. But when you combine with rehabilitation, you never go down the basic functional capacity line. You will have a good resilience to come out of the outcomes and less complications. What is this? What do you think this is? This is a surgical stress response. When patient gets on injury site is just a controlled trauma. When you cut open the abdomen, it's a controlled trauma. That leads to the neurohumoral response, that leads to the whole body protein catabolism. Also, you start getting insulin resistance. Now, this stress response cascade happens post-surgery or during surgery. So you can see there are so many physiological changes are happening here. So if you send the patient for elective surgery, already with poor reserve, this will add to it. And when do you think the patient starts the stress cycle? Is it in the operating room or before that? It will be before that. Once the patient is listed on the day for the surgery, few weeks before the surgery, the stress cycle starts. So it starts building this neurohumoral response. All these things start happening that time. So once we start putting stress management techniques pre-operatively a few weeks before, you are actually doing good for the patient. So rehabilitation involves strategies to prepare patients for surgery physically and mentally both, and psychological readiness as well. So main aim is to reduce post-operative complications, enhance recovery times, and decrease hospital stays. There are different modes of rehabilitation. You can call it as unimodal or multimodal.
5 minutes left.
Oops, sorry. Okay, so unimodal, these are different modes. If you look at the different modes, they are nothing but the pillars of lifestyle medicine. Again, the same thing which I explained to you in the last one, same graph it is. I'll just quickly go through a few slides. And this was from the cardiac surgery evidence. You can see they get early extubation, they get discharged to the hospital from the hospital early, they go home early, less complications as well. I'll flick. Okay. So nutrition-wise, you have to give good protein, do their micronutrients, put them on anti-inflammatory diet and microbiome support. Movement, just like any other pillars, other things we do, same thing here, 150 minutes per week, moderate exercise, even breathing exercises help them. Sleep, again, preoperative insomnia is associated with increased pain and increased inflammation later on. Sleep hygiene plus CBT, if you do, it improves recovery. There is evidence for it as well. Then stress management, again, as I told you, you have to start early as soon as your patient is listed for the surgery. Substance optimization, smoking, cessation, and alcohol, we know that will reduce infection. It will have increased healing time. And also the cardiopulmonary risk is reduced with alcohol and reduced bleeding risk as well. Hidden pillar of surgical success, connection again. Social support is important to adhere to all this thing, as well as peer networks, which will increase their sustainability on the behavior change which we address to them. So if you look at 6 pillars, they are nothing but 6 surgical superpowers. Nutrition makes you metabolically ready for the surgery. Movement gives you the functional reserves and functional capacity you need. Sleep puts you into hormonal balance. And stress, immune optimization, substances, healing, acceleration happens through that. And connection, adherence multiplier. So why this matters for High Island Kingdom, Saudi Arabia? It aligns with Saudi Vision for 2030. Prevention plus quality of life is a national strategy. You got an opportunity to lead the region in perioperative lifestyle medicine if you start applying this. And huge potential for cost savings because patients will come back less to you and they get discharged from the hospital early as well, less complications. So evidence is clear, multimodal rehabilitation improves functional capacity, post-op complications get reduced, ICU stay becomes less, and length of stay also in the hospital also becomes reduced. Readmissions are less, and mental well-being and quality of life improves. The good thing is that patient starts taking all these measures throughout his life afterwards, which is even better. So call to action is every time you see any patient in your primary care, at home, everybody, even lifestyle medicine advice, starting from there is important point to bring their impact in the outcomes. So send them to better lungs, better nutrition, better sleep, lower anxiety, and higher resilience. And this is my book. You can scan the QR code. It is available here as well if you want to. And anybody wants to translate this in Arabic, I'm more than happy to work with them. And we can also build a program on rehabilitation here if needed. Thank you.
Thank you so much, Dr. Sunil, for the highly informative presentation. You told us about how the lifestyle change make the surgery easier on the anesthesiologist and the operating surgeon. So without any delay, let's move to our next speaker. Dr. Yazid Anter. He is acting consultant, physical medicine and rehabilitation, and the lifestyle medicine specialist. He's gonna present a talk about the physical activity and the gym alternative. Without any delay, join me to welcome Dr. Yazid.
Assalamu alaikum, everyone. Thanks for Hail for the amazing hospitality. شكرا لكرمكم وشكرا للدعوة. Today I will be presenting the things that Dr. Sunil mentioned. I will prepare you for it without pressure. So if you want to achieve the metabolic equivalent without pressure of the gym, pay attention to this presentation. So I have nothing to disclose, and all the things that were presented in this presentation is without paid advertisement. So these are my objectives. I will define the physical activity very briefly, and we'll talk about the sedentary behavior prevalence in Saudi, and then we'll talk about different benefits of physical activity and exercises, population awareness of benefits of exercises, gym model of physical activity, and what are the limitations and considerations regarding this model of exercise. And we'll talk about daily habits. Then HIIT, or high intensity interval training, and activity snacks. This is something new that is being researched. And the case from clinic, as well as a suggested plan. Don't be overwhelmed with all these objectives. It is approximately 20 slides. Okay, so this is a scoping review of population sedentary behaviors. Although we are growing very rapidly in achieving physical activity, but still we are having a sedentary behavior here in Saudi as well as globally. So to define physical activity or exercise, it is any bodily movement produced by skeletal muscles that requires energy expenditure or burning calories. Physical activity refers to all movement, including during leisure time, transport to get and from places, or as part of person's work or domestic activities. And we have to be very focused on this point. Both moderate and vigorous intensity physical activity improve health. These definitions are based on WHO. So there are multiple neurological benefits of physical activity. These are a systematic review that talk about neuroprotective effects of exercise, maintaining healthy brain throughout aging, different physiology, blood-brain barrier, support the neurovascular unit, promote glyphatic clearance and aged mice, rapid regulation of neurotrophic factors, a lot of physiological cell-level improvements. But clinically, they did systematic reviews on Parkinson patients, and they tested it for 10 years, and it showed that physical exercise program, particularly treadmill training or walking, can improve cognitive function and mental flexibility in Parkinson's disease patients. Sleep health. We all know that it affects sleep positively. In this systematic review, they studied a group and they did a moderate intensity exercises, and it showed the positive effect on sleep. Musculoskeletal benefits. So for osteoarthritis patients, we don't tell them, don't walk, don't get into the stairs. We encourage them to walk. This myth of osteoarthritis patient that it will worsen the osteoarthritis is wrong. This is a metabolic benefits as well. It improves dyslipidemia by raising HDL, cholesterol, and lowering triglycerides in overweight, obese adults. I will not continue on these benefits. We all know the benefits, but this is just to take your attention on how important this physical activity is, as well as fertility benefits, of course, multiple. We cannot count them. Okay, so for population awareness, does the population become more aware of benefits of physical activity and risk of sedentary behaviors? There are governmental efforts and campaigns. There are social media propaganda for physical activity and awareness of physical activity. Friends and colleagues talks and encouragements of physical activity. Clinician advice when a patient comes to the clinician office, he's advising them. Hospital admissions due to sedentary life-related illness. Unfortunately, a lot of people does not improve their physical activity unless they are hospitalized. In their 50s for a stroke or for a cerebrovascular accident, then they try to start a change. This observational study studied the awareness of benefits of physical activity on female college students. And even though that was in 2015, it showed a lot of awareness in our population. But the barriers were a lack of designated areas available for physical activity, but not the Islamic or community barriers to physical activity. So when we talk about gym model physical activity, it's an exercise subset of physical activity that is planned on different machines or weight. It's structured and repetitive with final or intermediate objective to improve or maintain fitness. So what are the limitations of this model? So there is a lack of functional training in the gym, in most gym areas. Sophistication and complexity of exercises in the gym. Gym is boring to some individuals. Some say that for most individuals, it is boring. But for a portion, it is amusing and entertaining. But we need to have more choices to meet different tastes. So it has a cost. You need to pay a subscription or to buy the equipment. There is lack of play to exercise choices in the gym. There is misconception of gym as the only way of staying active. This is a randomized control trial in exercise in the Parkour gym. Physiological and mental response to obese people walking in different settings at different speeds. And to conclude, the exercise in natural environment such as parks, it provides better stress relief, restores attention levels for obese young adults compared to gym or indoor activities. So what are the alternatives of gym? Okay, so this is the mainstay of this presentation, the main point of this presentation. I'm suggesting that becoming active or healthy by becoming aware about healthy daily habits that might be underestimated. And I'm hypothesizing that it might be a suitable solution in modern life, in fast-paced life, that needs more validation by further research that we can all try to establish by controlled trials. So first habit is at work, is stairs versus elevators. So this is an elevator company that did a research to convince clients that they need more elevators, but I'm using it in the opposite way. They said that the average user of an elevator tends to take 4 trips daily. So they need to be more comfortable, so provide them with more elevators. But I'm using it, as Dr. Sunil mentioned, when you are standing, you're doing the minimal, very light activity, which is 1.3. But when you are walking the stairs, you are at moderate activity, which is MET4. This moderate activity, if you did 4 trips daily, is equivalent to meeting the requirements of moderate activity weekly. So when we are doing this, we are actually doing an exercise. So using stairs can be a great start for busy people. Other daily habits is standing meetings. I'm humbly asking Hail's committee or other lifestyle medicine committee to think about doing sessions or a couple of sessions while standing. This will enhance focus, will make us more active. So we are meeting the lifestyle intervention goal here. Other habits are ordering online. We are ordering online everything, food, supermarket. Before, elderly were buying the groceries and they were doing squats and they were doing everything. Nowadays, we are aiming at more healthy lifespan, but we are ordering online by our phone while sitting. So shopping, multiple maneuvers needed, kneeling, squatting, stretching, lifting, carrying, going from the car and to the second floor if your apartment or your home at second floor. You will meet the requirement of staying active easily by doing daily habits.
5 minutes left.
Yes. So this is another daily habit is brisk walking to mosque, which is نسلان. عن حديث الرسول صلى الله عليه وسلم أنه كان مشيته النسلان, which is brisk walking. And average distance of 200 meters 10 times, going back and forth from masjid is equivalent to 1.2 kilometers of moderate activity. Phone call or phone meeting while walking. Watching, so this is inspired by Atomic Habit by James Clear. It is mixing bad habits with good habits. So if you have a bad habit, let's say hedonic habit, by watching movies or watching matches, do it on a treadmill. Mix healthy habits with unhealthy habits. This is something that I try to build on in clinic. Instead of asking the patient not to do this, do it in a different way. So this is a new model of physical activity, which is physical activity snacks. This is just last month, published last month. It talked about effective exercise snack on fitness and cardiometabolic health in physically inactive individuals. And it showed that moderate certainty of evidence indicated that exercise snack, it's around less than 5 minutes snack two times a day, is improved cardiorespiratory fitness in physically inactive adults. However, evidence on muscular endurance is still limited. So high intensity interval training, it is time efficient exercise strategy involving short bursts of intense activity alternated with recovery period. I'm suggesting that it's suitable for our fast life-based. Research consistently shows that it delivers significant health benefits across diverse population, include cardiovascular health, metabolic function, body composition, etc. These are a couple of examples that I use. It is very simple. 7 is a type of HIIT application. It has full body training and a paid subscription as well. This is a type of HIIT, which is high intensity interval training. Wake out is more of physical activity snacks. So when you are at the office, you will do a couple of exercises. It will continuously remind you of that. But unfortunately, Wake Out is only paid subscription. Exploring different sports and hobbies, evidence suggests that people with hobbies tend to do exercises much more than people doing it in a gym setting. So we have multiple, I cannot count them. Maybe I need 2 hours counting different sports. But culturally and environmentally appropriate sports include, mashallah, I noticed that a committee did hiking a couple of days back. So hiking is very encouraging sports for our culture. Horse riding, archery, all are in Saudi genes and in Arabic genes. Archery, so this is Ms. Nofal Muteri. She's IBLM certified head of physiotherapy department and a professional archer. She's a role model of work-study life balance. She said archery is challenging art that teaches your mind, body, and spirit to unite with full focus, gathering all your strength and releasing it toward one clear purpose. It helped me develop focus, discipline, and deep sense of mental clarity. It taught me how to stay centered even in challenging moments. And this is a picture that she pictured with after a heavy training of archery with her Snapchat. She told me that after she did the IBLM and did archery for consistent training sessions, her focus is more, and she developed more successful journey. So this is last slide. From clinic, she's an elderly Saudi female. She's a case of osteoarthritis, living in a village without good access to PT or facilities. She does not like to do physical therapy at home or to exercise. It's not in her culture at all. She doesn't have a swimming pool or access to swimming pool. She does not like to ride a stationary bike. She's walking as an exercise, but walking is not beneficial for her quadricep strength that we want to alleviate the pain that she has from osteoarthritis, and she does not want any surgical intervention at the moment. So my only solution that was convincing to her is functional training on stairs, stair climbing gradually with increasing duration every week, with supervision of her son for safety, and they both agreed on the plan. And again, is stairs harmful for OA? No, it's a myth. This is a suggested plan in a busy life. Do a smart goal, specific, measurable, achievable to her, for example, relevant and time-bound. We have to revise our sedentary activities, such as sitting, elevator using, watching TV, ordering online, sedentary phone calls, and adjusting it accordingly. We need to explore hobbies to practice 1 to 2 times weekly. Without exploring and trying different hobbies, we will not know what hobbies we like. And want to do 2 days of full body strength and aerobic training weekly at home or at gym. That was my presentation and references. Thank you very much.
Thank you so much, Dr. Yazid, for the highly informative presentation. So the role of the physical medicine and rehabilitation used to be for secondary preventions, used to see the patients after stroke and after spine injury. Your job is great. You are helping the patient to get back to their baseline or even better. But today you told us about the alternative methods for the healthy guy to live longer and to live a healthy life. So now we are going to move to the virtual talk with Dr. Saud Al-Umar. Dr. Saud Al-Umar is a consultant in pediatric and adolescent medicine. He's a pioneer in workplace well-being program in the Kingdom. He's gonna talk about the navigation of the storm. And without any delay, join me to welcome Dr. Saud Al-Umar.
السلام عليكم ورحمة الله وبركاته. مساء الخير لكم جميعا وشكرا لكم على الدعوة، وتمنيت صراحة أكون حاضر في حائل وبين أهل حائل، لكن الظروف حالت بيننا وبينه، لكن بإذن الله في السنوات القادمة. My talk today is about navigating the storm. All we are in a medical field. We face a lot of challenges, a lot of stressors. Sometimes we acknowledge that we have it, sometimes we hesitate to talk about it. So maybe it's time to talk about some of these challenges, especially the burnout and its complications, its impact on the healthcare providers, and indirectly on the patient, directly and indirectly on the patient safety. We are talking about well-being. Well-being it's a combination of feeling good and functioning well. If you lose one of these two important elements, either not feeling good or if you are not functioning well, that means your stressors is you cannot deal with them in a good way. It means that the stressors are unhealthy, because as we know, there are some healthy stressors that push us and motivate us to work, and other stressors, no, it will not help us to function. Sorry, this Arabic in this slide in Arabic, but just would like to make the proper translation for the word well-being, which is in Arabic العافية. العافية، مصطلح العافية ورد في الأحاديث النبوية بشكل كبير جدا، وكان فيه تركيز يعني عالي جدا من النبي صلى الله عليه وسلم وعلى أهمية على أهمية المصطلح هذا وأهمية العافية، لدرجة أنه ورد في أكثر من 52 حديث. والنبي صلى الله عليه وسلم كان يعني واحد من الأحاديث ما سئل الله شيء أحب إليه من أن يسأل العافية. لم يعطى امرؤ بعد اليقين وبعد الإيمان وعلى عظم الإيمان عظم ما أعطي خيرا من العافية. الحديث اللي أمامكم العباس عن النبي صلى الله عليه وسلم أكثر من مرة، ويأتيه التأكيد كل مرة من النبي صلى الله عليه وسلم أن نسأل الله العافية في الدنيا والآخرة، فإن أحدا لم يعطى بعد اليقين خيرا من العافية، وأحاديث كثيرة في المجال هذا. حتى لما نجي نعرف العافية أو الويلنس دومين، يعني it is 8 or 7 dimensions all mentioned in this hadith. اللهم إني أسألك العفو والعافية في الدنيا والآخرة. اللهم إني أسألك العافية في ديني، أو العفو والعافية في ديني، وهو المحور. دين spirituality, meaning, your meaning in life, your meaning even at work, والدنيا whatever, anything in your life. أهلي، مالي، اللهم استر عوراتي وآمن روعاتي واللهم احفظني من بين يدي. This is 7 dimensions about it. Usually sometimes they call it elephant in the room, something big nobody is willing to talk about, or some people they are hesitant to talk about that. We have burnout. We know not everybody has burnout, but even those who has burnout will affect those who doesn't, and the work will be maybe. So if you have in your organization or even your department like 10 people and 6 of them, let's say 4 of them have burnout and the 6th they doesn't, so the work of this 4, who will do it? Those 6. So again it will affect those who have. These are some data about the prevalence of burnout. Maybe it was first described in 1994 by Herbert Frenberger, who described burnout at the beginning. Then Christina Maslach also talked about it in 1976. When they describe it well, and it has been a point of discussion and a hot point in many articles till maybe in 2025, more than 10,000 articles or even 12,000 articles talking about burnout. We did one study in 2019 on the medical trainees with the response more than 6,600, and the burnout was almost 56. In some specialty, it reaches to 70 and 70 plus. And CDC in 2022, where they investigated more than 26,000 US public health workers and found that 50%, half of them have mental health symptoms. And as you know, even before Corona era, every day, one physician in the state commit suicide, which is the highest rate among all jobs and all occupations. Also in the Saudi pilots, telecom companies, tech companies, a lot of in many other, even nurses. One of the highest healthcare provider who has or who have burnout, it reach up to 50% of nurses. What is burnout? Burnout consists of 3 major elements, which is the first one, physical and emotional exhaustion. Sometimes it's for a lot of reasons. You feel mentally and physically exhausted. خلاص مستنزف، ما عاد تقدر لا تروح لدوامك، تروح صباح وانت تسحب رجليك، ما انت قادر. الشغف، passion that you have is almost lost. You cannot go with the same passion. You have no goal at all. Nothing. You feel that nothing is added. Even sometimes to do. I remember one of the staff. He told me, sometimes I do the work. Everything is ready. But even just pressing a button to send it is difficult for me. I cannot do it. So this is a kind of emotional exhaustion. So if your brain perceives that this area or this workplace is exhausting, it perceives it as a danger. So if this is dangerous place, what the brain will do you will be withdrawn. يكون فيه شوي بعد عن المكان، لأنه يشعر الدماغ أن منطقة خطر. منطقة الخطر usually you don't fight the danger, you just flight. So it is fight, flight, freeze. then you will feel like decreased motivation and performance. Then you detach or get isolated from this dangerous place, which is like your workplace, if it is a source of a burnout. Then your even your contact with your patient, your empathy with your patient will be affected. So as Herbert Friedenberger, he described, he said at the beginning, I feel their wounds is mine. I feel their battles is mine. But after he got himself burnout, he said, I don't care anymore about my patient. So there will be a kind of في نوع من الجمود، في نوع من اللا إنسانية مع الكلاينت، مع المرضى. What will happen next? Even your perceived your self competency, that you are unable to do your work, unable to finish your task, it will end up with this stage. What are the causes? There are many causes, but this is the most important, the most famous kind of cause, which is based on Baker theory, which is job resources and job demand. If there is any like imbalance between job demand and job resources, you will have burnout. For example, if your resources is limited and your demand is high, you will easily get burnout. If you have a good resources and regular demand, your chance to get burnout is much less. What we mean by resources, the culture that you are work in, job control and autonomy. Sometimes you have no control at all. يعني تيجي القرارات بعض الأيام تجي ما عندك أنت أي قدرة على اتخاذ القرار، تجيك بعض القرارات برشوت من إدارتك المباشرة، نفذ وخلاص. حتى في تخصصك أنت أو حتى في الأمور اللي أنت أكثر واحد يفهم فيها، يجونك يقولك والله مثلا كمثال، يقولك والله ما نحتاج العيادة. طيب أنا صاحب التخصص، أنا أفهم فيه أكثر من أي شخص آخر هنا. لا والله ما نحتاج البوليسي هذه، ما نحتاج. فقضية أنك تسلب منك الجوب autonomy and control, one of the most important reason. طبعا electronic health records, electronic health records from the demands. relationship and social support very important, and the support from administration. دعم الإدارة المباشر هذا واحد من أهم الأسباب لبقاء الموظف أو خروجه. Gallup said 70% of turnover or retention of employee is affected directly by the direct manager. 70% من بقاء الموظف أو مغادرته يعتمد على المدير المباشر. طبعا الديماند a lot of things like workload, administrative burden, workflow interruption, and client factor. طبعا please إذا قربت أخلص الوقت let me know please. Those are some burnout causes: long working hours, profession, balance, political, all these things. Causes specific for medical like patient acuity, ethical dilemma, أو emotional demands. يعني زي ما كان في كورونا, sometimes they have very sick patient, you have like 10 or 15 patient, they need intubation at the ER, but you have just like a 3 ventilator or 5 ventilator. You don't know where to give, who is the most badly needed case. So this is one of the emotional, or sometimes in some of the critical cases. Organizational factor like shortage of staff, mandatory overtime, poor communication, electronic keeping, electronic health records. One of the, it helps us, but it's still, it is like affect our patient relationship and time. And poor team dynamics. What are the impact? The impact, I think some of people maybe talk about the impact of stress on our life, but as you know, burnout, it is a kind of stress. So cortisol level will be high. So you might have diabetes, hypertension, high cholesterol level, cardiovascular, musculoskeletal pain, prolonged fatigue, headache. It will affect also as absence and unprofessional behavior, poor quality of care. Sometimes if you are anxious, you will be more angry, so you cannot tolerate others. Maybe your even communication with your patient will be affected.
3 minutes left.
Okay, this is another kind of stress. Client, just joking. Client also will be affected. Your client will be affected. Drop client satisfaction. It will affect the decision making in the prefrontal cortex. So it will affect your cognitive ability to make decisions. So it will lead to more medical error. Maybe this is like decision fatigue or ego depletion or استنزاف الذات واستنزاف القرارات. Maybe there is no time to discuss it. This is a model which is called a stress bucket أو دلو القلق. It is a kind of just to know and self-awareness what level you have now. Do you have a relaxing state or normal state or overflow? Overflow, it means that you are not sleeping well. Maybe you become more anxious, more angry. You cannot. You have some physical symptoms. So this is the symptoms. What are the prevention and intervention strategies? Workplace support, stress management, very important. Building supportive relationship and culture. Setting realistic goals. Sometimes the unrealistic goal or deadline is affecting the employees. Continuous learning and growth. Self-care practice. I think also second victim program, one of the most important things that, and it is one of the GCI now requirement and very important part to be added in the Health Institute. What are the solution at personal level? It is good to recognize the signs of stress and fatigue, seeking support, establish your work-life balance, and take regular also breaks. Maybe there is no time to discuss the work-life balance, but this is the life wheel that we use to assess your different part of lives or different aspect of your wellness اللي وردت في الحديث اللهم نسألك العفو والعافية في ديني ودنياي وأهلي ومالي. You can plot it in this wheel. Very important to be active, to keep learning, also to healthy, basic health needs like healthy nutrition, avoiding toxin, regular exercise. One of my friends or clients, he said I was in a bad mood and my mood, I got depression. And he said I was diagnosed with depression. I could be mild to moderate depression. But he said I was dedicated to the gym every day, like 1 or 2 hours, very vigorous exercise. And also I adapted a healthy habits, adequate sleep, and my life totally changed to better. This is maybe also mindfulness, one of the most important let's say the skills that healthcare provider they should, or let me say they must master and know. Mindfulness أو الحضور الذهني, it is paying attention in a particular way on purpose in the present moment with no judgment. It is a kind of psychological freedom. Let's make it again in Islamic, more Islamic framework. هي الصلاة الخاشعة, الحضور التام في الصلاة. اللهم لك سجدت وبكمت، خشع لك سمعي وبصري ومخي وعظمي وعصبي، كل هذه تكون خاشعة. إن الرجل ينصرف من صلاته لم يكتب له من صلاته إلا عشرها تسعها ثمنها إلى أن قال إلى نصفها. إن الرجل يأتي إلى أحدكم إلى صلاته فيقول أذكر كذا أذكر كذا، حتى لا يدري الرجل كم صلى في صلاته، هل صلى 3 أم 4. ورد الآيات في الآيات آيات كثيرة، إنها لكبيرة إلا على الخاشعين، قد أفلح المؤمنون الذين هم في صلاتهم خاشعون. كل هذه الآيات والأحاديث تؤكد على أهمية الخشوع في الصلاة. لما يكون في خشوع في الصلاة يكون فيه أرحنا بها يا بلال جعلت قرة عيني في الصلاة. تعطيك الصلاة المعنى الحقيقي اللي لما تشتتك مشتتات الحياة تأتي الصلاة في أوقات دقيقة جدا حتى تعيدك إلى التوازن. كذلك الجراتيتيود والامتنان، في تجارب كثيرة على الامتنان وذكر الله سبحانه وتعالى في كتابه العزيز. هذه بعض الابليكيشن للمايندفولنس. أعتذر على يعني I'm sorry for this fast presentation. I prepared it. I thought it's at least 30 minutes. But I realized later on that it is just 20 minutes.
Thank you so much, Dr. Saud Al-Umar, for the highly informative and nice presentations. I know you are in a hurry, and so I'm gonna ask you one questions, and it's from the audience. So, what is the situation of burnout for health professional in Saudi Arabia? Are you aware about any, statistic or evidence published locally?
Yeah, I think a lot of studies, there is no, up to my knowledge, there is no one big study for the all healthcare providers, but the one we did for trainees, resident and fellows, which was in 2019, the burnout was 56%. It depends on the subspecialty. It depends on the level, if he's a trainee or just a healthcare provider. It depends also if we talk in consideration the ER or the ICUs or some specialty, they are more than the other specialties. And also, if we take in consideration the let's say the tool that used, because there are a lot of tools, and the most validated and most important or most widely used is Maslach, but it is unfortunately paid one. And there are a lot of, I know at least maybe 12 scales, different how they interpret it. For example, we did one with one of the scales. It gave us 90%, but it wasn't that. It wasn't accurate. We are there is also 2 item scale. We compare it with the large one of 2 item for the Maslach MBI 2 compared with the original one, and we are publishing this one soon. It's in the other publication. It gives I think 76% sensitivity.
Thank you so much, Dr. Saud Al-Umar. Now I would like to ask our speaker, Dr. Sunail and Dr. Yazid, to be on this stage for the panel discussion. So just a small comment on the last talk from Dr. Al-Umar. Now, the rate of using the antidepressant and anxiolytic is increasing among the healthcare providers, and also for using of those medications for the patients. So we have a lot of things we can do it and to avoid using and prescribe the medications. And medications the end, so we can just advise them for certain lifestyle changes, and they are going to be okay. So moving to the questions, the first question for Dr. Sunail. So it's from the audience. They asked about the caffeine consumptions and its effectiveness on the anti-anesthetic agent response. There is any evidence supporting, in using of the caffeine might affect the response for the anesthetic agent? Caffeine.
As far as I know, there is not very good published evidence on that. But caffeine itself will interfere in your sleep rhythm and circadian rhythm as well. So it's not a good idea to use caffeine as a lifestyle medicine physician, I can tell you as well.
Thank you so much. So before the surgery, and even the need of such operation for the patient, what is the lifestyle changes needed to improve the functional capacity of the patient?
Hello, yeah, it's a very good question. Whatever we are prescribing as a lifestyle medicine physician on nutrition, physical activity, stress management, and sleep hygiene, same prescription, if you keep on doing it for the patients whom you see, who may require surgery in their future life or anything. You are actually building up their functional capacity. As my other speaker was saying about the moderate activity which is needed, which is needed by the WHO guidelines, if you achieve 4 METs, if you do 30 to 60 minutes minutes of moderate activity per week, per day, or 150 minutes of moderate activity per week, that's good enough to take you to that level of functional capacity. And so on an average, if you see the person who lives, there's a global evidence that about 3 to 5 surgeries we have one person in a whole lifetime. Now, if you want to live longer, beyond 80, beyond 100, so maybe the chances of you are getting operations will increase. So earlier you start doing this lifestyle medicine principles and practice and the prescriptions, it's better you are preparing yourself for such surgeries in future.
Thank you so much, Dr. Sunil. So I'm going to move from the lifestyle to your specialty, Dr. Yazid. One of my graduates decided to be a physical medicine doctor because he got a spine injury, and he got impressed about the effect of the physical medicine and his outcome. So after he proceed all the journey of the surgery and physical rehabilitations, he decided to be a physical medicine doctor. So how they can, for the our trainee, what's the physical medicine and rehabilitation program, and what's the subspecialty after that they can join?
Okay, so physical medicine and rehabilitation specialty is very old, since the World War I. After the war injuries, Europeans saw that there is a huge need for such a specialty. So in this specialty, the focus is, let's say it's a mixture of neurology and musculoskeletal. It will handle disabled population. It will diagnose them, diagnose the deficit that comes with disability. For example, the stroke patient will have aphasia, will have a shoulder pain, but what is it? Why? Will have a spasticity, and so we will diagnose it by history taking, examination, imaging, and then we will treat it non-pharmacologically, pharmacologically, interventions such as injections. So the other part is musculoskeletal injuries. And in this specialty, you need to practice everything you can to achieve an outcome. For example, if the patient is having a stroke and he's impatient with us, I will do with the physical therapist, with the occupational therapist, with the speech therapist, everything that we can do for him to be active again and reaching his maximum ability. That's why lifestyle medicine is very important there. So we will control his sleep, better neuroprotective properties, better recovery in neuroplasticity after strokes or any other injuries, as well as other domains of lifestyle medicine. The other thing is musculoskeletal and sports, and everyone knows how performance now is optimized by all these interventions in lifestyle medicine. In regards to subspecialties, there are multiple subspecialties. There is neuro rehab, or we call it general rehab, where you obtain more qualification, but in general rehab. Other includes spinal cord injuries. So everything in spinal cord injury will be subspecialized. Stroke rehab, amputation rehab, sports medicine, as well as other new subspecialties such as like multiple sclerosis rehab and other neuromuscular diseases. I think I answered your question.
Thank you so much, Dr. Yazid. I have another question for you regarding the Parkinson patient. So there is any, evidence-based physical activity to prevent the onset of the disease in the high-risk group patients?
So there are multiple studies on physical activity that it's not on only Parkinson. As I mentioned in my presentation, it showed better symptoms with Parkinson's patient. but as a protective measure, in neuromuscular diseases, it showed that physical activity will have a neuroprotective properties in neuromuscular diseases. So I don't recall any specific protection against Parkinson, but I remember that in studies I read, it's neuromuscular diseases in general, physical activity will have neuroprotective, especially aerobic activities.
Thank you so much. By end of this sessions, I would like to give a big thanks for this High Health Cluster Organizing Committee and for our distinguished speaker. And thank you so much.
We now welcome our honored speakers and moderator on the stage to receive our abbreviation for your meaningful contributions. Now, we will be with the research session. Let me welcome Dr. Marwa Abdel Samad, General Preventive Supervisor for the Public Health Administration in Hail and Supervisor of the Public Health Operations Center, a national trainer certified by the World Health Organization for Rapid Response Team, Ministry of Health, Hail, Kingdom of Saudi Arabia. Please welcome.
Assalamu alaikum. Hello, my dear colleague and my dear speakers and everyone here. I am an honor to introduce the session of research today. It is a great session as always. Let me invite our doctor who will share with us today the research session. Firstly, let me give a brief overview of the work of the research committee in the fourth edition of the High Lifestyle Medicine. The committee received around 170 of research submitted through the website of the conference. Our research committee tried hardly to select the best 20 research from our 170. It was very hard because all the researchers, or almost all the researchers, with high quality, and it makes the work of the committee very hard. Today, we will start to introduce the best 5 researchers and give them the chance to introduce their work as an oral presentation to choose the best 3 researchers represented to the research committee today. Try to share with us the selection of the best 3 researchers. Now we will start with Dr. Said. Let me introduce the first researcher today, Dr. Said. Dr. Said Amir Ashraf, ranking among the world top 20% scientific research. He is a faculty member of Ha'il University as clinical nutrition. His researches focus in nutriculous function, food, and food safety. Dr. Said, by the way, is the winner of the past year of our research award. Let us greeting Dr. Said.
Assalamu alaikum. A very good afternoon to all the eminent dignitaries, researchers, and faculty members and students present over here. Firstly, I'd like to thank the organizers and the convener of this conference who provide me the opportunity to present my research findings. I am Dr. Said Amir Ashraf from the Department of Clinical Nutrition, University of Hail. The topic of today my presentation is there is one compound that is food bioactive which extracted from the Eureka sativa that is also commonly known as jarjir in Arabic. So we extracted this food bioactive compound uracil from this jarjir, and we checked the modulation of oncogenic pathway in triple negative breast cancer, which help to support the healthy longevities. In addition to that, why this research is particularly very important? Because this triple negative breast cancer is one of the aggressive subtype of breast cancers. And what the problem that it lacks the receptors, which is estrogen receptor, progesterone, and here HERA1 receptor. So it makes the problem for the therapeutic targets for the exact treatments. So in that case, what happened exactly, which makes the treatment difficult, and in this TNBC, the recurrence are more likely and survival rates are very poor. So for a young woman who still have the long productive years ahead, TNBC poses a major threat to the healthy lifestyle. Therefore, identifying a safe food bioactive compound that can help prevent and suppress the TNBC development is highly valuable. So as we know that cancer is a very growing, cancer is a leading cause of death worldwide, which is accounting around 10 billion deaths in the year 22. And as per the prediction, there will be more like 27 million by 2050. As per the records, as per the incidences case in Saudi Arabia, which is also increasing by 136% in the year 1919 to 2015, which is projected to increase by 63% by 23. Among the different type of cancers, the breast cancer has surpassed in women, and in 2020, the 2.3 million women were diagnosed with breast cancer, and 670,000 deaths occur globally. So to understand the breast cancer, we have to first understand the various stages of breast cancer development. If you see, it starts with the abnormal cell growth, and then there is a tumor formation. And if this unchecked tumor formation occurs, so it is spread throughout the body, which cause the metastasis, and the final, it may cause to the fatal outcomes. So usually it is very important to understand, because to analyze the therapeutic approach, we have to understand the stages of each breast cancer stage. Based upon that, we can apply the therapeutic targets. Thereafter, these are some of the factors which contribute to the breast cancer. There are some factors which we consider as a modifiable, and there are some factors which we consider as a non-modifiable factors. So modifiable factors such as diet, obesity, and physical inactivity, nowadays it is a very common because of different lifestyle, because of changing in the urbanization. What we have a problem in the eating habits as well as the lifestyle. So this is recently in 2022, there was a data published by Saudi Cancer Registry which suggests that the women who are in the age group of 30 to 44 years and those women who are in the around 45 to 59 years, they have the high incidence rate of breast cancer compared to the other cancers. Even if you see the all ages group, in the females, the 31%, which is again very high. So considering the fact that the incidences of breast cancer among the women, it is surpassing even the lung cancer, our objective was to identify some food bioactive or natural food product which can be utilized to prevent, to delay or suppress the oncogenic pathways for that TNBC, that is triple negative breast cancer. So this is a small description regarding the TNBC, that is triple negative breast cancer, which is an aggressive subtype of breast cancers, and it is very common in younger women. This TNBC is very common in younger women. That's why it is very urgent need for the society to develop a research program to make sure that we fulfill this criteria. So among the various food, this is a very commonly eaten food in the kingdom, even in Hail, this is eaten in the salad as a salad. So it has a very important food bioactive that is called uracil, and this uracil has a very promising approach in suppressing or modulating the TNBC markers. So here, so in the objective, what we did, we apply an integrative approach. We apply two methods. One is computational and experimental validation. In computational validation, we made a network pharmacology. We apply the molecular docking and dynamics. And thereafter, after the prediction of all the protein targets, then we make the experimental validation, where we did the in vitro cytotoxicity, apoptosis assays, and cell cycle arrest. And in computational methodology, actually, we try to identify the marker. Actually, in TNBC, there are many proteins which is involved for causing the breast cancer. But with the help of this identification of potential target, with the help of software, we receive around more than 3,000 proteins. But based upon the second one, the hub gene identification, finally, we receive around 10 proteins, which is our target, which is responsible for TNBC cancers. Thereafter, we perform the enrichment, gene ontology analysis, and cache pathway. And furthermore, we perform molecular docking and the simulation process. In the experimental validation, we perform these three tests, that is a cytotoxicity test, then we perform apoptosis test, and the cell cycle analysis to understand the nature of the compound, uracil, as well as the protein what we utilize. So these are some of the results. This is the target predictions related to the protein. If you can see in the left side, in the Venn diagram, there are 6,000 protein which is responsible for the TNBC breast cancer. And when we apply with the uracil, so we finally, in the mutual, we find around 84 protein targets which can be targeted with the help of uracil. And in the right side, which you can see, this is the network pharmacology structure which identify, if you see in the center, there is a compound that is uracil, which we derive from the Eureka sativa or jarjir. And these are some of the proteins, okay, which is responsible for causing the TNBCs. This is another computational approach. We call it GO, that is gene ontology, and we perform CAGE pathway. This analysis actually enables us to understand the molecular mechanism behind the uracil and how these 10 protein react with these pathways. So if you can see in the right, there are 4 rectangles which indicates the biological process, cellular components, molecular functions, and the last one, that is pathway analysis, means how it reacts with the uracil, all these 10 proteins. Thereafter, this is a figure. We actually targeted the 10 proteins. Out of 10 protein, we received the molecular docking result of 3 protein, which shows the highest affinity. Usually what happens when we perform the molecular docking, we analyze the result based upon the binding affinity. If we have a binding affinity more, so all these 3 protein, if you can see AK, T1, STAT3, and PTGS2, these 3 protein receive the highest binding affinity. So furthermore, we did the simulation part, which is not included here in the slide, okay, for the further analysis. So how long it is binding, for how many nanoseconds we bind this protein for uracil target. Thereafter, we perform the cytotoxicity test. So this cytotoxicity test we are done with the help of MTT assay by using the MDA-MB 231 cell line. This is a cell line which we apply, and the concentration of uracil we apply from 0 to 100. If you can see from the bar graph, when the concentration of uracil we included or increased, the cell viability were decreasing from 100 to it was decreasing less than 25 microgram percentage viabilities. Thereafter, we did perform that apoptosis detection by NXene. This is a test where we perform flow cytometry. With the help of flow cytometry, we analyze how this uracil can help to reduce or to process the cell of cancer cell in terms of life, in terms of early apoptosis, late apoptosis, and dead apoptosis. Means in all 3 situations, we receive a very good result when we compare to the uracil with the control one. Thereafter, this is the last experiment we performed, that is cell cycle arrest or cell cycle analysis. Here, actually, we perform all the 4 cell cycle, which is G1, S, and G2 and M. These are the all phases of cell synthesis. So we try to check that the live control cell, and when we perform with the treatment, so how this treatment react with the uracil and along with the control groups. So in final, based upon the results, we find that uracil provide a very promising approach. Yes, uracil provide a very promising approach to be further analyzed for development of food processing. Uracil can be applied for the nutraceutical and functional foods. At the same time, it needs to be a collaboration between the food and pharma industry to make sure that how this food bioactive compound can be utilized for further development in the nutraceutical forms. So, and in the last, if you can see that the food scientists, nutritionists, and food industries can improve the utilization of this nutraceutical uracil for the nutraceutical and functional food purpose. So these are some of the references we take for preparation of the slides. Okay, thank you so much. Yes. If you have any question, please. Yes.
Anyone have a question for Dr. Syed?
Thanks, Dr. Syed, for your nice, mashallah, presentation and nice outcome.
Thank you so much.
My question regarding the uracil itself, the amount of uracil that extracted from the gergeir.
Yes.
How much? Yes, the amount itself. We need to extract a lot of.
Actually, what we did in our previous article, we performed the HPTLC experiment. Usually, the amount we receive is a very low. Okay, because the process of extraction with the solvent extraction, what we did, thereafter we performed the HPTLC analysis. The quantification what we made in terms of the uracil, that was around 5 microgram. But here, when we apply the standard uracil to make sure to compare how the apoptosis go, how the cell cycle arrest perform, and how the cell viabilities goes. This is the way what we did for this experiment.
دكتورة.
Thank you so much, Dr. Said, for your presentation.
Thank you,
I
Dr.
want to ask you why uracil. Did you test other food or vegetable extracts and compare it with the result of uracil, or you just tested uracil?
Sorry, I didn't get your question.
Did you test any other food or vegetable extract by the same methodology?
Till now,
On
we have not extracted. We are working on this jarjir only, so we are focusing on this only. But we are now in the future plan, maybe we can try some another cell line as well as some other food product which is naturally available. And actually, there are many cruciferous vegetable, we say it, like maybe we can say some cruciferous vegetables which has isothiocyanate compound. So we try to investigate that isothiocyanate compound if the isothiocyanates are there, like a broccoli. So broccoli has isothiocyanate compound, and this jarjir, it has also isothiocyanate compound. So if we try to investigate in TNBC, we will first focus on isothiocyanate compound based upon the library, based upon the further future previous experimentation. If we find the isothiocyanate compound, then we can perform this uracil in compare with the other molecule or other food bioactive compounds.
Thank you so much.
Thank you, Doctor.
Okay, thank you, Dr. Said, and wish you good luck. Allow me to warmly welcome to the research judging committee. They are here in the first row. I would like to also to extend a special welcome to Director of the Ministry of Health, Mr. Sultan Messiaid, who was keen to attend this session today, reflecting his strong belief in importance of the researches. Welcome, Mr. Sultan. Let us go to the second session. Our second researcher, Dr. Humira Banu. Dr. Humira is Assistant Professor of the Department of Clinical Nutrition at the University of Ha'il. She beginning over 20 years to work an academic and clinical experience. She also play an active role in the curriculum development and accreditation process and supervision of postgraduate and undergraduate program in Ha'il. Welcome, Doctora.
Assalamu alaikum, everybody. First, I would like to thank the Ha'il Lifestyle and Medicine Conference and the scientific committee for shortlisting our research and allowing us to present it here. So today our research is about assessing the mindful eating and behavior and its association with weight, diet, and lifestyle. This is actually a postgraduate project which we has done. Unfortunately, she's not available to be presented, so I'm presenting it on her behalf. Okay, so introduction. Mindful eating focuses on understanding how and why eating behavior occurs rather than simply what is eaten. It encourages individuals to be aware of their hunger, fullness, emotions, and their triggers that influences their eating behavior, so they can fully recognize the reason for eating and type, amount of food they consume, and truly savor its flavors. This awareness can support better weight management, reduces overeating, and promotes healthier long-term habits by helping individuals recognize the satiety clues and resist external or emotional prompts to eat, such as boredom, advertising, or anxiety. Okay. In contrast, we also should know what is mindless eating. It occurs when a person is distracted and unaware of what or how much they are eating, which can contribute to overeating, overweight, and obesity. Because mindful eating skills can enhance control over eating patterns and reduces unhealthy eating behavior, learning this skill is important. However, mindful eating behavior in Saudi Arabia has not. So the main objective of the present study is to explore the mindful eating behavior and its association with status and with the physical activity among the Saudi population. So in this study, we have selected 400 subjects, okay, and then we have used the mindful eating scale to check their mindful eating response to different domains like disinhibition, awareness, external clues, emotional response, and distraction. And we have also checked what are they eating, how healthy their diet is by using a healthy eating index. Okay. The demographic profile. In the study, we had most of the population were from the females, that is 83%, and only 17% responses we got from the male. And when we see the age, the average age was between, in the females, it is 27 and 32. That indicates that most of the subjects were from the young adults. Then, regarding their education, most of them were graduates and most of them were not employed. And we did not find any significant association between education and their employment status regarding the mindful eating. Regarding their income, most of them belong to income less than 5,000 and most of them were single, and we did not find any association between their education status or their marital status and the mindful eating scores. So they don't influence them. And regarding the anthropometry, we have seen that most of the BMI is within, in males it is 25 and in females it is 26. And regarding the nutritional status, we have seen that majority of them, that is 51%, were having healthy weight, and 26 and 17% were either overweight or were obese. And we did not find any significant association between the mindful eating scales and the nutritional status. Then regarding the different domains, when we compared with the different domains, overall the scores were similar in both the genders, but we tend to find significant difference in their disinhibition and the response to their emotions. We see that the scores in the male were higher and in the female they were significantly less. This indicates that the female have disinhibition, that is they don't have a control over their eating and they tend to eat responses. And overall, we did not find any difference between the genders. And among males, the awareness score and disinhibition scores were higher and compared to the females, and they are not likely to eat in response to their emotions. Males were not related to eating to response of emotion. And whereas in females, there is disinhibition scores were high and emotional scores were significantly high, which tends to show that they have a control, they lose control while eating, or which tends to contribute to the prevalence of obesity. When we compare to the eating habits, it showed that 90% of the Saudi population demonstrated high mindful eating, and 68% showed moderate, and 12% showed poor mindful eating behavior. This highlights that there should be gender-specific strategies and behavior intervention for the females. And this is their scores for healthy eating. And we did not find any difference between the males and females scores. So that means they all are eating healthy. And regarding the physical activity, we have observed that most of the participants, only 40% exercise daily, and nearly 42% did not do any exercise. So the physical activity is very less among the Saudi population. This may be one of the reasons for the contribution of overweight and obesity in them. So insufficient mindful eating practices combined with poor physical activity level may contribute to overweight and obesity in this population. Promoting mindful eating may enhance healthier dietary behavior and support sustainable weight management. And daily mindful eating is linked to greater weight loss and helps in maintenance. And mindful eating fosters non-judgmental, positive relationship with the food. It encourages savoring food, trusting personal judgment, and living fully in the present. So thank you. Any questions?
Thank you, Dr. Humira. Any question from the committee, the judgment committee? Any question for the doctor?
Thank you, Doctora, for your great presentation and great work. My question is there any clear exclusion and inclusion criteria for your research? Exclusion or inclusion criteria?
We have used inclusion-exclusion criteria is we have choose only the young students without any disease condition. Okay, and the age group was between 35, 18, above 18 and below 35 years.
Regarding the BMI, Doctora? Nothing regarding the BMI?
Nothing regarding the?
BMI or weight?
BMI was there. The males had 27 and the females had around 25, the BMI.
Thank you, Doctor.
Okay. Thank you.
Thank you, Dr. Humira. We wish you good luck. The third research in our session, Dr. Ammar Tonkel. Dr. Ammar is certified as lifestyle medicine physician whose career mission has been shifted the health care from the medication first aid approach to an opportunity of lifestyle transformation. Serve as Executive Director of the Cooperative Association for Health Promotion and Quality of Life 234 as a president. He is a Medical Director of Lifestyle Medicine Physician, Sarwat Medical Center. He was the president 2021. Welcome, Doctor.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the scientific committee for giving our team the chance to present our paper and our experience in this really marvelous and exceedingly our expectation every year. So our paper is actually done by the main authors, and I'm just one part of the team who did a bit of the work, and they're giving me the opportunity to present here in front of the judgment committee. So our paper or our experience is about the integration between multiple models, the in-person and digital for lifestyle improvement. It's a review of this experience was started 6 months ago. So the main authors are Dr. Al-Mamoun Badahdah and Dr. Abdulaziz Al-Ghamdi. They are the main brain and muscles behind this project. So this paper review an innovative and integrated operational model developed by a developmental non-profit association. Our aim was to achieve sustained behavioral change. So the new model in lifestyle medicine is not about only the outcome, the change in BMI, the change in hemoglobin A1C, and not only to reverse disease, but to obtain new or sustained habits, even if the magnitude of this habit is small, but it will be augmented with the repetition and improvement. So it will take 3 phases. The first phase is direct interaction, and we aimed at, just not the general population and social media. No, it's a direct in-person interaction in order to shift the beliefs and to understand, what's missing or what's deficient in their lifestyle. And it's followed by motivation and the asking to commit, or they assess the readiness to commit, and with the help of the social support that sometimes we try to commit to the changes. Then we culminating this into healthy lifestyle habits. So the objective was to establish a robust framework that leverage both human connection and technology to ensure the continuity of healthy habits. So according to the statistics in 2021, more than 70% of our population does not meet the WHO requirement for moderate activity, and more than 50% are sedentary. And more than 95% of our population, in a study done by the Ministry of Health, do not meet the required fruit and vegetables. So sometimes small changes will make a great impact in the future. So our aim was not the diabetic, not the morbid obese, or in the disease state. We are targeting those persons with bad habits or insufficient healthy habits in order to recruit them into these trips or events or multiple competitions that really reshape their ideas about lifestyle and changes through stations and through real-time or real-life implementation of some aspect of lifestyle changes. So we did a video, but for the sake of time we're
حاسس إن عاداتك الصحية خطأ ونمطك ملخبط.
So our target was also in the children group, and just make some small changes and let them track their streak along with, maybe if we've done it for 5 days or 10 days, so they will come each day, they will implement this habit in-house and in their house. So in the event and in their house, in order to see the changes with the lifestyle and its impact in their health. And we did a trip. We rented an entire farm, and there was a station. One of them was to measure the BMI, blood glucose, blood pressure monitoring. Then there is multiple stations, one dedicated to diet, one dedicated to the sleep, stress management, and physical exercise. And there was real-time implementation of some also of the social connectedness and seminars. So this was the hook. So we want, a call to action. So we want to hook the person who does not have or do not have enough healthy habits in order to commit and sign the commitment. So our methodology to ensure in-person interactive event to serve as a strong starting point, such as meeting or force or focus trips, to impact then maintained and scale through a proprietary custom developed digital platform in order to ensure support, motivation, and competition. So we have a lot of models that we based our intervention on. And we ensure, first of all, the autonomy. So the person the one who lead the healthy habits, and there is a lot of options in the platform. And then he will track this and collect a lot of points, and that point can be redeemed by discounts or free activities. And then there is also group support, special coaching, and also workshops. So there has 3 applied features. So adhering, nurturing through constant reminding through WhatsApp, and then the continuing tokens and the implementation of the streak. And then after that, this technology or these tokens can be used for activity, and that will augment their continuity of this habit. And after that, and sometimes we do some brief challenges in order to collect more points, and then we see it can be seen as on hour-by-hour basis and who's on the top, so to encourage more sticking to these habits. And then the remote healthcare or telehealth, that provide really a broad variety of intervention and help and support to these individuals. So he can enter and he can track everything, and he can also add more habits and more tracking of his meal, intermittent fasting, activities, a lot of the features that needed for lifestyle medicine. And also we have the provider as well. The provider can enter the participant or the file, and he can suggest some lifestyle changes according to the progression of this person in order to encourage them. So we achieved, a good number initially, and we demonstrated that this approach is feasible and it has reach and engagement with a lot of entries or registered habits. And there is a lot of limitation, the cost, the ability to reach, to organize this event in order to funnel the person for the platform and continuing care and habits. And so that's why we're trying to develop this model into integrated voluntary work from doctors and physicians and lifestyle medicine physicians. And then we're going to transform this web-based platform into an app. So in conclusion, we observed that we reach really engagement and visibility. And I invite all of you to sign the نمط charter or ميثاق نمط in order to optimize the lifestyle. And special thanks to جمعية نمط عز الحياة الصحية, where we build the healthy habits. And thank you very much for your time.
Thank you, Doctor, for amazing presentation. Any question from the judgment? No question. Thank you. Dr. Bandar, you have a mic? But quickly, for time management.
Okay. Excellent application, excellent presentation. We have just a question in regard of how did you validate the scales and that measures, the application output, plus we don't understand how many participants did they try this application, and what is the results compared to the others?
So
perfect application is good. There are similar applications. That's why we want to know the significance and the importance of this application, like comparing to others.
Yeah, so the model is not only about the apps. So it's, the event that can change the mindset in order, the app is just, a tool in order to optimize or to ensure, he will stick into habits. So we don't want more people into the platform. We want more real-time or real-life intervention. So it's just in the beginning for these events and the platform, just to assess the visibility, the engagement, there is a lot of limitation for the time being, and we're developing more and more solutions in order to ensure that, it's feasible there is also questionnaire, validated questionnaire that can, whenever we can give it to the patient, and we can, measure the vital signs, and it can be followed up inside the app. There is a lot of features. There are also vendors side, so it's really integrated. But we are in the first phase, and we need, time to reach, inshallah, the needed impact.
Thank you very much. Good luck.
Thank you, Dr. Ammar. Let's go to the fourth research for today, Dr. Sahar Nisa Hassan. Dr. Sahar is an associated professor in the Department of Public Health at the University of Ha'il, Saudi Arabia. She was extensive work experience in psychology and instructor as a researcher. She worked as a spans women's health, disability studies, and culturally adaptation intervention across her work. Welcome, Dr. Sahar.
Bismillahirrahmanirrahim. Thank you very much. It's been now 7 years I'm living in Ha'il City, and therefore I hope that you will allow me to begin my presentation as a traditional Ha'il resident. And I have seen that always they start with Salat, so I will say, As-salatu was-salamu ala Nabi al-Kareem, Ya Sayyid al-Mursaleen, Rahmatul lil Alameen. My dear colleagues, esteemed conference organizers, my research fellows, and most importantly, my dear students who are today here on my request, not only to learn, but also to support me here. So it's a very, very grateful moment for me to be here and to present my research work. I believe that these platforms are very important to promote research, especially the local research. And I am very, very much grateful to the Scientific Research Committee for providing this platform to share the findings from one of our most recent work, and it is from the city of Ha'il. And it is indeed a great honor for me and for my research fellows, because research is always a teamwork, it's never a solo work. So I would certainly like to thank and appreciate the efforts made by my co-researchers, research fellows from the College of Public Health and also from the University of Leicester. And we together worked on this project. I hope that today my presentation would add some valuable insights about the prospects and the barriers to implement lifestyle interventions. And I can see there are many experienced clinicians, there are many seasoned researchers, and then many young professionals who are very much committed and dedicated to improve health and well-being through lifestyle interventions. Therefore, it is the right time to see and identify what are the factors, what are the prospects, what are the barriers actually to translate all this theoretical work into actual practice. And with this focus, and this was the rationale behind this work. I believe for the past 2 days, and even in fact, for the past few years, there is now enough background that determines the urgency for LSM interventions. There is no doubt. We are hearing several speeches and we are reading several research papers. You just go on the Google Scholar, make a single click, and you will find number of papers that are citing about the high burden of chronic diseases, especially in the Middle East region, Saudi Arabia, and then globally. So there is no other time that we can justify the urgency for lifestyle interventions, and it is the very right time that we need to talk about it, certainly. The COVID-19 pandemic was a very insightful pandemic itself. Why? Because we learned many things from that. We found that how the lifestyle factors were related with increasing the risk for infection And not only it increased the risk for infection, but it lead to the negative outcomes in form of prolonged hospitalizations and high mortality rate. Therefore, there is certainly a need for scalable preventive strategies. It is now unquestionable, and the answer is very simple, is that lifestyle medicine. I would like to appreciate the very timely response made by the Saudi Ministry of Health. I believe the way the Saudi Ministry of Health is now very active and proactive about promoting lifestyle medicine in Saudi Arabia, and certainly the Ministry of the Office of Ministry in the Hail region is taking more initiatives. And the last 4 conferences in 2022, 23, 24, and now in 25, they are the clear evidence that how much effort is being done by them to promote health and well-being in the community. When we talk about lifestyle interventions, they are not one factor that are impacting. There are multi-level drivers. There are multiple factors. I'm not going to talk about the details of it, but I would just like to refer back to the talk made by Dr. Khalid in the first day of this conference, when he said that it is not a question that lifestyle medicine is effective or not effective. The question is now how to sustain that behavior, how to sustain that healthy behavior. And we all understand the psychology literature, the sociology literature, all have clearly explained that there are multi-dimensional and multiple factors that are actually then determining whether the people will change their behavior and then how likely they are going to sustain that behavior. Actually, the findings which I'm going to share with you today is just a part of the preliminary findings from the part of the bigger project. This proposal I developed about a year ago, and the focus was that how to have a multi-pronged strategy, not only to focus on one target population, because lifestyle medicine is multidisciplinary. So the focus was to see how the healthcare workers are contributing to it, how their own health behaviors are then going to determine patient education. Then the focus was to see the students who are right now in the medical schools, in the nursing schools, what are their health behaviors, what are their current knowledge, and then also the general population who then have to implement this. So aim was to assess the awareness, interest, resources, and the barriers to the lifestyle medicine. I'm not going to go into the detail, and I would come to the main findings. The design was cross-sectional. The study was focused to the Hail region. And we all know that Hail region is known to have high literacy rate, and the internet access is also available, so it was easy to conduct the online cross-sectional surveys. And I'm not talking about the old times. I'm talking about the data which has been collected just 3 months ago. It's not an old story. It's a very, very recent story. So I will just quickly describe the demographic background of the participants. Although the sample size is only 231, but because it is based upon the preliminary analysis, and we could see that there's an overrepresentation of female participants. Most of them were Saudis, and then most of them were educated and not employed, but they have other income resources, and it could be due to the higher representation of the female participants. We also asked them about their health conditions, and there were around 30% of the people with chronic health problems, and 30% of the people with different health problems, and among that, 9.9% had chronic health conditions. We were interested about their nutritional behaviors. All these items can be considered as unhealthy nutritional behaviors. And I would just like to start with something positive rather than negative, because it's always good to be optimistic. And we could see that the packaged frozen foods, the highest percentage was that not consumed by the people. So this is a good sign. And then we could see the second highest thing, around 1/4 of the people do not consume salty snacks and the fast food. So I would begin with the positive, but yes, we can see that there are many gaps and we can address them. Related to physical activity, 32% of the people do it 3 or more times in a week. So I will again start with the positive, but yes, certainly we have to cover the gap of 20%, which is none. Related to the sleep problems, around equal proportion of the people are suffering from the sleep difficulties. However, 27% say that they have 3 or more times per week sleep difficulties. We are all the time talking about the use of digital tools, but it is very important that how much the people are ready to make use of these digital tools which we are introducing. So this is a very direct question and very direct answer. And it's always, we have to see that just 27 or 25 and 18%, so 1/4 of the people are actually not using these tools. We looked into the difference between the people who have health problems and who do not have health problems. And unfortunately, there was no difference. Okay. So we can see that, I will just quickly cover the last slide. Okay. Okay, thank you very much. I would like to conclude with a point that there is a lot of reflection points. We are talking about lifestyle interventions, but we have to see that whether these practices will be transformed into actual behavior or not. If we are not practicing what we are preaching, we will always be struggling. Thank you very much.
Thank you, Dr. Sahar. Let us go to the fifth research for today and the last research in our session for today. Dr. Nagla Abdulrahim Muhammad Ahmed. Dr. Nagla is a consultant of preventive medicine at Infectious Prevention and Control and Public Health, Directorate of High Cluster, Deputy Director of Saudi Preventive Medicine Board Program in Ha'il. She also works as Associated Professor at Al Zaim Al Zahrani University, as a Faculty of Medicine Director of Medical and Health Education Development. Hello, Doctora. Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for the scientific committee for choosing our research among top 5 researches presented to this nice and amazing conference. Our research is is a fruit of efforts of more than 40 researchers, all from all over the world. So I'm just an honor to present on behalf of them. Key lifestyles and interim health outcomes for effective interventions in general populations. This is a network analysis of a large international observational study. So, first of all, I would like to acknowledge my colleague at University of Hong Kong, represented by Dr. Daniel E. Tak Fong, for supervising this survey and for providing collaborative opportunity for 44 researchers from 30 territories from all over the world. 5 Arab territories voluntarily participated in this survey through their respective university. From Sudan, Zaim Al-Azhar University. I'm from Saudi Arabia, Majma University. From Egypt, I'm from Libya, and from Lebanon also. This research did not receive any specific grant from any funding agency. Background. You know that the interconnected nature of lifestyle and interim health outcomes implies the presence of the central lifestyle, central interim health outcome, and bridge lifestyle, which are yet be determined. Modifying these factors hold immense potential for substantial positive change across all aspects of health and lifestyles. We aimed by this research to identify these factors from pool of 18 lifestyle factors and 13 interim health outcomes while investigating potential gender and occupational difference. The methodology of this study, it was an international cross-sectional study, convenient sampling from 30 countries all over the world, which were strategically selected to ensure representation from all 6 WHO regions and diverse economic development levels, thereby to enhance the generalizability of the findings of the research. Data collected through online survey platform, participant age 18 years and older, who voluntarily completed the survey in their preferred language. So this survey translated to more than 15 languages all over the world. It surveyed to Arabic language by the 5 countries researchers contribute in this research. Participants rated the changed lifestyle factors and interim health outcomes during the coronavirus disease compared with pre-pandemic using Fish-Likert scales. These are the 18 lifestyle areas. And these are the 13 interim health outcomes. Statistical analysis of this research was by innovative methods. It used a network analysis, which you know it is well-known analysis in the psychopathology research, but it is not yet well used in a health research. It visualizes each variable as a node and connect them with an edge which depicted the relationship. 3 networks were obtained: lifestyle network, interim health outcome variable network, and bridge network, which linked them together. Nodes represented items in the network, and the edge depicted the relationships. Our results from 19,145 received responses, 16,512 were eligible for analysis. This is a graphical distribution of overall sample from whole of the world. You see, USA, Canada, and Brazil, Chile, here, Libya, Cairo, Sudan, South Africa, also Rwanda, Saudi Arabia, Lebanon, Australia, China, Philippines, and so on, from 30 countries. Here is a network structure of lifestyle. You know that the 3 largest H, if you see, was from L. We found that L5 and L6 and 7 having a meal at home and cooking at home, the largest H through the network of lifestyle. L13, L14, no. Less duration of sitting, less duration of screen time, and also this is a network of structure of interim health outcome. The largest H was H6 and H7, less mental burden. The bridge network was L18, which is the overall amount of exercise exhibited the highest bridge expected influence among the 15 lifestyles. The statistical analysis expected the influence centrality index for variables. The central variable was decided by the expected influence centrality. In lifestyle network, the central variable will found consumption of fruit and vegetables with less sugary intake. The centrality is 0.98. In health outcomes network, the interim health outcome network, the centrality found with quality of life and less emotional distress. In the bridge network, the centrality bootstrap difference test confirms that overall amount of exercise significantly surpassed all over the notes, indicating its great ability to influence all interim health outcomes. Is there any difference in the network between male and female gender difference? No, there is no significant difference were found in the network, and the centrality of the aforementioned key variables within each network between males and females, the p-value 0.8, or between healthcare workers or non-workers, the p-value 0.57. The key findings: consumption fruit and vegetables and reducing sugar intake are the most influential lifestyle factors significantly impacting overall health. Exercise emerged as the strongest lifestyle factor associated with all health outcomes, underscoring its critical role in enhancing well-being. Quality of life and emotional distress are central health outcomes, reflecting their importance and physical mentoring. What is the key message from this research? Consumption of fruit and vegetables is important. Less consumption of sugary drink, quality of life, emotional distress, and overall amount of health. This is the central key variables in lifestyle to be targeted and to allocate your resources for the those who is in charge in planning, and those for limited resources, especially in the developing countries. This is a limitation of the study, and the study was published in National Library of Medicine. You can find the whole study here if you make this barcode. And I am only just one of the 40 researchers, and it is an honor to me to present on behalf of them this research. Thank you very much.
Shukran, Dr. Nagla. Dr. Nagla was the last author with us today in our session, and let us now to pause for a few minutes, very few minutes, as we await for the decision of the judge regarding the top of the 3 research center research for this year's in the lifestyle medicine of Ha'il conference. And few minutes, and they gave us the results. And now we would like to invite Dr. Really, was a very hard moment for our committee for choose the best 3 from the best 5, from the best 20, from the best 70. I think from the 170 submission research, it takes a lot of time and it takes hard feeling because all our researches was very nice work. I thank you today. We see the work today was very amazing to find researchers concerning deeply in lifestyle medicine and mostly concerning with Ha'il work and reflecting the activity of Ha'il work and also concerning especially the support of حائل University to support the researches concerning with lifestyle medicine. حائل University, as from the first version of the conference, was main support for us and the main support for the committee of the research and the committee of the scientific committee as a whole. We are waiting now for the head of the Ministry of Health branch to join us to announce the first three ranking or first top three researches for today with Dr. Mishal al-Nais, the head of the scientific committee of the conference. Mr. Sultan will join us now. And through this moment, I would like to thank my committee. They do great work in a few time to review all these researches, and we are appreciate their work and appreciate their time. We appreciating your patience and support for waiting, but for more suspense. Where is the five researchers? Dr. Sahar here, Dr. Nagla, where Dr. Said? Dr. Said, Dr. Amgad, Ammar, Dr. Ammar, sorry, Dr. Ammar. Sure. Dr. Hamira. We would like to make some suspense, academic suspense. Today also we will honoring the best 20 research nominated as posters. I think many of the audience visit our research corner here. The research corner in the left side. You can find 20 researches. And today also we have a special honoring for a special researcher. We will announce the special researcher at the end of the session. Through this moment, we can, our committee, judgment committee, can introduce yourself. You have a mic? Introduce yourself.
بسم الله الرحمن الرحيم. دكتور إبراهيم قناوي، الصحة العامة، تجمع حائل الصحي، إدارة الصحة السكانية.
السلام عليكم، مساكم الله بالخير. الدكتور عبد الرحمن بومدين درقاوي، مدير إدارة الصحة السكانية في تجمع حائل الصحي. نتشرف بحضورنا اليوم ومساعدتك في الشغل هذا. شكرا.
السلام عليكم، دكتور خالد الشغدلي، أستاذ علم المناعة المشارك في كلية العلوم الطبية التطبيقية جامعة حائل، وكيل كلية العلوم الطبية التطبيقية للشؤون الأكاديمية حاليا. شكرا لكم.
السلام عليكم، دكتورة مروة حسني، قائد نظام رعاية الأمراض المزمنة من نموذج الرعاية تجمع حائل الصحي.
الدكتور علي المميز، فرع وزارة الصحة منطقة حائل، رئيس لجنة مخالفات القطاع الخاص.
دكتور عبد الله الخلف، استشاري طب الأسرة واختصاصي في طب نمط الحياة، حاصل على شهادة البورد الأمريكي لطب نمط الحياة، قائد نظام الحفاظ على الصحة في نموذج الرعاية السعودي في تجمع حائل الصحي.
دكتور بندر السيف، أستاذ مشارك تخصص الصحة العامة، استشاري صحة عامة، جامعة حائل.
علي فارس التبيناوي، صيدلي كلينيكي في علاجيات القلب، مدير صيدلية مستشفى الملك سلمان التخصصي ومركز القلب، ومشرف الخدمات الصيدلية بتجمع حائل الصحي، وأستاذ متعاون في كلية الصيدلة بجامعة حائل. صراحة أنا ودي أضيف نقطة، أنه أتقدم بالشكر. Thanks for Dr. Marwa for this organizing and for Dr. Mishal to allow us to participate in such very nice and organized, well-structured conference, and we, mashallah, happy from the all researcher from their abstracts, and inshallah this opportunity will provide more chance for all researchers in Hail and even the international researcher as well to participate in such conference. And بالتوفيق الجميع.
Thank you all the research committee. I would like to thank you all for this great job. Thank you for all the researcher for your research submitted here. And thank you, Dr. Marwa, for managing all this work. And alhamdulillah, we are now coming at the end. Please join us, Mr. Sultan Saeed is coming now, and we will start announcing the third place, second place, and the first winner. Thank you very much. Thank you for waiting.
Now we will start the announcement of the 3 top ranking of our best researches for today after the presentation of the top 5 presentations. We already have the result of our judgment committee. Are you ready? Are you ready for the results? Hello everyone. Now we would like to announce the third place.
Championship. Okay. From the championship. This is the part from the championship. Not only the research committee, even me and the Bunasser, we have our part. So please, yani, it's a kind of suspense. Yalla, start.
The third place awarded for the best researcher goes for Dr. Sahar. Are you ready now for the announcing the second place? Second? The second place awarded for Dr. Nagla Abdulrahim. We are all excited now to know who is the first one for today, who is awarded as the best researcher in our fourth version of High Lifestyle Medicine Conference. Forgive me, my voice is broken. Now we all honored to announce the first place for our research session and our fourth lifestyle medicine conference. Today, the first award goes to Dr. Said. Congratulations for the best three researches for today. By the way, Dr. Said, mashallah, for the second year, he has the first place awarded in our conference. He is amazing, mashallah. Now we have a special research award. This is special research award. Me and my team in the research committee decide to make this special award for the youngest researcher submit his work to our committee. The youngest researcher, our special for today, Mr. Saleh Zaiza. He is a student in the first year of secondary school. He make a research for lifestyle and he make a good job. And now I would like to let Mr. Sultan Al-Saeed and Dr. Mishal also honoring the best 20 research who join us in our research corner for lifestyle medicine conference of حائل. Let's me mention the name, please. دكتور نجاة التوم، الدكتورة نورين أختر، دكتور عبد الله الناجي. I mention only the name of the author who submit the research, not all the group work of the research. Okay, maybe the Dr. Nagat represent her team in the research. دكتور عبد الله ناجي، دكتور هاجر عوض الشمري، دكتور باسل محمد الرشيدي، دكتور خديجة محمود، دكتور أحمد عبد المنعم إبراهيم، دكتورة مديحة ربيع محمود، دكتورة نجلة عبد الرحيم محمد، مس نيجار نيسار، دكتور زينب أحمد الفرج، دكتورة سمية إبراهيم، دكتورة حليمة مصطفى، دكتور أماني محمد الخليفة، بروفيسور فريدة حبيب خان، دكتور وفاء عمر، Thank you for our colleague today. We would like to thank you so much, and we wish it was a very nice session. Thank you for the next. Inshallah, we will meet you in the next conference in the next year for researchers only. Thank you.
نشكر الأستاذ سلطان مساعيد على حضوره الكريم ودعمه المستمر والذي أضاف للمناسبة قيمة ووقار. أما الآن مع السيشن الأخير إن شاء الله.
We have just heard how lifestyle can change the story before, during, and after surgery.
Now, we're zooming out of the operating room to the whole community, to how lifestyle medicine and public health can work together to prevent chronic diseases.
If your city could adopt just one healthy routine as a community, what do you think would make a biggest difference? Better sleep, more movements, or less sugar?
To lead our final session of the day, we will explore how chronic disease prevention and management align with public health interventions and lifestyle changes. Please welcome our next moderator, Dr. Maher Rashidi, Consultant of Family Medicine, Saudi Ward in Family Medicine. Please welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. This will be our last session for the day. I would like to express my sincere appreciation to the scientific committee and organizing committee for their efforts in this amazing conference. We would like to welcome the first speaker for this session, Dr. Walauddin Mubarak, public health and preventive medicine physician, certified national master trainer by WHO, and John Hopkins Blomberg, certified in project cycle management, MDF, the Netherlands, head of BMO of the population health management, trainer at Saudi Board of Preventive Medicine, Hail Health Cluster. He was talking about lifestyle medicine within the population health management platform, a framework for person-centered chronic disease reversal, the Hail Health Cluster model. Welcome, Dr. Walauddin.
طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله تعالى وبركاته. It's a real honor to be invited to participate in this distinguished conference. I would like to extend my thanks and appreciation to the organizing committee, scientific committee, and every single person behind this huge, well-organized conference. Today, I would like to present lifestyle medicine within the population health management platform, a framework for person-centered chronic disease reversal, the High Health Cluster model. This presentation will reflect the all concepts and all the strategies and policies of lifestyle medicine, which discussed in this conference and other conferences regarding to lifestyle. And our goal is to translate these concepts into real, measurable, and well constructed and operational methods within the health information system. And that's why High Health Cluster designed and developed this platform. The content of this presentation will the introduction about the BHM platform, the BHM, and also we'll discuss a little bit about a person-centered care framework and integration of lifestyle medicine within the BHM platform. Also, we'll talk about risk stratification model, and we choose one of the common cause of death, hypertension and diabetes, as two of chronic diseases in this platform, lifestyle-focused care pathways, and patient engagement. Population health management promote patient-centered care, helping health system meet diverse population needs while managing the growing burden of chronic disease. And we have three pillars in our platform to improve goals, to improve patient outcomes, early diagnosis of at-risk patient, identification of undiagnosed patients, improved lifestyle by weight reduction and reduction in chances of developing chronic conditions, prevention of disease progression, and prevention of acute events from chronic condition. And the second goal is enhanced patient engagement. This is the new goals to engage our patients in their trip of cure. Better patient experience due to regular program interaction, patient awareness and education, higher treatment adherence. And the third one, reduce medical costs by reducing either the patient admission or readmission, also to minimize the staying at hospitals. The scope of this platform work at all BHC centers in Hail region, inside Hail city and outside Hail city, related hospitals, central and specialized hospitals, also related specialized centers like diabetic center. And in this platform, we focusing on two chronic disease pathways, the diabetes mellitus and hypertension. And in the future, other chronic diseases will be added in this platform. And this is the login page of the platform. Every healthcare provider will take his own credentials to log in this platform. after login, this is the main list of beneficiary list. As we see, there is some colors and dots, and this is referred to the risk stratification of each patient. In the other pages, you can see the this is actually the part of the health coach, who is the cornerstone in this platform, and lifestyle modification. And here also he can add the physical activity, and before that, the healthy eating and education request. Then the messages will go as SMS to the patient, and also he can follow up and track the progression of his patient. What's the difference between the health information system in our health facilities and this is new platform? Actually, there is a significant difference between both of them. The regular one supports reactive action, reactive care with diagnosis and treatment after the patient come to the facility, while the BHM platform is proactive, and this is the main difference between them. Focus on efficiency for health information system of hospital follow-up, while the BHM platform emphasizes preventive strategies. The health information system designed to document patient reported, while the BHM features care pathways and follow workflow that aids in chronic disease. The health system is useful for record keeping, billing, managing patient visits, while the BHM platform tracking population indicators, running outreach campaigns, and monitoring a long-term condition. Right now, both of them work on parallel, but in the near future will be integrated together in one screen to make it easier. Person-centered care framework, that means we put our person, not patient, all persons in the center, and the care providers surrounding them in their roles. As we see, the patient in the center, and all other care providers providing the care in coordinating between them, and each one of them has his own role. Care manager, this is the entrance of the BHM platform, who is the nurse making vital signs and physical activity, and while the BHC physician make the medical assessment and make risk stratification and management and monitoring of the medical improvement. The health coach, actually, he's the cornerstone of this lifestyle notification in this platform, who according to risk stratification, areas of needs, goals, and plan setting, sending education SMS by the platform itself, follow-up and monitoring, reassessment plan and notification. Case coordinator make appointments and coordinate the visits and transfers. Why integrating lifestyle medicine into BHM, as we said, to transfer or to shift the care from reactive to proactive, and focusing on the 6 pillars of lifestyle medicine. And we work right now on hypertension and diabetes. Each one we classified in 6 levels of risk, and this is the dashboard of the hypertension, and diabetes also classified into 6 levels of risk, and this is the dashboard of the diabetes. Lifestyle medicine intervention BHM platform, personalized health promotion, medication appointment, goal settings, tracking of lifestyle progression. And this is one outputs of this. Every patient will receive a message from this platform. For example, this is for health education materials. And the lifestyle medicine will help to chronic disease reversal. Also reduce the healthcare cost, as we said. Benefits for providers: he can follow up and monitor his patients. Also, he can use the already made care plans. No need to 1 minute. No need to lose his time to construct a new care plan. Also, there is benefit for provider. He will be integrated with the better care coordination and data-driven monitoring. And the conclusion of this presentation: BHM platform transform care into proactive and person-centered. Higher Health Cluster sets a leading regional benchmark by this platform. And thank you for listening.
Thank you, Dr. Wala, for the highly informative presentation. Our next speaker is Dr. Sharif Gouash, Professor, University of Mustaghanem, Algeria, literature at several universities. He will talk about lifestyle medicine in popular culture, monitoring and treatment. Welcome, Dr. Sharif.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه إلى يوم الدين. نشكر الحضور الكرام، نشكر اللجنة العلمية، نشكر رئيس اللجنة العليا والتنظيمية على إنجاح هذا المؤتمر الذي له دور كبير في دراسة علاقة المجتمع بالصحة. الحقيقة موضوع دراستي موضوع اجتماعي، ليس موضوع صحي أو موضوع تقني علمي. أنا قدمت دراسة أنثروبولوجية، علاقة المجتمع بالصحة. الآن كيف نخرج المؤتمر هذا إلى الشارع، إلى المجتمع، وليس المجتمع إلى داخل المؤتمر. في الحقيقة عنوان الدراسة طب نمط الحياة في الثقافة الشعبية، رصد ومعالجة. هذه الدراسة فيها 80 صفحة. حاولت أن أختزلها في بعض الوريقات وأعطي لكم فقط الملخص والنتائج. بالنسبة للمقدمة، هذه المقدمة أو تمهيد في الحقيقة هي في حد ذاتها ملخص للموضوع. يعالج موضوع الدراسة في رصد أهم التغيرات. أول شيء التغير التي تطرح عليه ثقافة طب نمط الحياة. فيه طب نمط الحياة، فيه ثقافة، فيه اختلاف. وسط المجتمع. ثالثاً المجتمع مع المعالجة لهذه التغيرات وإمكانية معرفة المسببات والآليات التي تتماشى مع تحقيق الأهداف المتوخاة تحقيقها، يعني أهداف المؤتمر أو أهداف المديرية الصحة. وهذا الطرح ينطبق على المجتمعات التي عرفت تطوراً ملحوظاً في السلوك والممارسات اليومية لطب نمط الحياة، وهي مدينة حائل. من أهم المدن العربية والعالمية التي كانت سباقة وبشكل ملحوظ في معايشة الفكرة الطبية لنمط الحياة، كما أصبحت نموذج يحتذى به في السلوك الحضاري من ناحية الطرح وتحقيق المكتسبات في تنظيم الحياة اليومية في مجال الغذاء، الرياضة، واهتمام بالفتوة من ناحية العمر. فتوة يعني الشباب. بالحقيقة هذا هو المخطط لإنجاح الخطة ولإنجاح تحقيق أهداف المؤتمر، يعني محاولة إنجاح المؤتمر داخل المجتمع، لأننا نحن الآن الحاضرون هنا أغلبيتهم من المثقفين، سواء كان ثقافة عربية أو سواء كان ثقافة متعددة المواد إلى غير ذلك، لكن فيه عامة المجتمع في الخارج. هذا الآن كيف نلبي طلب عامة المجتمع اللي هو يمثل 90% من إنجاح أهداف المؤتمر. فيه ثقافة طب نمط الحياة، تطرح الإشكالية ثم نطرح النموذج ثم نحقق الهدف. هذا هو المخطط العالمي يجب عليه أن نتبعه. في الحقيقة الإشكالية ما هو؟ تكمن في طرح التساؤلات الآتية: كيف نجسد الفكرة؟ هذا أول سؤال يطرح على المجتمع. ما هي الفئة المنشودة؟ ليس كل الفئات يطبق عليها طب نمط الحياة. يجب علينا الفئة الأولى، الفئة الثانية، الفئة الثالثة، ثم نخرج بفئة مجتمعية. ما هي آليات تجسيد الفكرة؟ فيه إشكالية مطروحة داخل ثقافة طب نمط الحياة، هو كيف نربط المجتمع أو بالثقافة ثم الثقافة بهذه طب نمط الحياة. آخر نقطة هو رصد الطرق وأهم العوائق، ما أمكن تحقيقه وما لم يستطع أن يتحقق. في الحقيقة أي مشروع صحي يواجه عوائق وصعوبات. ليس من المستحيل أن نحقق مشروع صحي بدون صعوبات. في الحقيقة الصعوبات هي في الحقيقة هي أصلها نجاح. في الحقيقة لتحقيق ثقافة مجتمعية ذو نمط صحي جيد لابد اتباع الخطوات التالية. الخطوة الأولى أن نحدد طبيعة المجتمع. في الحقيقة مجتمع حائل هو المجتمع الذي وجدته تلمسته بأنه يستطيع أن يطبق عليه فكرة طب نمط الحياة. ثانيا خلق فرص التعاون بين أفراد المجتمع ومديرية الصحة، لا نهمش أي فئة داخل المجتمع. نقطة أخرى تركيز على فئة الشباب. الفئة الشباب هي أول فئة يطبق عليها الفكرة. في الحقيقة آخر نقطة وضع برنامج تقني إحصائي. يجب أن نربط ما بين الأدوات الإحصائية التقنية وتحقيق الأهداف. الحقيقة ما هو النموذج اللي اخترته؟ هو متوسط عمر الإنسان كنموذج، والذي هو موضوع المؤتمر. قبل أن نتطرق نطرح سؤال: هل الفكرة التي طرحها مديرية الصحة أو وزارة الصحة السعودية عمر الإنسان هل طرح جديد أم قديم؟ قبل أن نتطرق، المعالجة هذه كانت فكرة كيف نعالج عمر الإنسان كانت مطروحة منذ المجتمعات القديمة. في الحقيقة نجد متوسط عمر الإنسان عند الإغريق والرومان وفي العصر الحديث. من الملفت أن النظر أن العمر الإنسان في الفترة القديمة عند الإغريق والرومان والشعوب شبه الجزيرة العربية كان مستقرا، وهذا دليل من الأبحاث الذي أثبته مونتاغو وبالنسبة للباحث كذلك باترينوس. في الحقيقة عمر الإنسان في الحضارة الإسلامية كان ما بين 69 إلى 75 عام. ما هي الطرق التي طبقها المسلمون أو الأطباء المسلمون في حضارتنا السابقة لتحقيق وإنجاح هذا النموذج؟ هو التزامهم بالتعاليم الإسلامية التي تنص على الصحة الجيدة والنظافة، كما اهتم المسلمون بقاعدة رعاية المسنين وعدم مشقتهم مع تفضيل مناولة الغذاء الصحي الذي لا يؤثر مباشرة على صحتهم، مع تجنب الإفراط في تناول الإطعام وممارسة الصحة لكبار السن. القاعدة عند المسلمين هو أن عمر الإنسان يصل إلى 70-80 عاما. دقيقة فقط. ارتكز على منظومة متكاملة بين الإجراءات الصحية ودور المجتمع وتفاعل مؤسسات الدولة مثل المؤسسة التعليمية التي لعبت دور كبير. في الحقيقة هنا نركز على المؤسسة التعليمية، المؤسسة المدارس الابتدائية والمتوسط والثانوي والجامعة، هي أول مؤسسة مستهدفة لتحقيق هذا البرنامج. في الحقيقة فيه كثير من ما أتكلم عليه، فقط أعطيكم بعض انتقلت من الفترة الحضارة الإسلامية إلى أهم ما يسمى بما هي أهم المواقع الذكاء الاصطناعي في تحقيق هذا البرنامج. أول موقع تطبيق هيلث، هذا يعرف بالصحة المحمولة. تطبيق فوديكايت، تطبيق تغذية جيد، يعني يضم 250 نوع من الأطعمة الصحية، هذا موجود عندكم، طلعوه موجود على الهواتف. تطبيق هوم وركوت، تطبيق تدريب والتمارين الرياضية. تطبيق لايف سوم، تطبيق يجمع ما بين النظام الغذائي وممارسة الرياضة. تطبيق سلامة، يساعد على تحليل البيانات الصحية ويقدم إرشادات صحية. تطبيق أورا هو تطبيق يعمل على تحليل نمط النوم وتوفير إرشادات لتحسين جودة النوم. ما هي أهم النتائج؟ أول شيء نؤكد على حائل أصبحت نموذج سعودي عربي عالمي في طب نمط الحياة الصحية الجيدة. ثانياً ضرورة الاستفادة من خبرة السابقين في مجال كيفية بناء مجتمع ذو نمط صحي. آخر نقطة ضرورة اتباع قاعدة إشراك كافة الفواعل الاجتماعية بين اتخاذ القرارات. وآخر نقطة اتباع الأساليب والحلول المبتكرة الحديثة في طب نمط الحياة من خلال توظيف خدمات تطبيقات الذكاء الاصطناعي. شكرا والسلام عليكم ورحمة الله تعالى وبركاته.
Thank you, Dr. Sharif. We will move to the next speaker is virtually. Dr. Melissa Berniston is an associated professor and chair of the Department of Nutritional at Rosalind Franklin University of Medicine. She's passionate about education, students, and healthcare professionals on the importance of the food as medicine for improving health outcome and quality of life, for which she was recognized as one of today dietitian, top 10 dietitian making a difference in 2025. Welcome, Doctora. Welcome, Doctora. Doctora, can you hear us? We cannot hear you, Doctora. Melissa? We cannot hear you. Dr. Melissa, we still cannot hear you.
Once more, doctor. Can you hear me, doctor?
I can hear you, yes.
Yes, continue, doctor.
Yes, I can hear. Could you hear me?
Yes, we can hear you, Doctora. Welcome.
Oh, that's so nice. Okay, should we begin?
You can start, Doctora.
Okay, thank you. Good afternoon. It is my honor to be joining you all again for the 4th Annual Lifestyle Medicine Conference. My name is Melissa Bernstein, and I am Associate Professor and Chair of the Nutrition Program at Rosalind Franklin University of Medicine Science and Chicago Medical School. And today I've been asked to talk about protein recommendations and considerations from older adults. And I receive royalties from the sale of nutrition-related textbooks. So let's get right into it. This is an important topic because people worldwide are living longer, and by 2030, 1 in 6 people in the world will be age 60 years or over. By 2050, the world's population over age 60 will reach 22% or 2.1 billion. And the number of persons age 80 and older, the oldest old, is expected to triple between 2020 and 2050 and reach 426 million people. And with longer life brings opportunities not only for older people, but their families, their communities, and our societies as a whole. And we want people not just to live longer, but live healthier and increase and improve their health span, maintaining healthy behaviors throughout life, particularly eating a balanced diet and engaging in regular physical activity and refraining from risky behaviors such as tobacco. All of these contribute to reducing the risk of chronic disease and improving physical and mental capacity and delaying dependency. And at the biologic level, aging results from the impact of the accumulation of a wide variety of molecular and cellular damage over time. This leads to a gradual decrease in physical and mental capacities and a growing risk for disease and then ultimately death. And these changes are neither linear nor consistent, and they are only really loosely associated with chronological age. Aging also brings about physiologic changes that affect our protein metabolism and our protein requirements. We have a progressive decline in basal metabolic rate of about 1 to 2% per decade. And this is due primarily to low levels of physical activity, which contributes to a lower caloric requirement and a progressive loss of lean mass and increase in fat mass. And this is directly relevant to our discussion about protein because nearly half of all the protein in the body is found in muscle, and this declines with age. So in young adults, lean mass could be up to 50% of total body weight, where in older adults, lean mass declines to about 25% of total body weight at about age 75 to 80 years old. And there are also changes in protein metabolism that occur with age. Older adults they exhibit anabolic resistance and reduced muscle protein synthesis, meaning that their muscles don't respond as robustly to protein intake and to the anabolic stimulus. And they also have increased protein turnover, and this could be from inflammation as well as illness. And so to illustrate these changes in body composition, what you see here on this slide is a cross-section of the thigh from a younger woman as compared to an older woman of the same body weight. And you can see the tremendous increase in subcutaneous fat as well as the intramuscular fat, and markedly that decrease in the amount of muscle protein as well as the integrity of the protein. And so therefore, the goals for healthy aging are preserving that lean muscle mass, strength, and function, the prevention of sarcopenic obesity, frailty, and the functional declines that are commonly accepted to be normal consequences of aging. And we know that these conditions can be improved with lifestyle interventions, primarily nutrition and exercise. And I recently read a quote that says, aging is not a diagnosis, it's a process that we can actually influence. And so the goal with aging is to really maintain that quality of life, independence, and health. So this slide here just illustrates in very simple terms, that vicious cycle of poor diet and disease burden and loss of functional independence that commonly occurs with older adults, where we have poor diet, which leads to inadequate energy and nutrient intake. And then this has both physical and metabolic consequences that further impact physical health and functional status, and then feeds back on the ability to consume a high quality diet. So in addition, there's also a number of other factors that influence specifically protein requirements in older adults, such as other metabolic demands and medical conditions, the type and the level of physical activity that the older adult may be involved in.
5 minutes
protein
left.
and amino acid.
5 minutes.
Yes? Should I continue?
Yeah, continue. 5 minutes left.
Oh, okay. Protein and amino acid metabolism are also affected by overall dietary intake, and the appropriate anabolic use of dietary protein can occur when all other energy and nutrient requirements are being met, such as the distribution and quality of protein intake and other nutrients, energy balance, and the dietary adequacy of other macro and micronutrients. And so protein recommendations, which have been traditionally based on studies that estimate the minimum amount of protein needed to maintain muscle mass, are determined by nitrogen balance. However, there's concern that the current recommendations really fail to adequately consider protein metabolism and physiology that occurs with aging, the anabolic resistance, the increased protein turnover, and that these recommendations don't consider physiologically meaningful endpoints such as measures of muscle protein, strength, and function that are relevant in healthy aging. So then this begs the question, what are the protein requirements for older adults, and are they high enough to support healthy aging? So for many older adults, evidence suggests that a dietary protein intake of at least 1 to 1.2 grams per kilogram per day is required in healthy aging populations. And intakes of 1.2 to even 1.5 grams a day are necessary for those with chronic or acute illness. And these protein intake recommendations can actually even increase to 2 grams per kilogram per day in more severe cases of illness, malnutrition, and chronic conditions. And evidence also suggests that a balanced protein distribution of 25 to 30 grams of protein, of dietary protein per meal from animal and plant protein sources alike are sufficient to maximize muscle protein synthesis rates in older adults. And protein quality is another key determinant of potential dietary protein to meet needs and promote skeletal muscle anabolism. And there are a number of potential benefits to a higher protein intake in older adults, such as improved muscle health and function, the prevention of sarcopenia and frailty, helping to maintain energy balance and weight management, improve bone density and prevent falls, enhance immune function and improve wound healing, and prevent the onset of chronic diseases and promote recovery from illnesses and injuries, as well as lower mortality, improve quality of life, and promotion of longevity. And so therefore, when we consider ways to increase dietary sources of protein, one area to focus on to boost the protein and improve overall dietary quality is to higher consumption of a variety of plant-rich foods. And it's likely that most older adults are going to have a health condition that will benefit from a plant-forward diet. Heart disease, dementia, obesity, diabetes, inflammatory conditions such as arthritis, as well as constipation. So therefore, recommending the recommendation to add more minimally processed plant-based sources of protein really also goes beyond protein and muscle, but can improve nutrient that many adults could be low in, such as fiber and antioxidants, and improve overall dietary quality and then the related health outcomes. Studies have found that plant protein can have a significant effect on longevity, and that intake of plant protein is associated with lower risk of mortality from all causes, where an additional 3% increase in energy from plant proteins a day is associated with a 5% lower risk of death from all causes. And we see this association in dietary pattern and longevity illustrated in the blue zones, the 5 places where people around the world consistently live to over 100, and many individuals live well into their 90s without chronic disease. And among other important lifestyle behaviors, their diet of those living in the blue zones is almost 95% plant-based, including a large amount of local and minimally processed foods. And while there are a number of shared common lifestyle behaviors that contribute to healthy aging, the dietary pattern of those livings in the blue zones is overwhelmingly whole food plant-based. There's a common myth that people need to eat animal protein to meet their protein needs. And it's important to remember when guiding older adults to meet their higher protein needs that plant foods such as beans, legumes, nuts, whole grains provide a valuable source of protein as well as fiber and other essential nutrients that are not found in animal products. And eating more minimally processed whole plant foods, beans, lentils, nuts, whole grains, provide protein that comes packaged along with the fiber, the antioxidants, vitamins, minerals, without the cholesterol and saturated fat that accompany animal foods, and the added sodiums and sugars that come in highly processed foods. There are a number of nutrients of public concern that are important to consider in the older adults: calcium, vitamin D, potassium, and dietary Many of these can be improved by eating a plant-based dietary pattern. However, vitamin B12 is a concern for many older adults because of the ability to absorb this nutrient decreases with age, and that's due to atrophic intrinsic factor, and the use of certain medications can also lead to its decreased absorption. So many older adults, especially those who eat a plant-predominant diet, will likely require vitamin B12 supplementation. So again, a few key takeaway points for the goal of nutrition health in adults of any age should be to preserve physical and mental well-being, maintain a high quality of life across that continuum of the aging process. And sarcopenia and loss of independence doesn't have to be a natural consequence of aging. Good nutrition and regular physical activity,
Thank you,
as you
Dr.
heard from
Melissa.
Dr. Mock,
The time is
especially
over.
resistance training in muscle mass, strength, and function in older adults. Thank you.
Thank you, Dr. Melissa, for highly informative presentation. I would like to invite our speakers to panel discussion. Dr. Wala, Dr. Sharif. Thank you, doctors. It was an engaging and beneficial presentation. The first question is for Dr. Walauddin. How can embedding lifestyle medicine protocol into BHM platform transform clinical practice from reactive to proactive approach?
Well, thank you for this nice question. Actually, this question will summarize our lecture, presentation. Since BHM platform is working as proactive, not like exist other softwares which work on reactive when the patient is come. That means the BHM platform work in risk stratification. It is the cornerstone of this platform. It uses the all data-driven available data in other platforms to analyze them, to stratify the population and patients into risk groups. Then the intervention will be proactive. There's no need to wait until patient come to the BHC or to hospital with late complications of diabetes, for example. Since the patient transfer from a level of risk to another level, either going up or going down, there is a notification for the health care provider will receive. Also, the patient will receive this notification to start in the next step of care plan. For example, to explain this, if we have a patient of, for example, X from people, patient, 55 years old, smoker, with family history of diabetes, BMI is 32, but the hemoglobin A1C is 5.5. Usually, we never consider this patient need any medical intervention. This is in the normal situation. But while in the platform situation, this patient will be stratified in the level 1 as risk of diabetes, and we will start the intervention immediately. This is the case in this BHM platform, not just normal person. No, this is the case because if we let him to live his life as before, definitely he will develop pre-diabetes and then will develop as diabetes. So proactive intervention of this platform is the significant difference between the exist or ordinary other platforms.
Thank you, Doctor. The next question is for Dr. Sharif in Arabic. كيف يمكننا أن نحقق تفاعل كبير لعامة المجتمع مع فكرة طب نمط الحياة؟
شكرا على هذا السؤال. في الحقيقة السؤال هذا هو جوهر الموضوع الذي طرحته. كيف أن ندمج المجتمع في ثقافة طب نمط الحياة. هذا في الحقيقة طرحته العام الماضي وما زلت أطرحه لهذه السنة. فيه عدة آليات، فيه عدة ميكانيزمات نريد أن ندمج بها المجتمع. أول شيء أننا نشرك فئة الشباب. هذه فئة الشباب التي تتراوح ما بين 15 سنة أو أقل إلى 25 سنة أو 30 سنة. هذه الفئة يجب علينا أن نترك لها المجال كيف تندمج عن طريق إنشاء مثلا المؤسسات الصغيرة والمتوسطة، مثلا مؤسسة مختصة في الغذاء، مؤسسة مختصة في الرياضة، مؤسسة مختصة في ربط العلاقات ما بين المجتمع. وهكذا نجد بأن الفئة 75% من المجتمع السعودي هو فئة شباب، وكل المجتمع العربي هو فئة شباب كذلك. نجد بأن هذه فئة الشباب هي تساعدنا على إنجاح الأهداف طب نمط الحياة. وإن شاء الله المسيرة متواصلة، وإن شاء الله تبقى حائل مدينة طب نمط الحياة بكل امتياز. شكرا والسلام عليكم.
شكرا دكتور شريف. دكتورة ميليسا, there is no question for you. Thank you for joining for us today.
Thank you.
Thank you. In the end, we would like to again thank the organizing committee and the scientific committee for this amazing conference. Thank you.
At this time, we would like to invite all our distinguished speakers and session moderator to stay on stage so that we may recognize and honor their valuable contributions. Thank you all for your presence and engagement throughout the sessions of Day 3. Today added another meaningful layer to our understanding of prevention, innovation, longevity, nutrition, and the science behind healthier living. Your questions, your reflections, and your energy brought life to every session. And remember, our journey is not over. Tomorrow and the day after, we begin the workshop phase, 2 days of hands-on learning, practical skill building, and real application of everything we've explored together. We look forward to seeing you tomorrow as we open the first day of workshop. Thank you all and have a good day.